morning, everyone. Welcome. Thanks a lot, Sam. Okay, so we will start today's conference with a prayer from Dr. Bukal, who is well known to me, a fellow family medicine resident. Over to you, Dr. Bukal.
Thank you, Dr. African. And good morning, everybody. May we commence in prayer. Father, we thank you. We thank you for waking us up this morning. We thank you for the privilege of being doctors. Lord, remember our colleagues who work in war-torn circumstances, who work in famine. We ask that you grant them wisdom, that you grant them grace, that you grant them strength to continue. And Lord, remember our colleagues who have passed because of the affliction of this pandemic. We ask, Lord, that you comfort their families. And Father, we present today's activities into your hands, and we ask for success. Lord, your word says if we commit our plans to you, you will grant us success, and we ask for that even now. And we pray that this date, World Family Doctor Day, how we commemorate it, will be truly inspiring to those who attend this conference. In your son's name we pray. Amen. And on behalf, as Dr. Ricken says, I am a family medicine resident, and on behalf of our program director, Dr. Standard Wilson, who unfortunately is not here with us today, we bring you greetings. Thank you.
All right, thanks a lot, Dr. Bukal. Dr. Gordon, good morning to you, and we're looking forward to your greetings to us today. Go right ahead.
Good morning, Sophie. Good morning. Are you guys hearing me?
I'm hearing a bit of music. Not sure if Sam can help. Okay.
Hello, good morning.
We're hearing you, Dr. Gordon, hearing you well.
Okay, thank you, Sophie. Good morning to the panelists. Good morning to all the members who are tuning here today. Good morning to the organizing committee. I am Dr. Gordon, and I'm pleased to bring greetings from the association on behalf of the membership and fellow board members to the audience here today. The association and its members are pleased to work with the World Family Day Doctor Planning Committee, who have done a tremendous job in putting together such a wonderful program today. Today's program is indeed a wide-ranging one, which covers numerous aspects of COVID-19, which I'm sure will be highly beneficial to our membership. The association applauds the tireless efforts of the membership and the planning committee of the WFDD, who continue to take the celebration of World Family Doctor Day to a higher level each year. The World Family Day Doctor Day Planning Committee can look towards the continuing support of the association in its yearly endeavor to showcase the work of the family doctors in caring for the family. And we wish you all a very highly successful program today. And back over to you, Dr. Abrikian.
Okay, thanks a lot, Donald. Yes, we look forward to that too. And I'm going to welcome Dr. Onanuju, the president of the CCFP Jamaica chapter. And I should have said, sorry, Dr. Gordon, that of course you are the president of the Association of General Practitioners of Jamaica. Thank you again. So welcome, Dr. Onanuju. We'll await your welcome as well. Thank you.
Good morning, everyone. To our specially invited guests, esteemed colleagues, our host, IT support personnel, Mr. Samuel Heron, administrative team headed by Mrs. Lynn Thompson Hyatt, our sponsors, friends, ladies and gentlemen, a pleasant good morning. I am Dr. Seni Ononoju, the current president and chair of the Caribbean College of Family Physicians, Jamaican chapter. It is indeed my pleasure and honor to once again welcome you to another World Family Doctor Day event. World Family Doctor Day 2022. What is World Family Doctor Day? World Family Doctor Day was first declared by Wonka in 2010, and it has become a day to highlight the role and contribution of family doctors and primary healthcare team in healthcare system around the world. This celebration is the perfect opportunity to acknowledge the central role of family doctors in the delivery of personal, comprehensive, and continuing healthcare for all patients. It's also a chance to celebrate the progress being made in family medicine and the special contributions of primary health care teams. In Jamaica, the Caribbean College of Family Physicians, Association of General Practitioners of Jamaica, and the postgraduate family medicine students have been celebrating the World Family Doctor Day for the past 9 years annually. These three groups proudly collaborate to celebrate this day today, May 15, 2022, usually acknowledged annually on May 19th. We are now thrilled to announce this year's theme, Let's Work Together to Combat Chronic Diseases in COVID Era. In the face of the ongoing pandemic, family doctors have been confronted with a multitude of challenges, and they have risen to the challenges and responsibilities placed before them by shifting negative mindset to positive mindset, sharing of ideas between doctors locally, regionally, and internationally, bonding together to ensure that patient care is optimal as unity is strength. Hence the theme, Let's Work Together to Combat Chronic Diseases in the COVID Era. Although there have been spikes in COVID-19 spread, related deaths, and the emergence of new variants, we are being consoled by statistics which show that there is a slight reduction in its spread. Despite this reduction, I implore of all my colleagues that we continue to give good examples to the broader society by continuing to encourage them to practice proper personal hygiene and adherence to all protocols recommended by Ministry of Health and Wellness. In short, endeavor to ensure that patients' physical, mental, emotional, and psychological state is optimally maintained. To our neighbors further afield, we continue to hope that a peaceful resolve can be found to the ever-deepening Russia-Ukraine conflict, and that lives will be spared during this geopolitical upheaval. As such, we have a lineup of exceptional speakers drawn from across the vast medical landscape. Speakers who not only bring sound theoretical knowledge backed by sound scientific principles, but also practical knowledge garnered throughout their years as practicing and consultant physicians, as they have sought to ply their trade as doctors within our island Jamaica. I feel confident that we will certainly be well informed and enriched by their presentations, and they share with us their time, talent, and expertise. We welcome each and every one of them wholeheartedly. We also welcome all our distinguished colleagues, our sponsors, our hosts, and IT and administrative support team, friends, all attendees, and all those who helped in making this morning's webinar a reality. A special welcome to all our members who continue to support us. On behalf of the college, I thank and welcome you all for your support throughout the years, and invite you to sit back and enjoy the presentations. God bless, and I thank you.
Thanks a lot, Dr. Ononuju, and the topics are indeed timely, at this time. I'm going to go ahead and introduce our first speaker, Dr. Mark Hosang, who's really well known to many of us here. He's a cardiologist who has trained at University of the West Indies in Mona campus, as well as in Canada. And, he's a consultant at University Hospital, as well as he works in private practice. And he's, of course, involved in teaching undergrad students and postgrad. students as well. I myself have been taught by him, of course. So he's going to talk to us today about heart disease, related heart diseases, rather related to COVID-19 infection. Over to you, Dr. Hosang. I look forward to your talk. Thank you.
Hi, Sophie. Thank you very much for the intro. Thanks to the organizers for inviting me to participate in this conference. So today, let me just get my slides up. Okay. All right. Hope everybody's able to see my slides. Yeah?
Yes, we're seeing them.
Okay, folks. Good. All right. So today I'm going to be talking about heart disease related to COVID-19. And there are a number of things that I'm going to go through. Some of the things that I researched from the international evidence and some from my personal experience here in Jamaica. Okay, so as we all know, just to give a bit of a background, we've been in this COVID-19 pandemic for about 2 years now, over 2 years now, where the first case was discovered in Wuhan in December of 2019, hence the name of the virus. And since then, about 521 million cases have been confirmed worldwide, even though the number may be much higher than that, with about with over 6 million deaths worldwide, and 132,000 cases confirmed in Jamaica, with almost 3,000 deaths being as a result of that. So it's no small problem, and it's a global problem, and nobody is untouched, including us here in Jamaica. So there's quite a bit of an association with multiple different aspects of heart disease with COVID-19. And it's seen that about a quarter of the hospitalized patients are thought to have cardiovascular complications. And for those patients who demise because of their COVID-19, it is estimated that about 40% of those deaths, heart disease has been a contributing factor. There are a number of ways in which heart disease may be seen in COVID-19, and the possible manifestations include things such as myocardial infarction, myocarditis, stress cardiomyopathy, also known as Takotsubo's, heart failure, as well as arrhythmias. So most of us are familiar with myocardial infarction, usually a classic presentation of chest pain, with ECG abnormalities and elevation of cardiac biomarkers. There's a strong association with COVID-19 in patients, COVID-19 and myocardial infarction. And there's data from the Chinese Center for Disease Control, as you know, that's where it occurred firstly. And it's seen that up to 4.2% of patients who come in who are admitted for COVID-19 or who are diagnosed with COVID-19, according to their statistics, about 4.2% of these patients had coronary artery disease. But a significant number more than that were involved with the fatal cases. So clearly there's an association and a worsening of mortality if they have a history of coronary artery disease. Almost 23% of the fatal cases has involvement. It's also associated with the risk factors for coronary artery disease, the main ones being diabetes and hypertension. And it's seen also, according to that registry data, it showed that there was 16% of the patients with severe versus almost 6% for the non-severe cases. There was a relationship with diabetes and hypertension, 23 versus 13% of the patients. And these are patients who were admitted. So clearly, there is an association between the severity of disease as well with the risk factors for coronary artery disease. There was a second study also from China using a smaller number of patients, 187 COVID-19 patients who were admitted consecutively to one institution, where they measured the troponin, and it was noted that there was an elevated troponin in 28% of these patients. And there was an impact on the mortality where there was 69% the mortality was 69% in those patients with a pre-existing history of cardiovascular disease and elevated troponin versus 7.6% for those patients who had neither of those risk factors. So just to remind you, troponin is one of those things that we use to determine whether there's myocardial damage and is used as a critical part of making a diagnosis of a myocardial infarction in patients. However, understanding that an elevated troponin is not the be-all and end-all of diagnosis for myocardial infarction. Also from the data, it's shown that there is an increased risk of myocardial infarction versus in COVID patients versus non-COVID patients. A small percentage, 0.03% versus 0.01% in terms of age-matched controls. And in patients, there are much lower number of patients presenting with myocardial infarctions with COVID-19. The data shows data from studies done in the northern part of California as well as Italy and London. There was a reduction in the number of patients who presented with myocardial infarction in the early stages of the pandemic. And these studies were done between the months of February and March of 2020. So we think back, that's when the virus landed on most countries. And there was a significant drop up to 50% in certain places. Of course, it varied by region, but up to between 40 to 50% fall in the number of patients presented with myocardial infarction, which we also saw here, as there was a significant drop in patients presenting to the hospital for all reasons at around that time. And we'll speak a little bit more about that a little later on. What's also noted is that the patients who did present also had a more advanced stage. So they presented a lot sicker. A lot of them came in with heart failure as well. And a few of them have demise as a result of that. And thinking on that now, because of the delayed presentations for people who have had myocardial infarctions that have completed, in the future, we may be having more presentations for heart failure. I mean, being only 2 years into it, we're not seeing that as much yet, but going forward, I think that it's something that we may expect to see. I spoke earlier about raised troponin in its use in the diagnosis of myocardial infarction. And it's important that we realize what the utility of a troponin is. And just because your troponin is raised does not mean that you have a myocardial infarction. There are cardiac reasons for having an elevated troponin. The most common one that we think of includes things like a myocardial infarction, but other things such as myocarditis or myopericarditis, sometimes demand ischemia from arrhythmias, tachyarrhythmias, bradyarrhythmias may also cause it. But it may also be caused by non-coronary ischemia, and in patients with COVID-19, where many of them are significantly hypoxemic. In fact, COVID-19 is probably the only condition that I've ever seen where someone could present with an oxygen saturation of 85% and be completely comfortable, which is one of the things that struck me earlier on, and almost shockingly so, to see them sitting down having a conversation with you, and you put on the oxygen saturation probe and it's 85%, which I've never seen in any other condition. So you get a lot of non-coronary ischemia. If you have hypotension, a lot of these patients may be hypotensive, may present in shock, which will also reduce the coronary blood flow. So that will also raise your troponin. And then you can have myocardial injury when there is absolutely no ischemia at all. So these patients, things like sepsis, so infections like COVID-19, which is thought to be due to cytokine release, such as interleukins and tumor necrosis factor may be contributors, it's theorized, but also things such as pulmonary embolism may result in myocardial injury. And as we know, pulmonary embolism and DVT is not uncommon because those patients with COVID-19 have an increased risk of thrombosis because they become hypercoagulable, again, usually during the period of cytokine storm. So a raised troponin, just because it's seen in COVID-19 patients, does not necessarily equate to a myocardial infarction and doesn't necessarily mean that it is the virus itself that led to the raise in the troponin, because there are many other associated features. Here, again, is a marker of myocardial damage. Usually, we don't just use one troponin. We'll repeat the troponins usually a few hours apart. And the reason for that is that it is dependent and has to be taken in context to the presentation of the patient and the onset of symptoms, because we would normally expect an increase in your troponin after about 3 to 12 hours. Most of them will have an elevation after 6 hours and peak after about 1 to 2 days. And it remains elevated for up to 2 weeks. So it has to be taken in context when the patient presents, because that will determine what pattern you would expect to see. Because if a patient presents within 24 hours, you would expect the second troponin to be significantly elevated compared to the first. Whereas if you were to do this after 2 days of the patient presenting with their symptoms, then your troponin may not show any significant rise, but yet the patient may have still had a myocardial event. So keeping an interpretation of a troponin has to be kept in context with the history. And again, it always goes back to the history and clinical presentation, because as I always say to my students, that we treat patients, we don't treat results. So every result that you have has to be taken in context with the story. While we're on the topic of troponins and elevated troponin, the other differential diagnosis that we would have to consider is that of myocarditis, which essentially is an inflammation of heart muscle. And most cases of myocarditis are due to viral infection. And when this happens, it can lead to clinical features of suggestive or very similar to myocardial infarction, or they may present in heart failure as a result of ventricular dysfunction. Because many of these patients also present with chest pain, similar to that of myocardial infarction, with diaphoresis and shortness of breath, and of course may present in heart failure as well, similar to myocardial infarction. The diagnosis of myocarditis is usually made or by using an ECG, where features can be very similar to myocardial infarction with T-wave inversions and ST elevation. However, the temporal sequence of the ECG changes tends to be a little bit different. Again, troponin can be elevated, but more definitive investigations to determine myocarditis would require cardiac magnetic resonance imaging or cardiac MRI. And the gold standard of diagnosis would be that of endomyocardial biopsy, showing evidence of inflammation, necrosis, and fibrosis, as well as demonstration of actual viral particles within the cells. An echocardiogram is also useful, but more to rule out other causes of the patient's heart failure or their chest pain. On the right-hand side, you'll see, on the top right, you'll see cardiac MRI, just to give you an idea as to what it might look like. And the arrows are pointing to areas of edema seen within the myocardial cells. And the picture before gives an idea of how we might go about conducting an endomyocardial biopsy. However, we don't often biopsy patients because there's a risk of that. And the main risk, of course, is damage to nearby vessels when you're going through the neck, or perforation of the actual myocardium, which of course may be fatal after having cardiac tamponade, etc. So many cases of myocarditis are made because of clinical suspicion, and only a few cases are confirmed histologically for the reasons mentioned. There was a study done in Germany in April of 2020, a series of 39 autopsy cases, where SARS-CoV-2 was documented in 62% of these patients, which was, I believe it was about, 62% of the patients. And they were able to demonstrate evidence of the virus particles in the actual cells in about 16 out of 39 patients. However, when they checked for evidence of inflammation and inflammatory infiltrates, and they compared it to the other patients also within the same autopsy series, there was no difference in the amount of inflammatory infiltrates versus those who had demonstrable virus versus those who did not. So even though there was evidence of viral infection of the myocardial cells, it wasn't very clear and not demonstrated that the actual virus causes myocarditis in these patients. Also on the topic of myocarditis, we also have to think about it, not just from a perspective of COVID-19 causing it, but also those due to vaccination. In fact, many people who are resistant to vaccination, I don't really like to call them anti-vaxxers, because many people are actually not completely against vaccination. And I think we have to be very mindful of that and how we interact with patients who are slightly resistant to being vaccinated. But there is a risk of myocarditis post-vaccination. There are a number of different studies. I've just chosen two here. One was from an Israeli database, and as we know that because of the government and social situation of Israel, their vaccination rate was quite high. And their predominant vaccine that they used was a Pfizer vaccine, and they were able to demonstrate that there was about a 2.1 per 100,000 patients who received at least one dose of the Pfizer vaccine developed myocarditis post-vaccination. Most of the cases were mild to moderate, very few were severe, and it was noted that most of the patients were at a higher risk were male, young males between the ages of 16 and 29 years of age. So those guys were at slightly higher risk. CDC was able to publish their own data as well. Their numbers were a little bit lower, of 0.48 per 100,000. And this number, however, went up for candidates who, again, were young between the ages of 18 to 29 years of age. So clearly younger patients and being male did put you at a slightly increased risk of having myocarditis, but most cases were mild. So there were very few deaths as a result of this, if any at all. The other thing that we have to think about is that of heart failure. So things like myocardial infarction, myocarditis can lead to heart failure, but there may also be patients who have pre-existing heart failure who do acquire the COVID-19 infection. There was a study done in New York in 2020 using 6,400 plus patients. And these patients had a history of heart failure, and they were able to demonstrate from the study that these patients, when infected with COVID-19, they tend to stay longer. They also tended to require mechanical ventilation more than the average population, and they also had an increased mortality as a result of that. There have been other retrospective studies also done in New York, where they noted that 0.6%, so less than 1% of the COVID-19 admissions had developed heart failure, and 22% of those patients had no risk factors prior to. So they weren't known to have heart failure. They never had any of the traditional risk factors, coronary artery disease, hypertension, etc. It's also important to note that, because usually when we think about heart failure, we think about left heart failure, but you can also have predominantly right heart failure, especially in patients who develop pulmonary embolism, what we call cor pulmonale. So again, as I mentioned before, these patients have an increased risk of thrombosis, so they develop DVT. And if you have a significant enough pulmonary embolism that results from that, you can get right heart failure as a consequence. Arrhythmias are also not uncommon in patients with COVID-19. The ones that we worry about more are atrial fibrillation. There was a meta-analysis done using 19 studies where they were able to demonstrate atrial fibrillation in about 11% of the patients. And this was done using Holter monitoring for the patients who were admitted over, I think it was about a 2 to 3 day period where they had to keep on a cardiac monitor. And that's where they were picked up. So it was not just from a simple ECG, but they actually monitored these patients over a number of days. And it was also noted that the patients who were more likely to have atrial fibrillation also had a more severe disease. So 90% of the severe cases versus 3% of non-severe admissions with COVID-19. Atrial fibrillation is not just a benign finding. It's not just a thing of very little consequence, but when it is seen in patients with COVID-19, it also results in an increase in all-cause mortality, as determined by a New York study, which used almost over 9,500 patients. And the difference in mortality was at a 54 versus 37% in the patients with atrial fibrillation. So there was a significant increase in mortality when atrial fibrillation was seen. And it was also noted that patients who had new atrial fibrillation, which was picked up for the very first time on their admission, happened to do worse than those patients who had a history of atrial fibrillation, 55 versus 47% mortality rate. There was also studies from China, from the Hubei province. I'm not sure if I'm pronouncing it right, but that's where Wuhan is. And what they did is based on their records, they were able to state that 7.3% of these patients had palpitations at the time of presentation. There wasn't necessarily any other supportive data in terms of ECG or Holter monitoring or any other ambulatory monitoring after that to say any other incidents of the arrhythmias, but they did document a number of patients had palpitations, and 7.3% is not a small number when you're thinking about millions of people. And even in our own local experience, a lot of patients do have palpitations, and even post-COVID infection palpitations are not uncommon. In a New York cohort, they noticed a prolongation of the QT interval of greater than 500 milliseconds in 6% of patients who were admitted for COVID-19. But this was not seen as much in other studies. There was another study done where the QT interval was only 435. So just to have you guys understand the significance of the QT interval is that patients who have a prolonged QT interval, and usually we'll use like 440 milliseconds as a cutoff, there's an increased risk of ventricular tachycardias, which can be potentially fatal. So a QT interval of 500 milliseconds does significantly increase your risk of having ventricular tachycardia. And the results are not consistent between the different cohorts. And we also have to remember that these studies were done early 2020. And in early 2020, there was a great push by many people, including the President of the United States, for the use of hydroxychloroquine as a part of the treatment for COVID-19, a treatment that has since then been proven not to be effective in altering their course. But hydroxychloroquine is also known to elevate your QT interval. In fact, early on in the pandemic, I think we did have a patient who was on hydroxychloroquine at the University Hospital and had been doing well and was nearing a time for discharge when they got up to go to bathe, and they collapsed on the floor and they subsequently died. I mean, we have no evidence as to exactly why they died, but one of the suspicions is that they may have had an arrhythmic cause for their death, possibly due to a long QT syndrome. Of course, no way of proving it, but it's something that we have to consider and to also understand that and to be careful how we institute therapy for diseases without proper evidence. Also, just to note that there were also evidence of ventricular tachycardias and ventricular premature complexes or ventricular topics seen at another center in the US, a small study of 143 patients where 15% had non-sustained VT, but a number of them had significant amounts of ventricular extrasystoles. As I had alluded to earlier, even after recovery from COVID-19, there's a study done in Wuhan, which was published in December of 2021, where they used 289 consecutive patients, and they noted that these patients, 8.3% of them had palpitations at rest after recovery, and with Holter monitoring, they found tachycardia in 82% of them. And the vast majority of these were sinus tachycardia. So an inappropriate sinus tachycardia because your heart rate shouldn't really be above 100 when you're relaxed and at rest. And it's also noted that there was a significant amount of anxiety and depression. It was quite prevalent amongst these patients of 68 and 59% respectively. There's a suggestion that the emotional or psychiatric component factors may have an impact on those patients who are complaining of palpitations. It is not uncommon for patients with anxiety and depression to have palpitations. So that is one thing to consider. The other thing to consider in these patients who have resting tachycardia is dysautonomia, because A part of the long COVID syndrome is actually, so one part of it happens to do with the pulmonary complications, but there are also involvements of the nerves. And a lot of these patients may develop what's called POTS, or Postural Orthostatic Tachycardia syndrome. And this is seen where they get tachycardia just on standing. And this is not thought to be a primary cardiac problem, but really a neurological problem. And this has been associated with other features of long COVID, being the brain fog, the fatigue, palpitations, lightheadedness. Many patients who have this, I mean, they really struggle to even to return to work for half a day. And I have many colleagues who have suffered from this, most of whom have recovered, but some still, when asked, still do have some residual effects of long COVID with these features. There's no clear treatment for POTS. Usually we try to ensure that these patients are well hydrated, because dehydration will make it worse. They may need to increase salt in their diet, and sometimes they need to be on medications as a result of it. Fludrocortisone to increase the hypotensive effects with this tachycardia syndrome, and sometimes beta blockers for those patients who may have the tachycardia. But there's no specific treatment for it, and most of it is somewhat anecdotal. There are a number of things that have been associated with COVID-19 and arrhythmias, a number of extra risk factors. Of course, myocardial ischemia or an infarction would be a clear risk factor. For those patients who are very sick, so patients who are hypoxemic, who go into shock, or who demonstrate the systemic inflammatory response syndrome, electrolyte abnormalities may also be seen, and therapies that prolong the QT interval, as we spoke about earlier. One of the treatments, remdesivir, which really, doesn't affect mortality much, but does reduce hospitalization in moderately ill COVID-19 patients, has been associated with sinus bradycardia. And it's also noted that many of these patients may have a pre-existing abnormality, what we call channelopathy. So something on a cellular level that makes them at risk of having fatal arrhythmias, things like Brugada syndrome or long QT. And fever is known, and that fever of any cause may actually unmask these channelopathies and lower their threshold for arrhythmias. So not only do we get cardiac arrhythmias like tachyarrhythmias, sinus tachycardia, AFib, and VT, but also cardiac arrest. So your heart can also stop. There's an observational study that there was increased mortality from out of hospital cardiac arrest even before they reach it. They think that possible causes may be directly related to COVID-19. Some of it may be stress related from the COVID-19 and all the lockdowns, etc., or there may be delays in medical attention. So these are the possible factors. Nothing is clearly proven, but there were studies in both Italy and France where they noticed an increase in out-of-hospital cardiac arrest when comparing the same periods between 2020 and the year before, pre-COVID 2019, in around March. So between February and April in 2020 compared to this period before, there was a significant increase in out-of-hospital cardiac arrest. On top of the things that COVID-19 can cause directly, what we have all noticed is that COVID-19 not only has direct effects, but also may act as a barrier to cardiac health. And there are a number of factors that contribute to this. One is patient perception, reduction in services that are being offered, or reduction in staff, and also a reduction in healthy lifestyle behaviors. Because I think earlier on in the pandemic, I mean, many of us have seen this. We've had patients who even stopped coming in to visit us at the doctor's office. I remember when COVID hit, in my office, we didn't really stop. I mean, we instituted a number of precautions, what are now considered to be standard precautions. But our patient load went down significantly because it was very clear as to what was happening earlier on and how the virus was truly being transmitted. We all knew it was respiratory, but people are saying, well, is it droplet versus aerosolization? the risk of coming into an office with recirculated air, being in a waiting room of people who you don't know. So that became a very big barrier, and a lot of patients didn't come in for their regular visits, or even patients who had problems didn't want to come into the hospital because it was seen as, you know, the COVID hospital if you were going to present to UE or KPH or Cornwall Regional. So the thought was that you would go to the hospital and they would put you in the same room as many of the COVID patients, and you would catch it that way, which you know, may be true to some extent, but not to the degree that was first thought. Over time, I think patients have been returning, and we are now back or close to our pre-COVID type of patient presentations, even though there are a few who still hold out, but and especially during periods of surges, of which there will be one or two more before the day is done. So, and as I mentioned earlier, the treatments for heart attacks and stroke have declined, and a lot of that had to do with what is theorized to be the decreased presentation. So people had their chest pain, but they stayed at home, and it has resulted in an increase in deaths as a result of that. And those people who haven't died will be suffering a much longer period over time. The full extent we have not even truly begun to notice. I think 5 years down the line, I think, is where we'll be able to look back and say, well, yes, well, clearly this led to that. But it's still pretty young in this process, despite us having been in it for 2 years. But some of the longer effects take a while to be seen, to become obvious. And as I mentioned before, many of these patients present with more advanced disease. Reduction in services. Initially, many hospitals had to go down to only their essential services for emergencies. There were many wards that were no longer available for regular patients, but were repurposed for COVID care. They became isolation wards, and some of them were not able to hold the same capacity as a regular ward for various reasons, being separation of the patients, of the beds. So there were less beds on the wards, and then also availability of wall-mounted oxygen, where some patients couldn't be put in a bed beside someone who was on a high-flow oxygen delivery system, for example, which would require 2 wall units. Staff had to be redistributed to be dedicated to COVID care. There were many COVID teams that were formed throughout the island, and many of our different hospitals responsible for that. Then there was also the fact that many doctors themselves were also getting sick or having to go into quarantine. And we do know of cases where our colleagues and our brothers and sisters have died as a result of COVID-19. And one of the things that we've noticed, or that we've seen working inside the hospital, is that doctors tend to lower their guard when they're hanging around with other doctors. And, you know, many people don't just work in the hospital, but they're associated with others, their friends, their family outside. But yet when they're in the hospital, you know, everybody feels, because that they know each other, that they're safe. But, you know, there have been incidents and documentations where doctors have, there's been a clear track where doctors have caught COVID from their own colleagues because they may eat lunch together, or they're in the same lounge, etc., or they're on call together, and they're not wearing their masks or distancing as according to protocol. Many private offices were closed for many physicians, general doctors, specialists, initially because of the fear as to what was going on, or because they got sick themselves. And there's a lot of uncertainty, especially earlier on. And even some doctors who did open up began to give differential care to patients, where some doctors came out right and said that they would refuse to give care to anybody who was not vaccinated. A very controversial approach at best. But anyway, it was also important that there was a reduction in service because clinic sizes had to be cut to reduce crowding, as well as wait times, which we know would be associated with an increased risk of transmission. But of course, if these patients are not seen, it means that problems are not detected earlier on. Patients run out of medications, patients have symptoms and have nowhere to turn. Also, amongst the behaviors of our patients, things like diet, stress, exercise, and the response has been very variable. There's some people who, you know, when their diets change, it's very stressful and they resort to emotional eating, comfort foods, which tend to be very high in calories and very low in actual nutritional value. The stress levels, we know stress is really directly related to many different diseases, and cardiovascular disease is no exception. And social media, I mean, people spend all this time on social media or watching CNN for the whole day to hear about this and that. And really, it's just reinforcing a lot of the stressful behavior. And there's actually no added benefit in looking at these things for beyond a certain amount of time. There's also the concept of lockdown loneliness, people who may live alone and isolate themselves even further because of the various restrictions, because of lockdowns or because of fear of transmission. It interferes with sleep because of the stress or because they spend so much time looking at screens, which results in blue light stimulation. And exercise has also been very variable. There are some people, I mean, there was a study done, I believe in Norway, where a number of patients increased their healthy behavior because it was recognized that things like exercise and that were more important for surviving an episode of COVID-19, whereas there are other people who began sitting more, gained weight, etc., as a result of that. So the response to COVID-19 has been very variable amongst patients, and it also depends on the area where you're from, because certain places their lockdowns were more severe, for example in China versus other places in the US. So there were more restrictions in other places than others. Here in Jamaica, we had a number of curfews which would restrict the available amount of time that you could be on the road. And there was closure of gyms earlier on in the pandemic. And there were certain exercises, for example, cycling has noted to be increased. I remember going to a bike store for my kids, and you know, speaking to the guy who owned the store, and he was saying, you know, a lot of people seem to be taking up cycling during the because of that. So I'll just finish up. So in summary, most cardiac manifestations are associations and not clearly proven to be causative from COVID-19. Myocardial injury is common. There's an increase in mortality as a result of cardiac involvement. Arrhythmias are common, mostly sinus tachycardia. And some patients may have some low level of myocarditis, which may cause problems in the long term. And there are many other indirect issues related to COVID-19. Thank you for your attention.
Thank you so much, Dr. Hosang. You know, that was really informative, interesting, and really very relevant. And a good reminder to us, I think, as family physicians, to sort of be cognizant of the systemic effect of COVID, and you know, recognize that these complications can occur, and always to try to take a holistic approach to a patient, listen to them, empathize with them, and of course, you know, very importantly, ensure that they get the adequate care, including if it needs to see, you know, if they need to see a specialist. But thanks a lot again. I learned a lot, I'm sure we all did, and just encouraging persons attending the conference to just please continue to put your questions in the Q&A chat so that after the second presenter we can discuss the questions. Thank you. So now we have our first presentation from one of our sponsors, and it is from Ms. Sherman Rabathom, Director of Health Promotions from the National Health Fund. Thanks a lot, Sherman, for being here, and we welcome you and look forward to what you have to tell us. Thank you.
Hi, Mr. Rabathom, please unmute. Should see a pop-up on your screen saying unmute. There you go.
Okay. Moderator, Dr. Sophie Abrikian, Dr. Donald Gordon, President of AGPA, Dr. Seni Ononunju, President of CCFP, members of AGPA, sponsors, colleagues, guests. Good day to you all. The National Health Fund is pleased to sponsor yet another World Family Day activity. The theme for this conference, Let's Walk Together, is most effective because to mitigate against the alarming statistics being reported annually, we really need partnership. And the NHF has recognized this. And consequently, doctors play a very important role for the NHF card program. Indeed, doctors are key partners for the NHF. So we seek mutually beneficial opportunities to provide support, and conferences such as this meet that criteria. So we're happy to be sponsors again this year. So for this presentation, I want to highlight why NHF covers chronic illnesses, NHF card benefits. Note that doctors are key NHF partners. Look at the NHF COVID response and approved drugs for private patients at selected drug-served locations. I know I don't have to go into the need for the focus on chronic illnesses. We all know the serious impact on families, communities, and the country as a whole. When NHF was set up in 2003, it started out with support for chronic illnesses because of the financial impact of these diseases, and any resident of Jamaica can obtain benefits available on the NHF card. The NHF is the agency that was set up to establish the National Health Insurance Plan or scheme as stated in the NHF Act of 2003. And we're hopeful that the NHF card program will make greater moves towards achieving this required funding, having the required funding in place to achieve the NHIP or some similar scheme. Now, through the NHF card, Jamaican residents are able to achieve subsidies on selected medication, diagnostic tests, diabetic and asthma supplies, once diagnosed with one or more of the 17 chronic illnesses covered by the fund. Of course, these applications, the doctor must verify that the person has the condition. And what we find is that doctors are the only ones, of course, based on the Medical Act, who can verify a person's condition. And when you look at the NHF program, we have some 3,500 doctors who have done so. Some have certified only one. There are others who have certified cards for over 600 NHF card beneficiaries. So the NHF application process, the doctors play a very important role, and we encourage you to, motivate your patients or get your patients to sign up for the card so that they can be in a better position to treat their chronic illnesses. Now, in this COVID era, what we're trying to do is, or what we tried to do during that time, and we still continue to do so, is to try to lessen the amount of time that NHF cardholders who are chronic disease patients spend in our offices at NHF and also on the road to access NHF benefits. Now, we introduced the online registration platform for doctors to support the NHF card application process. So doctors whose offices are computerized or who use computers at their desks, you can sign up your patients right there, and they receive a call from the customer care department to tell them to come in for their cards. And over the last couple of months, we have consistently seen about 33 applications being signed up this way, and we want to see more and more doctors participating and increasing this way of sign up. And why is this important? Because I've met patients, and perhaps you have have them in your offices as well, where you have signed up an application form for them and they take it home. And years later, they're still asking, can I still take in the application form now, even though it was signed up 3 years ago? When we use the online application process where the doctor actually signs up the patients, then we at NHF can call them to consistently remind them to come in and get your card, it's ready. So we ask, if you're interested in this, please call our customer service department or email us info@nhf.org.jm and we will get you on the program. The other thing that we have done to reduce patients' interaction in the public is we have reduced the time between filling of prescriptions. So you spend less time outside. So prior to COVID, you were able to fill your prescription, your 30-day supply up at day 26, but we have reduced that to 15 days. For the 60-day supply, we have reduced that to 45 days. And for the 90-day supply, you can now refill at 75 days. So we, if you're out in the town center and you are able to fill your prescription without going back another day, then this will reduce your time outside. There are currently some 255,000 active patients on the NHF card program, many of whom were introduced to the program by doctors who are online today. And again, we want to thank you for your continued support of the NHF program. But there's something I want to bring to your attention. What we have been doing last year is that we started a survey process where those who were recently signed on to the program, we're calling them to find out, how are things going? And one of the questions we decided to ask is, do you know what illness your doctor ticked on your application form? And surprisingly, 20% did not know what their doctor ticked. I know that there could be various reasons for this, but we really all need to work together, both the doctors and ourselves when they come to sign up, to increase awareness and understanding of the condition that they have and that they have signed up for, so that they can use the benefits of the program to control their illness. Now, in this COVID time, and at other times as well, we know that there are some drugs that are quite expensive, and not only that, they are not widely available in the private pharmacy sector. So the NHF has approved a basket of drugs that private patients can purchase from DrugServe. And these are selected DrugServe locations. And these are medications for renal disease, HIV, cancers, mental illnesses, attention deficit hyperactivity disorder, endometriosis, inflammatory bowel disease, multiple sclerosis, and Guillain-Barré syndrome. So we're not saying that all the medications are available through DrugServe. It's a basket of drugs that have been approved for these conditions. So you can always call us for those details. The NHF is committed to continuously improve the customer experience for our chronic disease patients and also for everyone who interacts with us, including, of course, our doctors. And by way of our health promotion efforts and the NHF card program, we will continue to work together with our doctors and with our other stakeholders to combat chronic diseases through partnerships. So thank you very much for listening. These are the various ways in which you can contact us at the NHF. You can always go on our website to get this information and on our social media pages as well, and at NHF Jamaica, and send us a direct message. Continue to have a great conference. Thank you so much.
Thanks very much, Sherman. I know for me it was really informative as a GP, and thanks a lot for all the updates. And I see a lot of doctors also have some additional questions. Perhaps if we don't get to them orally, perhaps, if you're willing, maybe you could type a few answers if it's not too much for you. Because I think some of those questions can actually be very commonly asked, and we're always not so fully sure. So I'd appreciate if you could give us some responses. Thanks a lot again.
Yes, I'll do the responses in the chat. All the best.
Awesome.
Also, I believe there was a link in the presentation that persons would like to have shared in the chat so they could access it. Not sure if you could do that, Mr. Rabathom.
Yeah,
Related
sure,
to
will do.
the doctor signing up the patients, yes. Because some of
will
us may not be aware of that. Thank you. Okay, I'm going to move on to, we have two other sponsors representing Recharge Distributors Limited, or RDL, Mrs. Chrisanne Montgomery Legisto, and very well known to us from Abbott Nutritionals is Mr. Paul Russell. For these sponsors, what we're going to do is there will be two short videos played successively, so we can just stay tuned and see what updates they have for us. Thanks a lot for the sponsorship, and we look forward to the information from both of you.
Are you looking for quality products you can trust to meet your needs and your patients' needs? Then RDL Distributors has all the tools you need. We are committed to providing medical professionals with the best all-natural health and prescription drugs at a competitive price, along with the most appropriate technologically advanced medical devices, medical supplies, and point-of-care tests, both quantitative and qualitative. So sit back and relax as we share briefly some of our products in our catalog. Our product catalog is specifically designed to include products for prevention, diagnosis, and treatment of illnesses. Let's look at some of our products for prevention. Firstly, our supplements. Nourish Gold, which contains 7 B vitamins along with essential minerals like zinc, vitamins C, D, and E, and is a great supplement for everyone, especially diabetics, persons recovering from COVID-19 and any other ailment, and should be used as a daily supplement to maintain good health. Our Zecal D3 contains 2 essential vitamins our own bodies can't produce, calcium and vitamin D3. Our other supplements include Evictal, vitamin E, and Code Soft EPO, evening primrose oil. Other products from our prevention line includes our exciting line of Moots condoms, which offers 17 different variants. And if you were in the mood and forgot to use Moots, our emergency contraceptive Prevental gives coverage up to 72 hours after unprotected sex. Let's review some of the products from our treatment line. Firstly, our oncology line from Get Well Pharmaceuticals, which covers products for solid tumors, hematological malignancies, and palliative care. Our gemcitabine, doxorubicin, and paclitaxel are subsidized by NHF, and unlisted Get Well products are available upon special request. Next, we have iron preparations for both adults and children, with little to no constipation and a great taste. Our Hemop Gems is a complete blood builder as it contains cupric, manganese, folic acid along with ferrous fumarate, all of which works in sync to help the body form red blood cells. And of course, Overmalt, which comes in 2 preparations, Overmalt drops and Overmalt Forte chewable tablets. Our vaginal suppositories, Gyno V6, contains clotrimazole, while Danfoss and Trinite contains clotrimazole and clindamycin, all of which targets mixed vaginal infections. Next, we have Overclow with active ingredient metoclopramide, which is used in conditions such as pregnancy, chemotherapy, GERD, and any other conditions that require stomach emptying. We also offer a wide variety of injectables such as ceftriaxone, vitamin K1, diclofenac sodium, and triamcinolone. Let's not forget our proton pump inhibitor Lantacid 30, which contains lansoprazole, and our beta blocker Acridol, which contains carvedilol. Our point-of-care analyzers are easy to use and provides accurate results within minutes. We offer a wide range of point-of-care analyzers and diagnostic rapid test kits for both humans and animals. Testing parameters for humans includes but not limited to blood glucose with SD code-free, lipids using SD Lipidocare, HbA1c using SD Multicare, and hormones and cancer markers using the Vida Lab Analyzer. Our rapid test kits for humans includes COVID-19, STIs such as HIV and syphilis, drug of abuse which includes cocaine and THC, dengue, blood-borne diseases, enteric diseases, and cardiac markers such as troponin I. We also offer PPEs such as thermometers, disposable gowns, and pulse oximeter, along with our premium quality powder-free gloves, both nitrile and latex. Remember once more, all products marketed by RDL distributors are very affordable. To access our world-class products and more, be sure to contact us or visit our location at 136 Maxfield Avenue. We're looking forward to partnering with you, RDL distributors, empowering individuals to live a healthy life.
As a clinician, helping your patients make the right decisions is a daily task. Glucerna shakes provide nutrients to help your patients support their immune health. Replacing a usual breakfast and a snack with Glucerna Hunger Smart resulted in a 50% reduction in the positive blood glucose area under the curve after breakfast. Glucerna contains Carb Steady, which is a scientifically designed blend of slow-release carbohydrates which allow your patients to maintain more consistent, balanced blood sugar throughout the day. Because many of your patients make poor choices or they may miss breakfast and lunch altogether, Glucerna provides a better meal choice with more protein, key vitamins and minerals to support the immune system of your patients. Glucerna is available in all major supermarkets and pharmacies and is distributed by Caramel.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
Life doesn't stop for diabetes. Be ready for every moment with Glucerna. It's the #1 doctor-recommended brand that's scientifically designed to help manage your blood sugar. Live every moment. Glucerna.
Thank you so much again, the sponsors, for updating us and just for being a part and helping us to allow this conference to happen today. And thanks for all the questions, very relevant questions. Thanks a lot, Sherman, and thanks a lot, Dr. Hosang, for answering them so promptly. They really are great questions, so keep them coming in the chat. And we will, once the questions are answered by being typed in the chat, we won't go over them again, but you can check for the answers there. But those that have been unanswered, when our next speaker has finished, we will go over which ones hadn't been answered at that time. So keep them coming. So just to introduce Professor Peter Figaro, his name, he is just so well known to us in medicine. And he has so many qualifications, I had to even look up one of them. I didn't know what they were. His name is synonymous with public health here in Jamaica, with HIV and AIDS. He's been so instrumental in so many things. Doctor of public health program. He's been, part of work with PAHO, WHO, and really heavily involved in HIV, national HIV AIDS work, and the STI, national STI program. So welcome, Professor Peter Figaro. It's always great to hear information from you, and we know you'll be talking up to us about infections causing cancer. So thanks a lot for being here, and we're ready to listen to you.
Okay, thank you so much, Dr. Abrikian, for your kind introduction. Good morning to everyone. My talk is on infections causing cancer. And thanks for inviting me to do this presentation. I'm going to just touch on the leading causes of death and the leading infections and cancers globally with an overview, but then I'm going to actually discuss the key infections causing different specific cancers. And I want us to focus on how we can better control these infections in order to reduce the burden of cancer. Now, when you look at the leading causes of death globally in 2000 and 2019, you can see that 7 of the leading causes were non-communicable disease. And for each of these, you can see that the number of deaths increased between 2000 and 2019, shown by the empty circles as 2000 and the blue filled-in circles as 2019. Ischemic heart disease was number 1, followed by stroke. There were 2 infectious diseases at 4, lower respiratory infections and diarrheal diseases at 8 that were leading causes in the top 10. Neonatal conditions were number 5. If you look at the global burden of infectious disease, going back to the turn of the century, there were 14.9 million deaths due to infectious disease. This was just a quarter of all deaths, but 5 of these diseases accounted for 77% of the deaths due to and these were respiratory tract infections, diarrheal diseases, HIV, TB, and malaria. Now, in low-income countries, those last 3 infectious diseases, HIV, TB, and malaria, actually are among the top 10 leading causes of death in low-income countries. Now, of course, COVID has, over the past 2 years, made a huge difference in relation to leading causes of disease. And we've had over 6 million reported deaths, but actually WHO has estimated nearly 15 million excess deaths due to COVID, either directly or indirectly, which interestingly is equivalent to the number of deaths due to infectious diseases in 2002. So COVID has made a huge difference in the past 2 years. But if we look at the morbidity and if we look at the deaths, you can see on the right-hand side, in millions, the number of deaths due to infectious diseases. The number of episodes, of course, due to diarrheal disease are huge, over 4 billion. But many people do not realize that globally, tuberculosis is still responsible for over 1.4 million deaths annually and responsible for more deaths globally than HIV. Now, when we come to COVID, you will see at the bottom there, over 6 million deaths reported, nearly 15 million estimated to be the actual true number. The number of episodes reported, over 500 million, but in truth, probably closer to 5 billion or more. And we just heard from Dr. Mark Hosan, the impact on the heart from long COVID. There's a paper in the Lancet just published, which followed up for 2 years, persons suffering from COVID who were in hospital, discharged, and 55% of them had at least one symptom of long COVID after 2 years of follow-up. So this is not a disease to be taken lightly. Now let's get to the cancers. These are the leading causes of cancer globally in 2020. And over 2 million cases of breast cancer, lung cancer, nearly 2 million of colorectal. But the ones that we are going to focus on are those that are 5th, 6th, and 7th, stomach, liver, and cervix, because these are conditions where infections play an important role. This looks at the age standardized rate, the incidence of the global cancers in blue. So you can see that breast has the highest incidence, followed by prostate and lung. However, when it comes to the highest mortality rate in red, you will see that lung leads the way, followed by breast. Another way to look at this, if we first look at the new cancer cases, you can see that breast leads, followed by lung, and then colorectal cancer. However, if you look at the cancer deaths in 2020, it is lung cancer that leads the deaths, followed by colorectal cancer, and then liver cancer, stomach cancer, and then breast. So the therapeutic options do make a difference in relation to which cancers cause more mortality. Now, the global burden of cancers due to infections, you can see that the global incidence of cancer in 2020 was 18 million cases. About 15% of these cancers, 2.7 million, there's some contribution from infections, whether Helicobacter pylori, Hepatitis B and C, human papillomavirus, and then certain other viruses that I will come to. If we start with stomach cancer, the risk factors. H. pylori is an important risk factor for stomach cancer. And the risk factors, usually it's older men more than women, 60 years of age or more, persons with a history of smoking, alcohol intake, and being overweight or obese. In some instances, industrial chemical exposure and consuming salt processed foods. If you have a family history of stomach cancer, you may be more at risk. And if tumors in other parts of the digestive system are found, or stomach polyps. And stomach cancer is found particularly in Asia, Mongolia, Japan, Korea, China have high rates, and Peru in South America. There's some inherited genetic syndromes also. Lifestyle does play a role. The eating of a lot of salty or processed foods, grilled or barbecued meat or fish. If you don't eat fruit, drinking more than 3 drinks of alcohol a day, inactivity, smoking, and if you don't store or cook food properly, all these can contribute to a higher risk of stomach cancer. And if you have citrus fruit, it appears to decrease the risk. The symptoms, frequent heartburn, may not just be dyspepsia. It may be something worse, loss of appetite, a lot of bloating, indigestion, and burping. Early satiety, in other words, feeling full after eating only a small amount. Excessive fatigue or persistent abdominal pain. Bear in mind that you may need to rule out stomach cancer. If it's more advanced stomach cancer or metastatic cancer, then melena, bloody stools, anemia, nausea and vomiting or epigastric mass can lead to jaundice and weight loss. Diagnosis, usually through endoscopy with biopsy. Imaging can be useful. And then there are a range of treatments that we're not going to go into. The prognosis is not that great. In the US, it's about 32% over 5 years. In many other countries, it is worse than that. Now, moving from stomach cancer to liver cancer, 90% of which is hepatocellular cancer. It's the 6th most common cancer and considered to be a silent killer. The number of people living with liver disease has increased from 1.5 billion in 2017 to 1.6 billion in 2019. And there are 2 liver conditions you need to bear in mind. Non-alcoholic fatty liver disease, where there is excess fat deposited in the liver, but there's no actual damage to the liver. And then there's NASH, non-alcoholic steatohepatitis, where yes, there's a lot of fat being deposited in the liver. There's also inflammation and damage to the liver cells. And this can lead directly to liver cancer. The number of patients actually progressing to liver cancer is increasing, and over 800,000 cases of hepatocellular cancer in 2020. The risk factors, hepatitis B and C play a critical role in contributing to the high rate of liver cancer globally. And these can cause cirrhosis, or they can cause cancer directly through chronic viral hepatitis. Infestation of liver flukes can also lead to liver cancer. Long-term use of oral contraceptives containing high doses of estrogen and progesterone. I don't think that these high doses, that most people would stay on them for that long now. Smoking and alcohol are important. And again, note overweight and obesity. Overweight and obesity is increasingly being identified as a risk factor, not just for stomach and liver cancer, but for a range of cancers. And foods contaminated by aflatoxin toxins from fungi also are important. Fatty foods, insulin resistance, type 2 diabetes, dyslipidemia. Again, diabetes also is being shown to be associated with a number of cancers. Now, there are protective factors. Vaccination with hepatitis B, that is a fully preventive measure against liver cancer arising from chronic hepatitis B. And we are encouraging now the birth dose of hepatitis B to newborns because this prevents mother-to-child transmission of hepatitis B. Drinking coffee appears to decrease the risk of liver cancer. Consuming fish also might decrease the risk, and being physically active also might decrease the risk not only of liver cancer, but lots of other conditions. So healthy lifestyle and avoiding the risk factors is important. This is just a graphic showing a normal liver, which if infected with hepatitis B or C, can develop fibrosis, cirrhosis, and liver cancer. But they're now recognizing that if you have NASH, that can also contribute directly to an increase in liver cancer. The signs: abdominal pain or tenderness, easy bruising or bleeding, enlarged abdomen, unexplained weight loss, and jaundice may be signs of hepatocellular cancer. And you can do ultrasound or liver biopsy to diagnose, and of course, CT scan, abdominal MRI. A liver biopsy is important. There are a variety of treatments: surgery, radiation, liver transplant, of course, where the facilities are, and a range of therapeutic agents that can be used. However, about 50% of persons diagnosed with advanced liver cancer die within 1 year. And even within the US, less than 30% of persons with liver cancer receive any treatment at all. And this is a huge problem globally. Moving on to human papillomavirus. If you look at the Hpv prevalence in cervical specimens of women with normal cytological findings, the worldwide prevalence of HPV is just under 12%. In Africa, it is twice as high at 24%. And in the Caribbean and Latin America, it's approximately 16%. There are over 200 human papillomavirus types, but the primary high-risk types are HPV 16 and 18. There are about a dozen other high-risk types. I've put some of them there. Now, HPV associated cancers, clearly we all know that HPV infection is the cause of cervical cancer, but it is also the cause of a proportion of cancers of the anus, the oropharynx, the vulva, the vagina, and the penis. So HPV really is an important cancer, an infection that causes cancer. The type 16 and 18 are associated with maybe 71% of cervical cancers globally, 85% of HPV-related head and neck cancers, and 87% of anal cancers. So this is an important infection. You can see that if you look at the estimated age-standardized incidence rates, you can see in dark that it's Africa and South America, Central America, and the Caribbean. With Southeast Asia to some extent, you can see these are the areas, the southern aspect of the globe that is really affected. Now, the risk factors: this is the fourth most common cancer in women, cervical cancer. Most of the HPV infections are asymptomatic and resolve spontaneously within 1 to 2 years. The interval between acquisition of HPV infection and progression to invasive cancer is usually 20 years or longer. And the basis for the progression is not well understood. But persistent HPV infections may progress towards pre-malignant glandular or squamous intraepithelial lesions, and they are classified histopathologically as CIN, cervical intraepithelial neoplasia. Now, many of these CIN lesions regress spontaneously, but some go on to cancer. So, of course, infection with type 16 and 18, big risk factor. If you're immunocompromised, like if you're on HIV infected and not properly treated, then you're at greater risk. Co-infection with other sexually transmitted infections, increased parity, younger age of first pregnancy, tobacco smoking, which we know is associated with so many cancers, diethyl stilbestrol. This has now been withdrawn. It's a synthetic estrogen. And again, we're now seeing that overweight or obesity is also a risk factor for cervical cancer. 90% of cervical cancer deaths occur in low and mid-income countries. The prevention, if we could get our girls or our girls and boys vaccinated with HPV, we could fully prevent the vast majority of cases of cancer of the cervix. Treatment, surgery or radiotherapy, with or without chemotherapy. But really, this is a preventable cancer. These are the targets for 2030, getting 90% of the girls fully vaccinated against HPV. If you can get 80% of the girls vaccinated in our country, you get herd immunity and reduced HPV in those who are not vaccinated, as well as the boys. 70% of women screened with a high performance test, and 90% of women identified with CA cervix to receive treatment. These are the targets for 2030. The quadrivalent HPV vaccine was licensed in 2006, the bivalent in 2007, the nonavalent, 9 different types are in this one, in 2014. All of these are excellent vaccines. They are highly effective and they are safe. Even the bivalent and the quadrivalent appear to have cross-reactive protection to types, to carcinogenic types that are not in the vaccine. Initially, when it was introduced, it was 3 doses that were required. Now we know that 2 doses, given roughly 6 months apart, is very effective in preventing cancer of the cervix. And recent studies are showing that 1 dose may well be effective once it's given prior to the resumption of sexual activity. This is a vaccine that we all need to support, and it is a very safe vaccine, one of the safest. Now, moving on from those important cancers, stomach, liver, and cervix, we touch on Epstein-Barr virus. This is in the herpes family, human herpes virus 4. And you know about the kissing disease, infectious mononucleosis. Some people, a minority, do have continued symptoms of fatigue following infection with this virus. It is associated with several malignancies, including stomach cancer, nasopharyngeal cancer, Hodgkin and Burkitt lymphomas. So this is an important virus infection that causes virus. It's also thought to be associated with autoimmune diseases such as SLE and multiple sclerosis. I don't know too much about that, And I didn't get a chance to read it up properly. Tony Fauci says, that a vaccine against Epstein-Barr virus could reduce the incidence of infectious mononucleosis, as well as reduce the incidence of some malignancies. And they're actually doing a clinical trial to try and develop a suitable vaccine for that. This now is images of Kaposi Sarcoma. You can see these kind of purplish lesions on the skin, usually the extremities. 34,000 cases in 2020. The cancer cells are found in skin or mucous membranes that line the GI tract, usually purple patches or nodules on the skin and or mucous membranes. And this is due to the human herpes virus 8, HHV8. So it's the same family as the Epstein-Barr virus, the herpes family. There are 4 types of Kaposi sarcoma: classical, which is a slowly developing Kaposi sarcoma. There's endemic African Kaposi sarcoma. And then AIDS-related Kaposi sarcoma, due to the reduced immunity, then you may develop Kaposi sarcoma. This is much less common now, given the good antiretroviral treatment available for HIV. But persons who get transplants and you have to suppress their immunity, they could even get transplant-related Kaposi sarcoma. Usually 75% of people with Kaposi will live for at least 5 years after diagnosis. Let's now come to an infection which is very important in the Caribbean, and we're not paying sufficient attention to it: the human T-cell lymphoma virus 1. This is a significant health burden globally. 5 to 10 million persons living with this virus. And it causes a cancer, a very severe cancer, adult T-cell leukemia lymphoma, in which most people die within a year. There's also HTLV1 associated myelopathy, or TSP, tropical spastic paresis. This was initially described in Jamaica at the University of the West Indies. Professor Cruikshank, Pam Rogers, and others. They described this as Jamaican neuropathy before the causal agent was identified by Gallo. Other conditions, uveitis, infective dermatitis, arthritis, can be caused by this infection. A lot of the research concerning this infection has been done in the Caribbean, including Jamaica, Trinidad, and Martinique. The prevalence you can see is described in the Caribbean, South America, Africa, and Japan. A lot of the research also done in Japan and a few other countries. There are a number of different types. Sorry about that. And these are shown on this map. And you can see all along the west coast of North America and spread throughout the globe because, even though new areas of HTLV1 endemicity is being found, including among the Aborigines in Australia, where in some areas it is as high as 24% prevalence. If you look at the cancer, the ATL, that is due to this virus, you can see the same areas, especially South America, Central America, the Caribbean, and Japan. It's interesting that this cancer usually is in persons over 60 years of age. You can see where the incidence rises rapidly after that age. Okay, the modes of transmission are vertically from mother to child, primarily through breastfeeding. And this is very important because that is where the cancer usually arises, when an infant is infected young in life, and then decades later, they develop ATL. Parenterally through blood transfusion or organ transplantation, and sexually. Now, the Global Viral Network wrote the WHO in 2018, pointing out that more needs to be done to control HTLV1, and there is clear evidence to show that transmission of HTLV1 could be averted by using condoms when having sex, avoiding transfusion and transplantation of infected blood, advising HTLV1 positive mothers not to breastfeed, using sterile needles for people who do injecting drugs, and better educating health professionals and the population. And they propose, this Global Viral Network, a number of strategies to protect the sexually active population through routine testing of those who are at risk in sexual health clinics, and to promoting counseling, monitoring of persons who are positive, partner notification, and condom use. Now, in Japan, in Nagasaki region, they introduced antenatal screening in 1987, and they were able to reduce prevalence from 7% to 1%. And they rolled out a mother-to-child transmission prevention program, which dramatically reduced vertical transmission from 20% to 2.5%. Likewise, in Martinique, I just have a couple more slides and I'll be finished. In Martinique, they also decreased the incidence of ham-TSP by 87%. So this is something that we need to do. We can screen all pregnant women, test them for HTLV1, and then advise them if they are positive to limit breastfeeding to under 6 months, because it's after 6 months that you're more likely to infect the newborn infant. And then, of course, also try and prevent sexual transmission. The significant challenges, although we still need a more reliable, inexpensive test for HTLV1. Counseling a person is not straightforward because it can induce stress, anxiety, and uncertainty. And some persons may prefer not to know their status. But, you know, we should attempt to do better, as well as to reach partners and to counsel them. But of course, we would have to learn how to do this counseling. So in summary, there are a number of important infections that cause cancer: H. pylori, hepatitis B and C, HPV, and HTLV1. And we can do much more to promote prevention, ensuring vaccination with hepatitis B and HPV vaccines. We can screen pregnant women for HTLV1 and advise them not to breastfeed beyond 4 months. And of course, effective treatment of H. pylori and hepatitis. And we need more research so that we can do better. I thank you.
Thank you very much, Professor Figaro, for the very relevant and current presentation. It really just reminds us as family physicians too, to continue in our holistic approach, to encourage our patients, towards positive lifestyle changes. And it's still our duty, as always, to keep up with, for red flags and to recommend age-appropriate cancer screening when relevant. Thanks again so much. We have a lot of questions for you in the chat. And Dr. Ho-Sang has kindly answered almost all of his questions already. Thanks a lot, Dr. Ho-Sang. So what I will do is I sort of choose a few I think Sam Conroy, we may have about 10 minutes or less, so I'll try to choose a few, and then what I will ask Prof, if it's okay with you and Dr. Hosang, if there are those that are not answered, if you will be willing to give us a little more time and just type the answers there for us, please. Thank you. So I will go to one that I see here from Ruth Hanno. She has a couple of questions. I won't pick all of them, Ruth, but I'll ask a few. So, Prof. Figaro, for you, she says, why are HIV, TB, and Myocarditis more prominent in developing countries? Why do you think?
Well, part of it is the general less developed state of the health services and the economy as a whole. We know that HIV hit African countries the hardest, and there are many low-income countries in Africa, partly also because of the history of colonialism, slavery, the devastation that wreaked on these countries. So, you know, there are important social reasons why this is the case. Also, malaria is an important disease in many of these countries where it has not been eliminated as we were able to eliminate it in the Caribbean and some of the other more developed countries. So it's a reality, you know, the nutritional state of the people as well. So it's a reality of underdevelopment and continued exploitation in the world, and the inequity that we face globally that we need to address better.
Thanks, Prof. Also, another question, can the HPV vaccine, which is a common question actually amongst us GPs, can the HPV vaccine be given safely in those overall over the age of 45 years?
Sure, it can be if they've never received it. It's not going to do any harm even in someone who has been infected. So it's a very safe vaccine. So if in doubt, you can always use it.
To follow up on that, is there a maximum age after which we shouldn't give it for the females or males?
Well, usually you wouldn't be giving it in older people, you know, over the age of 50 because they've already reached a certain point in life. Clearly, we use it routinely as a childhood vaccine. But the problem that we face, our coverage is pretty good in the Caribbean and in Jamaica. But the problem is that if women of reproductive age, for any reason, get infection with hepatitis B, let's say sexually, and they are infected, they get pregnant, we're not testing them to see whether they have hepatitis B or not. And they can pass it vertically to the newborn child. So this is why we want to give a birth dose to that newborn child, so that that birth dose actually will, in most instances, prevent vertical transmission from a woman with hepatitis B who has not been diagnosed. It will prevent that child becoming infected because we're not giving the first hepatitis B vaccine till 6 weeks or 2 months. And by then it's too late. The child would have already been infected. So this is a very important initiative that PAHO is pressing, and hopefully we can, you know, get 100% coverage of our newborns.
Okay, Prof, I think we have time for one more question, and I will choose this one from Ms. Hannah. What effect, if any, has COVID-19 had on the increase or the incidence of cancer?
I think it has probably increased it because, unfortunately, with COVID, as Mark pointed out, the access to the health service became totally, you know, it was a huge barrier. And I think we as physicians have to reassess soberly whether we, you know, can we really manage pandemics in this way, where you're only focusing on the pandemic and you drop your hands entirely or claim that no one else can come into the hospital. I just don't agree with that at all. We've got to learn to deal with infectious conditions like COVID, and yet continue to manage those who most need care from other conditions. So, I mean, part of the challenge is that health providers are humans and therefore are anxious. They're at greater risk. There's no doubt about it. We've lost a lot of health providers, but as long as, you know, proper attention is being given to ensuring that the protective gear is there, we are the frontline people who need to continue to provide care. You know, I didn't close my office during COVID, and I am over 50, I can tell you that. But you just be careful. You just have to be more careful. But people need our attention and care. We cannot, I don't think we can neglect them just because we have COVID. Over.
Thanks a lot, Prof. Very sobering and a good reminder for us all. I'm going to end this session now, but just a reminder to the persons attending, please try to put your questions in the actual Q&A chat, not the regular chat, so we can definitely have the presenters answer them, because I'm seeing a few questions in the regular chat. Thank you so much for all the presenters, and we really learned a lot. Thank you. Handing over to Dr. Anna Brown-Morgan. Good morning, Doc.
Good morning, Sophie, Dr. Brikian. Good afternoon. Good afternoon, everyone. I am Anna Brown-Morgan, and I am your moderator for the second session this afternoon. I thank everyone so far for doing so very, very well. And of course, thanks to Dr. Brikian. I'd like now to start the second session with inviting Mr. Daya from Indus Life Sciences to do his presentation. I just like to say how very much we appreciate Mr. Daya's continuing support for the World Family Doctors Day seminar, conference over the years. Go ahead, Mr. Daya, thank you.
Afternoon, thanks Dr. Anna Brown-Morgan. Afternoon to everyone, and from Indus Life Sciences. And we are just allowed to brief about a new product that we are just introduced in Jamaica. So let me straight away go to the product. And doctor, as you know, you come across patients with these conditions quite often, suffering from heartburn, hyperacidity, gastritis, flatulence, reflux, acid reflux, and also ulcer, like duodenal ulcer. And the thing is that not all these patients need to be treated with H2 receptor blocker or maybe a proton pump inhibitor. Many a times you will choose to start with an antacid, but the challenge is that which is the right antacid, because you know, if you see, there are many brands of antacids available in the market, and it's being detailed to you also. Brands start with D, R, M, like different alphabets. So that's the reason the antacids are basically classified as generations: first generation antacid, second generation antacid. So a little understanding about the first generation. The first generation antacids are those antacids are basically helps to neutralize the acidity, the excess acid that is secreted. So obviously they offer components like magnesium hydroxide, also they offer dried aluminum hydroxide, as well as magnesium trisilicate. So these components helps to neutralize the excess acid. But unfortunately, this is not the complete, because the ulcer patients do suffer from flatulence, acid reflux conditions also. That's why the second generation antacids were introduced. Honestly, currently what we see in Jamaica, 90% of them are the second generation antacids, and the balance 10% maybe the first generation. So the second generation antacids are the one which, apart from neutralizing acidity with aluminum hydroxide, magnesium trisilicate, they also offer either dimethicone or simethicone. This role of this dimethicone or simethicone is basically they helps to release the excess gas that is formed due to ulcer. That is basically helps to for the flatulence. You know, they have anti-flatulence action. So that's the benefit of that. But if you look at it closely, the other major complication in ulcer is still left unattended. One of the most important complication is the GERD, gastroesophagus reflux disease, which is the acid reflux, which is unattended. Many times after dinner, when the person goes to the bed and they lies down, it throws up, and basic symptom is the heartburn, or some patients may even complain to us chest pain or chest burn, and some of them may even panic. They even think it is heart attack, and then they are worried and disturb the sleep. So the acid reflux is something which 8 out of 10 patients, ulcer patients, will suffer from. Unfortunately, the currently available all antacids, whatever the brand name that you see, they have nothing to do with GERD. So that is where we are coming in with the new generation antacid. As I mentioned, heartburn, the basic symptom is heartburn. The GERD, the symptom is heartburn. And of course, regurgitation as well as dysphagia, extraesophageal manifestation, which also leads to laryngitis and cough. These are the symptoms GERD as associated, where basically the stomach content moves up towards the esophagus. It goes up. Normally we know GA system, it is supposed to move from top to bottom, but in ulcer, the GERD is a condition where it goes from the stomach into the esophagus. That's why the heartburn happens. So we have to stop this moving of the stomach content from the stomach to esophagus. That's why the new third generation, we are the first company proud to share introducing an antacid which is classified as a third generation antacid, or it is a new generation antacid, I could say. So first time in Jamaica, the new generation, third generation antacid has come in with alginic benefit. The alginic acid is basically a natural algae. It's an algae, natural algae. The role of this alginic acid is that when the patient takes this antacid, which has a regular acid neutralizing medications like aluminum hydroxide, magnesium hydroxide, magnesium trisilicate, and also it has a dimethicone for the gas, plus it has alginic acid. When the patients take this antacid, this alginic acid mixes with the stomach content and forms a thick foam or a precipitation, and that floats over the stomach content. As you could see in the picture, it forms a raft. This raft, basically what it does, it stops the movement of stomach content from stomach into the esophagus. Thereby the acid reflux is prevented. Good thing with this alginic acid, it's a totally neutral. It does not interact with any medication, does not interact with the stomach content, and also it formed within 4 minutes of taking the antacid. The raft is formed, and the raft stays literally up to 4 hours. After 4 hours, it gets completely excreted along with the stomach content, and it does not leave any residue. So that's the benefit of the alginic acid, and this is the brand that we are introducing now. It is already available in pharmacies across the island. We coined the brand name as New Gel, just to communicate is a new generation antacid gel. That's how it has become New Gel, new generation antacid gel. That is the third generation. The only third generation or the new generation is New Gel. It offers the regular acid neutralizing medications, aluminum hydroxide, magnesium trisilicate. Even if you look at it, these acid neutralizing medications, they are very, very, balanced. Each of them are just same, proportion, 250 of each. The reason is that if one of them is in higher, strength, probably it may either cause diarrhea or constipation. This balanced formula avoids that, that side, the diarrhea or constipation. And the dimethicone, as I mentioned, helps to release the excess gas. And the alginic acid is an anti-reflux mechanism it has. So the good news about this new gel, new generation antacid gel, it's a sugar-free antacid, so can be safely given for diabetes patients. And as I mentioned, is fast acting. Within 4 minutes, the action kicks in and stays up to 4 hours. And also another good news, it's safe in pregnancy. Can be given for pregnant mothers, whether it is first trimester, second trimester, or third trimester, this antacid can be given to them. And in children, 12 years and above is a regular dose of 10 to 15 mils you can give 3 times or maximum 4 times depending on the acidity. So 3 times is a standard, and you can go up to 4 times. 10 ml is the normal dose, and it has a mint flavor. So, we all know mint has little digestive properties, so it has a mint flavor, and it comes as 200 ml bottle. That's the size you see it in the pharmacies. And another good news, this is over the counter. So no need for prescription. Patient can just go, and if the patient calls you, wakes you up in the late night, and you need not have to worry about sending a prescription, you can just advise them, go and get a new gel from the pharmacies nearby, so they can get it without prescription. And now, doctor, we have extension of new gel for your patients who are duodenal ulcer associated with pain or gastritis associated with pain, which is a basic symptom. They come to you with the pain. That's where they normally knock your door for help. So for them, we have this new gel O. The O is actually the oxytocin. The oxytocin, you all know, it's a pain medication, is anesthetic drug, which what it does, the oxytocin, when the patient takes this antacid, it gives a coating to the stomach wall. By giving a coating to the stomach wall, it relieves the pain associated with gastritis and ulcer. And also Nugelo as a regular other, acid neutralizing medications, the magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate. It has the alginic acid, anti-reflux medication. It has simethicone, which helps to release the gas also. And Nugel O is also sugar-free, and it comes as 200 ml. And again, this is also an OTC, over the counter. So both Nugel and Nugel O are over the counter. There's no need for prescription. And it's in insurance already. We have they call as NDC number, which is the insurance. So it's covered by the insurance also. And the only contraindication or caution is that Nugel O is not recommended for pregnant mothers, as because the oxytocin component, probably pregnant mothers where they experience the cramp, the pain, that it may interfere with that. So for during pregnancy phase, we can recommend Nugel. And non-pregnant women or rest anybody else, I could say confidently, this is the one-stop solution. Because if you look at it overall, this is the first antacid, relieves, helps for hyperacidity and relieves the gas and stops the reflux, and also, it relieves the pain. So I think nothing is left for ulcer patient with this. So all side, what complication ulcer patient normally complain, all this will be attended by Nugel O. So as I mentioned, the heartburn is attended, pain is attended, gas is taken care, and hyperacidity is done. So everything. So it's a one-stop solution, honestly speaking. So the dose is again for less than 12 years, we don't recommend Nugel O. So it is for 12 years and above. So 10 to 15 ml, depending on the age, and you can go maximum to 15 ml, 4 times a day. Maximum dose is recommended. And this is the indication: gastritic, duodenal ulcer, heartburn, reflux, gastritis, flatulence. So doctor, next time if you want to give an antacid to your patient, probably this could help you, doctor, to select the right antacid. Just doctor, look at the indications and look, second generation you want to go or third generation, which is obviously currently only Nugel is the third generation in Jamaica. So hyperacidity, Nugel is okay, is yes, and flatulence, Nugel is yes, GERD is yes, pain is yes. Cost, I'll come to you. The second generations are good. I'm not bashing them, the second generation are very good antacid, but unfortunately, there are limitations. It's good for hyperacidity and flatulence. With respect to GERD and pain, and none of the second generation will be, true, except the third generation, which is Nugel, the new generation. So this is actually, I'm not bashing any of this brand. All of them are good. I'm just giving you, as you are the better judge, you know what each of the antacid offers you. You can just compare. It's a ready reckoner just to look at it and understand. The cost is also on the bottom. This is a price to the patients from the pharmacy. Not our price to the pharmacy, what the patient pays when they buy this product. You see the pack also, it's a 200 ml bottle, and this is the composition. And the doctor, again, I'm mentioning it, I'm not bashing any brand. Every brand is good, but the best, that what you all look for. So you have a choice now to go for the best, which you always look for your patients, to for the best. So new gel, that's our new generation antacid gel, available in all pharmacies, OTC. Both are, Nugel and Nugel O. So just to conclude, before I can't stop concluding without our big juice, that's our amino pep, as we all again, worried about the, the pandemic again. So, we have the best immunity for, especially I'm honestly recommending every doctor should have it for personally, because I look every doctor as a warrior. You don't carry a gun, but you carry a stethoscope. That's the difference. You also do the same job like, like a soldier. You protect the community with your stethoscope, and so your immunity is important for your community. If you are good, your community is good. So you have zinc, which is 50 milligram in amino pep, gives a pep to your step, and it has all vitamins, B1, B2, B6, B12, vitamin E, vitamin C, vitamin D. It has calcium, it has protein, everything what you look for is there. So be a winner with amino pep, that can help you to be a winner always. Thank you, Dr. Morgan. That's my presentation. I'll put my number in the chat, WhatsApp number. Any of you need samples of new gel O, amino pep, feel free to just WhatsApp to this number. We'll organize to deliver it to you. Thank you, Dr. Morgan, and please enjoy the rest of the presentation.
Thank you, Mr. Dale, for this new drug that you're introducing us to. Your new gel and new gel O, a third generation stomach medication. And of course, the AminoPep, which is your usual flag holder. You're the one that you always have to push. It is my distinct honor at this point in time to introduce to you Professor Michael Boyne, who is a professor in endocrinology and metabolism and heads the Department of Medicine at the University Hospital of the West Indies. Prof is an honorary consultant also at the University Hospital of the West Indies, and he received his medical degree, the MBBS, from the University of the West Indies. After his residency in internal medicine at the University of Virginia, he completed a clinical research fellowship in endocrinology, diabetes, and metabolism at the Johns Hopkins University School of Medicine. He's a fellow of the Royal Colleges of Physicians of Canada, Edinburgh, and London. He is the immediate past president of the Association of Consultant Physicians of Jamaica. Prof. Boyne is a dedicated Christian. He is also a well-known and popular presenter at our Family Doctor Group conferences over what is now decades, and he continues to share new and exciting perspectives in his area of expertise every time. We can always depend on him, and we are thrilled to have him speak to us and this afternoon on managing diabetes in this time of persisting COVID-19 infections. And it is my pleasure to hand over to you, Professor Michael Boyne.
Thank you, Arna. You're too kind. And thanks again to the CCFP for the invitation to speak again. And always glad to do so when it comes to topics of diabetes and endocrinology. And now with the very topical issue of COVID and diabetes, I'm just going to share my screen. This stage, let me just, okay, so we're going to speak about managing diabetes and COVID infection. And of course, I have to give a little bit of a background before we plunge into some aspects of management. And I just wanted to also just say that I don't have any relevant disclosures for this talk. Now, today in Jamaica should be a pivotal day in that yesterday the mortality from COVID was 2,999. And we might expect that we might surpass 3,000 COVID deaths or deaths attributable to COVID today. And, you know, that's a lot, unfortunately, of souls who have been lost. And I also think that we should also remember that worldwide, there's about 6 million persons who have died from COVID. However, all of these are thought to be underestimates, and actually that the worldwide figure might be even closer to 15 million people, because we know that there's some undercounting, as well as there are persons who die also indirectly from COVID. So in our region of Latin America and the Caribbean, it's thought that the mortality is actually 2.86 times, just call it 3 times what is expected. So for us in Jamaica, that would, if true, would be about 3,000 deaths. Sorry, 9,000 deaths that we may attribute to COVID. So that's a staggering number for us to think about. We're also in a different phase of the epidemic in the sense that now we have the Omicron variant being the predominant variant, and we're getting back into a fifth surge. And just also as a reminder that things that you know very well is that in the older variants, they would enter the cells using the ACE2 receptor, along with another receptor, a protein called TMPRSS2. And basically, the older variants would use these two proteins to gain access into the cell. In the current circulating variant of the Omicron, it does not need TMPRSS2. You can also just do it sufficiently just with the ACE2, and that allows it to infect more readily, and which has led to its becoming predominant and outcompeting the older variants. Luckily for us, so far, this variant has been a little bit milder, but we don't know what the future will hold, and other variants, they could be even more aggressive. So we'll have to see. So we have a large number of persons with diabetes. 1 in every 8 persons in Jamaica has diabetes. And as we now focus about how diabetes interacts with COVID, many times I get this question, are persons who are already known to be diabetic more susceptible to the virus? And we might think so, because from medical school, we were taught about lazy leukocyte syndrome and impaired bactericidal killing. So we know that persons with diabetes have depressed immunity. We also know that persons with diabetes express higher ACE2 levels, so they should be more readily infected by the virus. We also know that hyperglycemia increases the replication of the virus, as well as hyperglycemia also impairs natural killer cell activity. So one would expect from a theoretical basis that diabetic persons should be more susceptible to the virus. However, I caution to say there's no real world data that shows that there's increased susceptibility. So even though we think it should happen, we really don't have data to support that. I have to say it's a bit surprising to me, especially based on some data that we've had before, because if I was to use a slide on the left, and you have to pardon me, because coming from a basic science background, moving on to clinical medicine, I like to show some basic science, but we generally know that like natural killer cell activity also utilizes a lot of glutathione to effect killing of cells. And in persons with diabetes, we had also shown in a publication several years ago that persons with diabetes have lower levels of glutathione and therefore even worse ability to protect themselves from infections in general. One of the things, though, that we noticed is that the low levels of glutathione are more particularly seen in persons who are not just diabetic, but diabetic with complications, whether either microvascular complications or macrovascular complications. And the data that we've had so far hasn't really segregated out whether, they've just said all persons with diabetes, but, on the basis of some data like this, we might want to be more particularly careful about our patients who are not just diabetic, but diabetic and complicated. We also know that once you get SARS-CoV-2, it worsens the diabetic state. So the virus on the left-hand side will use ACE2 along with TMPRSS2 to enter the cell, the beta cell now. So it will infect the beta cell directly. And when it infects the beta cell, it's going to increase MAP kinase signaling, which is going to lead to apoptosis and death of the beta cell. It can also have a change in the stress response, which allows the beta cell to transdifferentiate. So it no longer makes insulin, but it might make glucagon and less insulin. So you have less beta cells, and the cells that you have don't work as well. So we will anticipate that your blood sugar levels will rise. And SARS-CoV also causes an increase in insulin resistance. So you have less insulin production, more insulin resistance, you get hyperglycemia, getting out of control. And hyperglycemia, as we'll also see in a little while, will also worsen the overall infection. As well as also, the virus infects not only the beta cell, but other aspects of brain, muscle, fat cells, inflammatory cells, all of which also promote hyperglycemic states. Now, rather than show you a lot of studies that shows that persons with diabetes have poor outcomes, we're just going to take it as a blanket statement. And in this meta-analysis where they looked at it with many studies, they're able to show that high blood glucose levels on admission is a predictor of bad outcomes, either severe increased need for oxygen, critical illness, admission to ICU, and death. And especially if that blood glucose is more than 10 millimoles per liter on admission, the risk is higher. And of course, there are other things, so age, as well as also chronic kidney disease or heart disease, we heard from Dr. Ho-Sang before, etc. All these are going to worsen your prognosis. And if you're using insulin, insulin generally is a marker of persons who have more severe diabetes, and that too, of course, is a predictor of worse outcomes. Now, persons with diabetes act older when they get COVID. Well, they act older in general. Think of it almost like advanced aging. But we speak about like sort of COVID age. And in several studies, what they're trying to show in this complicated slide, but I won't bother to go into too much, apart from maybe just highlight the table towards the bottom. If you are 30 years old and you have diabetes, you don't act like a 30-year-old person who has COVID. You act as if you were 54 years old. If you're 40 years old, diabetic, and you get COVID, you act as if you're 60 years old. So your risk is increased also just by this sort of the way you act biologically. And therefore, we should prioritize our persons with diabetes for vaccination. And it should be vaccine, vaccine, vaccine is our talk to our patients. And I just want to let this group also know that the human response of diabetic patients to the vaccine is very similar to a non-diabetic person. So they act the same way. The vaccine is effective. So we should prioritize that. Now, how does diabetes make COVID-19 outcomes worse? Well, as in this slide, we're trying to show that it increases inflammation, it increases natural killer cell activity. Now, this can affect directly the lungs and cause acute lung damage and ARDS. There's an increase in also reactive oxygen species, so oxidative stress goes up. That can also damage the lungs, can also cause insulin resistance. It activates the RAS system and you get more angiotensin 2, which can also cause vascular damage. It also activates fibrinogen and D-dimer, increasing blood viscosity. And so therefore you get a wide variety of cardiovascular events, thromboembolism, and unfortunately, the risk of death. This slide is also trying to show it in a slightly different way. If you don't want to think about all the molecular things, you're going to get glucotoxicity, very high levels of glucose. You're going to get endothelial damage, oxidative stress, damaging your vital organs, increasing thromboembolic risk, and therefore causing increased mortality and death. Now, diabetes and obesity coexist many times. And so sometimes it's hard to piece out what is also the contribution of obesity versus diabetes. Because at least 80% of persons with diabetes have an elevated BMI. But persons who are obese actually express more ACE2 and therefore more potential for entry of the virus into the cell. And in this slide, what they're trying to show is that if you look at subcutaneous fat, the fat that you see underneath the face and the arms, upper limbs, that doesn't have as much ACE2 expression. But visceral fat, as exemplified by within the abdomen, in the liver, around the muscle, that expresses high levels of ACE2. So basically persons with obesity express more ACE2 and therefore can have a higher viral load. This is some data from Tamara Thompson and researchers in the Department of Medicine in a preprint. And it showed that in Jamaican patients here at the University Hospital, if you're obese, your chance of being critically ill or dying was more than double. And that effect also overwhelms some of the effects that we even see for diabetes and hypertension, etc. So being obese is not good, as you know. And obesity, along with diabetes, creates various problems. So your respiratory reserve is reduced. You're not able to have as much expiratory flow, gas exchanges decrease. You may even have pre-existing obstructive sleep apnea. Persons may have other comorbidities, and inclusive of the diabetes, inclusive of hypertension, also low levels of vitamin D. As we mentioned, being obese means that you have a potential more viral shedding, more viral load. And and we know obesity, like diabetes, is a chronic inflammatory state. So all of this works together to create the perfect storm. And unfortunately, the perfect storm in this case is a cytokine storm leading to poor outcomes. And so if you're obese and diabetic, you are going to have lots of problems with COVID. Acute kidney injury, ARDS. We heard about autonomic dysfunction, myocarditis we heard about, pneumonia, stroke, thromboembolism, vasculitis. And there are various therapeutic strategies now to try and rescue these persons, but we don't want to rescue the perishing when we could try to prevent them from perishing. But we do have various new antibody-related technologies. Not all of them are available in Jamaica. Dexamethasone is a standard therapy, which, as we also know, can worsen glucose control. Remdesivir, etc. And all these we use in an attempt for the persons who are now with severe COVID and at risk of critical illness and death in an attempt to preserve them. So how do we manage diabetes in the times of a COVID pandemic? Well, there's been a rise of telemedicine, and some of you here might be practicing this. You may be in communication with some of your patients, especially some of the elderly patients, utilizing a variety of social media, WhatsApp groups, etc. There's also the rise, mostly in the northern countries, of continuous glucose monitoring. We don't have that here, unfortunately. One or two patients may go overseas and bring it, but that really does help because at least you can download data and electronically transmit it and help people to get a concept of how they're doing in the home setting. And we can only hope and pray that also, although expensive, that CGM may one day also be available in the Caribbean. So we know that having an elevated fasting plasma glucose or elevated A1C, or if your mean blood glucose based on finger sticks predicts worse outcomes and death. But does lowering glucose improve outcomes? And I have to say that we don't really have hard and fast data that says when you lower the blood glucose in someone who has COVID infection, that you improve the outcomes. We know the opposite is true, but does lowering it? We have less data. However, it makes good sense. And it makes good sense because in other diseases, we do know that getting persons out of significant hyperglycemia into more modest levels of blood glucose does have a spin-off positive effect. So we do it. So persons are always asking, so what drugs should I use? You know, which anti-diabetic agents are the best agents to use? Well, metformin has been our workhorse over the years. And metformin in some databases does seem to have a protective effect. So what I'm speaking about now are persons who were on metformin before for their diabetes and then got COVID. And we can see here highlighted in red that metformin, persons who are on metformin did better. They had a 76% reduction in mortality in this study of 25,000 individuals. So metformin itself might be useful to have on board. And yet another reason why we may like metformin. Now, of course, this is not a randomized clinical trial. This is observational data. So we know it has, it's not perfect data. And various persons have mentioned that different drugs that we use for diabetes control may theoretically improve aspects of the dysmetabolism that occurs during COVID. So take, for example, we see here, when you look at what can it theoretically improve on in persons who are critically ill, those which have anti-inflammatory effects, those which may have help on the lungs, those which have cardiovascular improvement, those which can maybe somehow directly help COVID itself. And so metformin may directly improve COVID outcomes. And it was also thought that maybe also DPP-4 inhibitors, because DPP-4 is upregulated in COVID. And DPP-4 is used as an entry point also to get into the cells, just like how we have ACE2. So there's a lot of interest about DPP-4 inhibitors. So as you can see here, there's also pioglitazone and SGLT2 inhibitors, and some of these may have theoretical effects in different areas. Now, how well do they really work? And that's a lot of controversy. But here's some recent data that came out. And what we saw for the most part is that several of them seem to have done very, very well. Metformin was still significantly a good guy in helping to prevent bad outcomes in persons with COVID. SGLT2 inhibitors was also good. Sulfonylureas in mild disease may have also not been too bad at all. Insulin, not so good. But the thinking there is that insulin is a mark of persons who already had severe. Those persons, when you adjust for how bad their diabetes was, you see that it's not that insulin itself was the factor. But DPP-4 inhibitors didn't come out as well as expected from the theoretical data, although DPP-4 inhibitors have been shown to be useful in persons when they have been known to be have infection or been in the hospital. So many of the drugs actually do seem to help outcomes if they were on them before they got infected. But as the disease becomes more severe, you have to change. You have to be flexible and adapt. So when the disease is less severe, you can use almost anything to try and help control their diabetes. As it becomes more severe, if they've had already pre-existing heart disease or kidney disease, SGLT2 inhibitors and GLP-1 and insulin are useful. We don't have that much GLP-1 receptor agonists here in Jamaica. We have a lot of SGLT2s. But then as it becomes very severe, you need to up the game and go to insulin in your more severe cases. Now, here's a slide that you might find useful. So in this one here, we're trying to see how should you select your drugs during the course of the disease. So we're moving from when you're relatively uninfected in the upper left-hand corner, where you can use almost anything, to when you have mild ambulatory disease, to when you have more moderate disease and you might be hospitalized, to when you are actually hospitalized with severe disease and maybe even admitted to the intensive care unit. So let's go to the second column, ambulatory mild disease. So if you have ambulatory mild disease, then insulin, DPP-4 inhibitors, metformin, and GLP-1 analogs are good drugs to use. You can use other agents such as sulfonylureas, SGLT2 inhibitors, pioglitazone, and acarbose. Might have to use them with a little more caution, and they may not be as great, but you can use them. When they become hospitalized, though, you need to, again, change the game. Because when persons become hospitalized, thiazolidinediones such as pioglitazone and SGLT2 inhibitors may not be the best agents. And why might that be so? Well, let me just see if I get this. Because SGLT2 inhibitors can promote osmotic diuresis and promote dehydration. Their effect is limited when you have reduced glomerular filtration rates And you may also get the phenomenon of what we call euglycemic ketoacidosis. So we're not big fans of, in the hospitalized patient, utilizing SGLT2 inhibitors. And pioglitazone, there's limited data in the hospitalized patient, outpatient data, but limited data on the inpatient side. We don't like to use sulfonylureas in hospitalized patients because the beta cell function is very bad at that stage and it don't seem to work very well at all. Now, once they become critically ill, insulin really takes over, is a main game. And DPP-4 inhibitors can be used as insulin sparing effects. And as we mentioned, sulfonylureas, type 2, pioglitazone SGLT2 inhibitors really should not be used much at all. And things like metformin and alpha glucosidase inhibitors, you can use, but you have to be careful, especially if there's lactic acidosis already existing because of hypoperfusion. You may want to be a little bit more careful about using metformin in those situations. Now, a lot of persons also can slip into diabetic ketoacidosis or hyperosmolar comas. Very easy to do when they get infected. And this data shows that when persons develop DKA or hyperosmolar, when they have COVID, their mortality skyrockets. Their mortality is more than 6-fold greater. They have tremendous high insulin requirements because of the very poor beta cell function, the high insulin resistance, and also many times we're giving them dexamethasone or other steroids as part of their COVID management. We need to give them insulin even longer, and it takes longer for them to settle down. So the presence of DKA or hyperosmolar really makes a big difference. Now, for the interested family doctor, you can write down this reference that you have right here. It's a very short 2- or 3-page article, Diabetic Medicine 2021. Write down the numbers if you want to look this up afterwards. Because I'm going to show you a couple of tables, but I know you can't digest it in this talk. But a person now who is diabetic and is COVID positive, and they call you and they may or may not need hospitalization. What should you be doing? Well, guess what? Fluids. Cannot overemphasize the relevance of preventing them from getting dehydrated. Tank them up. Monitor their blood sugars at minimum every 6 hours. You should rule out DK or hyperosmolar. You can get a urinary electrolyte, UNEs. Make sure that their bicarb is normal, their sodium is normal, get their random blood glucose. You do a urine analysis, see if there's any ketones. If you have access to venous or arterial blood gas, that's also great. The target, as you think about if they're on oral agents, you want to, or even on insulin, you want to kind of keep them below 10. That's your target, keep them below 10. But if they're going above 12, you may need to insulinize them if they're not insulinized. So this table here is really just some of the table that how you can correct their blood glucose using rapid acting insulin, right? So Lispro as Humalog, or if you're not able to use rapid acting insulins, Humalog, Pedra, use regular insulin, what you call soluble insulin. And the table tells you how much you adjust by whether you are, how high is your blood glucose, whether or not you are light in weight, or whether or not you're using a high dose of insulin before this time. And also make sure they're not getting ketotic, okay? If they've never been on insulin before, you can start them with some NPH. And if they're elderly, you might, or having stage 4 CKD, you may want to cut the dose back. And you can increase the NPH or basal insulin by about 20% and titrate as necessary, as you see on the slide. When you're getting ready to discharge them, or they're over their infection, if you're stopping the steroids, you need to rapidly cut down their insulin dose. If they were normal glycemic, not diabetic before, they may not need ongoing diabetes therapy, but screen them because they're at high risk of developing diabetes later on. And what happens after the COVID infection? Does pre-existing diabetes increase the risk of long COVID syndrome? Well, some studies say no, some studies say yes, so we don't really know. But what I would like you to realize, because many persons who have had COVID and were not diabetic before, 3 months later, there's a 28% increased risk of new diabetes, which could mimic some of the symptoms of long COVID syndrome. And up to 1 year later, 40% of persons have an increased risk of type 2 diabetes. So unrecognized diabetes is common after COVID. So here's my last slide. This slide here I showed, I think, at a CCFP conference last year or 2 years ago, and it's changed a little bit. The big change, of course, is vaccination. And what I tell my patients is that you need to have full vaccination, not vaccination and booster. In my mind, full vaccination is a 3-shot course. You need 3. A booster gives them the impression that they have an option. I said, no, you're high risk, you're diabetic. Full vaccination for you means you have 3 shots. Get that into your head, 3 shots. And of course, we can utilize ways to improve our access to patients in terms of telemedicine and other ways. We need to be careful about our high-risk patients, especially the elderly patient. We need to make sure they have enough medication. We need to try to avoid hypoglycemia. We need to allow them to monitor and get back to us with that. We need to look at their psychological health, and we need to look at their overall aspects of how they get their medications, how they exercise, their meal plans during these time periods, etc. So it is, as family physicians, I know you do all of these things very, very well. So thank you for your attention. I hope this has been some benefit.
Professor Boyne, it has been our pleasure to listen to you this morning. You have shared so much on the management of the diabetic in the times of COVID. All of us would have thought that being diabetic would definitely increase your risk. So this is something to know, that that's not the point, but that if they do get COVID, then there's a lot happening. And if they are COVID, and if they're diabetic with obesity, Lord help them, right?
That's right, that's
so,
right.
We just want to thank you for imparting all of this information. There's such a variety of cardiovascular pathology occurring in the diabetic with COVID disease. And we just want to also remind everybody what Prof has told us. 3 vaccinations is what makes you fully vaccinated. There are a lot of people out there who have stopped at the 2nd and are not boosting. And I think we all, doctors here, need to push that as a slogan. 3 vaccinations is what is fully vaccinated. So thank you very much, Prof. I'd like us to go immediately into the Q&A now. Any questions? Oh, Dr. Dawson is here.
Yes,
okay.
I am.
Wow. All right, so we'll hold the Q&A for the end as Dr. Dawson is with us. Well, thank you, Prof. And we will go straight to Dr. Dawson's segment, her presentation. And after that, we will take the Q&As. Dr. Paula Dawson is a consultant, is it a psychiatrist? Physiatrist, right?
Yes.
Right, and a lecturer with the University of the West Indies. She's also an interventional spine and sports medicine physician with the University Hospital, and she's a medical director of Rehabilitation Institute of the Caribbean. She's a co-founder of the University of the West Indies Sports Medicine Clinic and is a university examiner in the Masters of Science degree in sports medicine for both doctors and physical therapists. And she has treated many professional athletes and often travels with them, lucky her. And Dr. Dawson is the only physician in Jamaica who is board certified in psychiatry, physical medicine, and rehabilitation. After graduating from the Faculty of Medicine at the university, she subsequently attended the Albert Einstein College of Medicine, where she completed her residency in physical medicine and rehabilitation. She later completed her fellowship in interventional, spine, musculoskeletal, and sports medicine rehabilitation at Northwestern University in Chicago. So Dr. Dawson has received many numerous accolades which speak to her outstanding contributions as a woman. She has been lauded locally and internationally as an outstanding Jamaican woman and is a Caribbean icon. And most importantly, Dr. Dawson is a born-again Christian and gospel vocalist who, we thank God, has chosen to come on with us today. And I know she has left some of her Christian fellowship to be with us. And we can only thank you so very much, Dr. Dawson, for choosing to participate and present to us today. We look forward to hearing from you on ergonomics in the 21st century, fitting the job to the man rather than the man to the job. Dr. Dawson, please go ahead.
Good morning. Good morning. Thank you very much for having me. It's a privilege and an honor to be here presenting at the World Family Doctor Conference this year. And I'd like to thank all the organizers for inviting me. So today I'm going to present on ergonomics in 21st century, fit the job to the man rather than the man to the job. And I just always like to start all my presentations with talking about what a physiatrist is, what is physical medicine rehab. A lot of people tend not to understand it. Even my very close friends don't. So we are physicians of function. So it's a field of medicine. The general field of medicine has added years to people's lives. The practitioners, the surgeons, the neurosurgeons, by managing a patient's illness, you add years to those lives. But many times those patients may have dysfunction, and PMR, us as physiatrists, we strive to add quality to those years along with the rehab team. It's an area of medicine that was established since 1921 out of World War I. And in 1952, when we had the polio pandemic, it changed PMR from a military to a specialized area where civilians were allowed to enter. And so I always start my presentation by saying Sir John Golden, he is the father of rehabilitation in Jamaica. Even though I'm the only physiatrist, the first one, and the only one who's been here for the last 12 years, he is indeed the father of rehabilitation. Many of you will know him. He was appointed an orthopedic surgeon at the University College UC, and then became was anointed, and he is the founder of Sir John Golden Rehab Center, which we affectionately call Mona Rehab. What's the difference between a physiatrist and a neurologist? Many people ask. A neurologist will evaluate and perform a directed and detailed examination just like a physiatrist, but they identify impairments that give a clue to the location of the lesions within the nervous system, and then develop a differential diagnosis and the treatment plan. So they look mostly at the location of the lesions. Where us as physiatrists, we do the same thing. We perform a directed and detailed exam, but we look more for functional deficits. We try to identify impairments, and then our treatment of care is around functional recovery. And so we're going to talk about ergonomics. Now, I like to always start with a little bit of history. Who and where did this term, who coined this term? Where did this term ergonomics came from? So when you look in when you do your research, you'll find that they have two forefathers, and they say there are two people who actually started it. And it depends on which literature you look at. It was attributed to a Polish called Jastrowski in 1857, but he outlined the ergonomics with the science of work. And Murrell, round about when World War II was happening. Again, similar to physiatry, it kind of started when they had to do the science around aircraft cockpits, and planes were crashing because they got confused in their workstations. And so they tried to fit the workstation to the pilot. And that is where ergonomics came about. So the basic idea is to design tools and procedures that create a more productive and less strain on the workforce now, but then it was more for safety. And the thing is, there's an evolution, as you can see, or is there, they would say. First, you start off with, man walking further down, closer to the ground, and then we became upright. Now we're back at the computer, but we're evolving again, because we have said now you should be having standing desk, right? And so these are the pictures of, this is a picture of the Polish Dysautonomia. All right, so I'll proceed. So now, what is ergonomics? Well, ergonomics comes from a Greek word, ergo, work or labor, and nomos, which is law. So it's the science concerned with the problem of how to fit the workstation to humans' anatomy and their physiology and psychological profile. And why do we do that? Because we want them to be efficient. We want to enhance their health. We want to make sure mentally they're good, and physically they're well as well. So it's designing a job to fit the worker so that the work is safer and more effective. It's not only to treat the design of the furniture. A lot of people think ergonomics is just the design of the furniture. No, it's also the physiological and the psychological aspect of it as well. So where and how do we work? So ergonomics originally, now when we think of ergonomics, we think about ergonomics primarily to do with the office desk and computer, but it actually has to do with everywhere you work. And I like this diagram because when you have human factors, whether it's the person, you have a machine that the person is using, whether it's a computer or the cockpit, and you want to make sure the task is efficiently done. So the intersection of all three, where human factors are considered, the ability of the machine is considered, and the task design is made a priority, then you get perfect ergonomics. Outside of that, you're not getting perfect ergonomics. So that's essentially what ergonomics is about. So why is it important? Well, implementing ergonomic solution can make your employees more comfortable and of course increase productivity. And at the end of the day, you really want your employees to be able to produce more so that you as a company can be more profitable. At the same time, you want to avoid causing any health risk to them. You want to avoid the risk of musculoskeletal discomfort because once you're sitting at your desk 1 hour per day, it increases musculoskeletal problems. Your risk is 9 times greater when you use the computer, the desk, 4 hours per day. And a lot of us, especially now since COVID, we use a computer more than 4 hours per day. Not only is it the duration of time that you're sitting at the computer, but the workstation has to be appropriately arranged so that it doesn't lead to any injury or cause any decrease in your productivity. So where are we working now? Back in 1984, only 25% of all workers use computers. In 2008, this is in the United States, 90% of all US workers use a computer. 40 are on the computer up to 4 hours per day. But now where are we working? We're working at home. And since the pandemic, more people are known to be working from home. And the question is, are they working in an office setting, or are they using the kitchen counter or the dining table with a dining chair which doesn't have any wheels, which doesn't have any lumbar support or arm support? You know, the dining table is usually higher than a desk chair. And so the desk chair will allow you to sit in a particular position so that you're able to be more efficient. Now, what are we using for work? In addition to computers, we are now using cell phones. We're using tablets. And so we're going to have to find an ergonomic setup where, you know, our patients are able to work efficiently and safely. So more statistics. Musculoskeletal disorders are 1/3 of all occupational injuries and illnesses. Not necessarily, you would expect that if it's occupational, it might be, you know, trauma or accident at the workplace. No, 33% is musculoskeletal disorder. And that means that it can be prevented if we are able to put or institute ways to avoid these problems. In 1997, there were over 600,000 lost work days. This is in the United States. And carpal tunnel syndrome, I know a lot of patients complain of that, which is the pain in their hand, more so the thumb and the 3.5 fingers, half of the ring fingers, which is the median nerve. That is where you have patients getting the highest median number of days off from work. And millions, actually billions of dollars are spent on workman's compensation claims. Now, what are the risk factors? Well, there are general ones. There's a force, meaning how, how hard you have to work, the duration, how long, duration and intensity, very important. And one of the culprits is repetition and frequency without breaks. Workstation designs, we're going to talk about that. Organization, which is, can be structural organizations in the office. The environment, mechanical stress, awkward positions. Sometimes our workers are forced to work in little tiny positions or in a position where it's twisted or not ideal for their body. Now that they're at home, they're in the couch, they're in the bed, they're in the lazy boy, not efficient for the spine or the neck or even the other joints. Lifting, if it's lifting that you do, satisfaction plays a major part in productivity and injury. I have found as a rehab doctor that if someone loves their job, their discomfort will not be as, I don't want to say sensationalized, but as prominent to them because the satisfaction of the job tends to have a psychological impact on their perception of the pain. And of course, the posture, right? So now let's talk about the force. How much pressure is applied or transmitted through your body as you work? And so, for example, something as simple as, and we're not even going to look at manual labor, we're looking at you sitting down. So you're sitting, what force, and the next slide is going to talk about that, what force is transmitted through your spine and on your neck? Now, for those people who are doing manual labor, manual handling weight, depending on your height, as you can see from this diagram, the higher you go off, ground level, and the further away from the body you go, you'll tend to have more force, which is why if you're going to be carrying something, carry it closer to your body. And it's different for men and women, likely because of the height and the muscle bulk that they have. Higher prevalence of carpal tunnel syndrome noted in jobs that are highly repetitive. They're always at the computer. And it's not just the computer, it can be painting as well. Someone who uses a lot of stroke, writing as well. And another type of repetitive overuse injury that we see is tendonitis. And the tendonitis can be in different parts of the body. I've seen tendonitis in the foot because of how the person sits at a desk and swivel themselves from side to side. So the incidence of tendonitis is 29 times higher in highly forceful and repetitive jobs. So usually when a patient goes back to work, one of the things we ask them to do is to avoid repetitive bending and lifting. We usually put a limit, and I'll come to the limit of the weight, poundage weight that we usually recommend. So we have to be mindful of other forces as well that may affect your different parts of your body, your wrist, your elbows, your knees, and even your ankles. You have some patients when they sit at a computer, one leg is bent under the body and they come with ankle pain and they're like, I didn't go running, and you're wondering why are they having lateral anterior talar fibular ligament strain, and it's because of the position sometimes where they sit at the desk. Duration and intensity. Computer, now this is what we're using now, tablets, iPads, cell phone, make it very easy for workers to get lost in what they're doing without taking a break. I know some people are social media specialists. And that is a job where you're supposed to, do social media work. I mean, sometimes I encourage my medical officers not to be on Instagram. I mean, I am on Instagram and primarily for the news. I have the major newspapers and online media houses, and you can get sucked in. Before you know it, you're on the phone for over an hour. Your eyes start hurting. So it's not just musculoskeletal, you can get visual issues as well. So we must establish reminders for rest break at least every 20 minutes or up to once an hour. Repetitive and frequency. Computer work is very repetitive in nature. You're typing, you're sitting there. Studies have shown that force and repetition are among the most important task variables that will lead to musculoskeletal injury when you're sedentary. So you can get injury to your neck, your wrists, almost every joint in the upper body as well as the lower body. So let's talk about workstation design. So the workstation design is the driving force behind ergonomics, whether it's a workstation if you're working at a computer, if you are a doctor working in an operating theater, you know, if you are a painter, you know, the solutions are variable and endless. But essentially, you have to establish a workstation that will, one, consider the body, the patient's ability, the patient's physical, the tasks to be done, and the machines to be used, whether it's the tools to be used or not. That is what efficient ergonomics is all about. And of course, ultimately, you want the worker's productivity to improve, and it is directly affected by the comfort and the ease of the design. So the patient has to be comfortable. So let's look at the environment now. What do you look for? Some simple things are important. You're at home, normally you're in an office that has air conditioning. Now you're, unfortunately, the summer is coming and we know how hot it can be. We know the cost for electric bill. Some of us don't have air conditioning units, and even if we do, it's expensive. And so you have to make sure where you're working is comfortable for productivity to be at its best, and also for your comfort, because when you're uncomfortable, you tend to have more discomfort in many ways. So you must be comfortable. It shouldn't be too cold or too hot. Lighting has to be adequate. Why? Because you may strain your eye or you may just get physical injury. You can't have too much noise. The sound has to be, you know, at a level where you're able to concentrate. The size of your workspace, you don't want the workspace to be clustered. You can barely sit at, believe it or not, this is a desk to the bottom right. There's a computer buried under and in between those papers, and the hard drive is on the floor. And so the furniture is going to be very important that you use. Then you have mechanical stressors. Outside of the workstation, mechanical stressors, how you sit, what you sit on. There was an age when people were sitting on these Swiss balls. You know, we now know that this is definitely how, the bottom right hand picture, this is definitely not how you should be sitting. You know, if you stand for work on a standing desk, or if you stand to teach, or if you stand to operate, or if you stand to see patients, examine the patients on your table, your patients are coming to you, depending on the type of work that they do, you have to, review with them the mechanical stresses that may be present. Lifting, how they lift, how they twist, wrist and hand position when you're doing these activity, because awkward positions and awkward posture can lead to more injuries. Now, let's talk about awkward positions. So some people will have some interesting places to have desks, and you see from these pictures on the bottom right-hand corner, you see some people will utilize all the spaces in the house and they'll put an office on a staircase. You know, while this is cute, you know, this can cause injury to your head. You know, you're not able to stretch your legs out if you need to stretch your legs out. And as cute as the picture in the middle looks, it's a chair that doesn't have wheels. It doesn't have an armrest. And I'm going to go through an ideal chair setup so that you will be able to see. Now, twisting, slump sit, and bending are some of the things that you want to certainly avoid. You're reaching for the mouse or on a keypad constantly, the keyboard. You always have to ensure that things are set up properly. You want to cradle your phone if you have to, rather than, you know, putting the phone, sticking it by your ear. You want to avoid crossing your legs and leaning onto sharp edges. These are awkward positions that you have to avoid. Now, lifting, for those people who do lifting jobs, it's always important. We always tell them about lifting. You know, you bend your knees, not your back, keep the weight close to your body. But if someone is doing repetitive lifting, it's always better to ask for help if needed and if available. And they should always maintain a neutral spine as much as possible, because the spine is most vulnerable when it's flexed and turned, twisted to one side. So torsion of the spine. So the spine is made to go in a sagittal plane relatively efficiently. But when you flex and twist, which is torsion, that is when you can have injury to the disc. That's when the discs are at their weakest and you can get back issues, disc herniation from that. So satisfaction, once they're satisfied, you'll get productivity, you get good productivities. Workers may complain that employers are not concerned with their individual well-being. A lot of the times patients will come to us, and I'm sure everyone here, and ask for a letter to go to my employer to get a desk or to get a chair. And sometimes I don't necessarily commit them to that, because I first want to educate them as to how to sit, because the best chair can be sit in an improper way. And so first we teach them proper sitting, and then we encourage them to get a chair. And I'll explain to you the ideal setup for a chair. Now, if you look at this picture, the sitting posture, you want to make sure the spine is in neutral. Where is the spine? Tips for achieving a neutral spine: sit down twice. They always say that. Can you really do that? Where is your head? Where's your shoulder blade? Is it touching the back of the chair? You don't want this. You as much as possible, you want to keep a neutral spine at the bottom right-hand corner. You can see when you slouch forward, there's more pressure by virtue of the vector and the gravity that is acting down, along the spine. You'll have more pain when you slouch. And then the more pressure will cause myofascial discomfort, as opposed to 12 pounds that are, your head is about 10 to 12 pounds. And so if it's in a neutral spine, you tend to put 10 to 12 pounds down on your spine. But once you lean forward, that 12 pounds is multiplied by probably the 3 inches or 3 times as a factor to multiply to cause the pressure here. So you use the vector of force that we're using here. Here's another diagram on your left-hand side looking at the pressure posture in your lower back. So when you're standing, using standing as 100%, so the effects of pressure going down once you're sitting at 110 degrees, you're going to put more pressure. Believe it or not, some people say, no, man, when I lean back, I'm more comfortable. No, it's just that the pressure is not going forward like here. The pressure is going backwards. So this is not ideal. A neutral spine is always ideal, right? You try to maintain a neutral spine. And as you go forward, as you see, you get more disc pressure developing, all right? More disc pressure developing. Now, some people say, well, I only use my phone and I use it in a lazy boy. I'm sorry, that is the same issue. With a smartphone, it can also cause stiffening in our necks because it applies so much pressure when we tilt our head down. These two pictures are basically the same, but I just wanted to bring both of them. So when it's neutral degrees, just the weight of the head, which is about 10 to 12 pounds. When you go 15 degrees, 27 pounds. When you're going 30 degrees, 40 pounds. The further forward you go, the more pound you're pressing down on your spine. And so the forces in the neck increases the more we tilt our head forward. And this can cause spine curvature, can cause kyphosis as well. So what are we looking for? Well, sitting posture. Ears over shoulder. You want your ears to be over your shoulder. Your shoulder should be down and back and relaxed, right? This chair is a little bit short. I would prefer a chair that comes up to the shoulder blade. But I like this diagram because it's very descriptive. You have viewing distance. You have the about 19 to 24 inches. The viewing angle. Most of the computer monitor is more or less at eye level. The elbow is supposed to be at 90 degrees. Your hip is supposed to be at 90 degrees. Your knee is also at 90 degrees. And your feet should be comfortably flat on the ground or on a footrest as well. It's good to have an adjustable seat because some people are taller than others. And so when you're sitting, if you're too tall, you'll have to bend your knees behind you, or if you're too short, your knees will be dangling. And so ideally, you would want to be able to have your knee at 90 degrees. So an adjustable chair is very good to have. An armrest should be there because when you have an armrest, it kind of takes the pressure off your lumbar spine as well. And the lumbar support should be there. So shoulders over hips, that means 90 degrees. Pull your stomach in, hips and knees are level. Your hips and knees are level, which is why it's going to be 90 degrees. Knees over the ankle, which is there's a straight line going down, and feet flat on the floor or on a footrest. And so standing posture, some people now are working on standing desk. And so it's good to stand straight up, not forward, leaning over, because the more you lean forward, the more pressure, literally pressure, you will have exerting across the intervertebral disc, right? So tips for standing with a neutral spine: don't go like you're sipping water. Think tall and your chest proud. And so this is a picture showing the wrong sitting, correct sitting, and correct standing. Now, standing posture checklist. So here we go. Now, back in the day when standing desks first came about, they were like over $1,500, and then they were mostly mechanical or hydraulic. But now you can buy a standing desk converter, which is a platform which you can buy on Amazon. They range anywhere between $60 to $500, even $1,000. You can choose one that can hold 1 monitor, 2 monitor, or just the laptop alone. And you can put it on your desk. You can carry it in your bag from home to work, and it works quite as well as these more expensive hydraulic desks. So ears over shoulder, make sure your shoulders are even. Shoulders over your hip. This guy is standing straight, the stomach in, hip over your knees. So you're looking for a neutral spine all the way down from the tragus, which is right anterior to the ear. You can drop a plumb line, a nice neutral spine. Knees straight and unlocked. Feet shoulder width apart, and have even weight on both feet. Now, some people will tell you get a foam mat. You don't have to buy all these expensive, elaborate looking ones that you see on Amazon. What I always tell my patients, you can go to PriceSmart or Super Value. Those same little foam mats you see the cashier standing on, those are the mats that we recommend. And they're the same mats that some people will have in their kitchen as well. Now, the question is, there's a time when treadmill desks was in vogue and people were having walk-in meetings. There are meetings that you actually walk along the corridor and you try and keep up. But, this is a walking standing desk meeting on the right. And here's another standing desk with the hydraulics to match the height, because not everyone is the same height, right? Almost finished. All right, so this is not what you want. No matter how exotic it looks or ugly, that's not essentially what you want. You want to avoid being too static. Use specific muscles. You want to make sure that you're not staying in a position too long to get these trigger myofascial knots in the muscle. Motion is lotion. You have to move to move. And if you don't move, you won't move. So muscle contracts and stays contracted if you're in a sustained position. You get an energy crisis, which is essentially what happens in these trigger points, because you have continuous contraction, you occlude the micro capillaries going in, and then you have ischemia in the tissue, not enough oxygen, you get scar tissue, and that's how you develop a trigger point. We can always inject those and break them down with lidocaine and steroid. Dynamic work is always good. You're using the general muscle groups. Muscles are changing positions. Muscles contract and relax. That's what you want. Blood flow freely to the muscles. Muscle receive oxygen, and you can have multiple working positions. People always ask me, what is the best chair? Well, a best chair is one that you sit in and you feel comfortable. One, you must make sure you can adjust the height to your knee is 90 degrees. So you don't want it too high or too low. You want one where you can recline if you want, but at the same time, you can lock the chair. You want an armrest as well. Headrest is not essential. And this diagram shows an evolution of office chairs from 1938 to now. You have gaming chairs. It's in 2021, and gaming chairs are these people who sit and the computer all day long. They have their laptop and their phone, so they're always on the computer. There's a thing where people are trying to work in a reclined position. You can see this human office setup where they say ergo human is effective. I don't believe so, because it puts pressure on the spine. Essentially, you must have your stretch break. Now you have two jobs. A lot of people working from home. They have the work that you're being paid for and the work that is rewarding with other payment of having children or loved ones at home. Keyboards, many designs, just get something that feels comfortable. What I recommend though are these, which are the rests. Essentially, when you have a mouse or a keyboard without a wrist pad, you tend to cause an angulation at your wrist, and you can get carpal tunnel or entrapment of the ulnar nerve in the Guillen's canal. So you just lift the wrist, both when you're on the keyboard as well as when you're using the mouse. Very comfortable, very inexpensive, and they're easily available here in Jamaica. Same thing, you have some people that talk about ergonomic mouse. I have bought an ergonomic mouse before, but didn't find it ideal. I use a regular mouse, but then with my wrist pad, and it made it very, very comfortable for me. People always talk about seating cushions. This cushion is from Relax the Back. Why I like it is everybody's body is different. Everybody has a different shape in the lower lumbar spine. This is a valved lumbar support, and I like it because it's self-inflating and you can adjust it to your to your own body design. And it is 40 US. I bought one in 2008 and it's still 40 US. The best $40 I've ever spent, and it still works. So office assessments are done by physical therapists. We usually recommend patients, if they have a need for ergonomic evaluation at home, we usually ask them first to just take pictures and let us see, have someone take their pictures when they're not looking, because they'll pose. But you can have physical therapists going. They're the ones who do the consultation and make the recommendation. In this case, it's the occupational therapy, but we only have about 2 occupational therapists in Jamaica. So our physical therapists are well trained to do this ergonomic assessment. So the proper chair fit, similar to what I said before. Just make sure you have lumbar support. It's not too high, not too low. You can adjust it. You can block the back from going back into too much of a recline, and then it can be very comfortable for you. So same thing I said about the mouse, I'll just go through that. This is a summary slide, and I put this in, so if you want the lecture, you can certainly get a copy, and I'll send it to the organizers of this conference. And my penultimate slide, I believe, I always tell people you must take a stretch break. You have to take a break. You shouldn't sit on a computer. This is an easily downloadable Word document. You can print it, you can give it to the patient. All of this exercise on the left is about 2 minutes. Or you can download Stretch Break app on your phone or on your computer. And don't forget your eyes, because your eye muscles can get overworked as well. Stretch Break, it has evolved. Back in the day, it looked very weird, like this is the 2.2 version. Now, I printed this yesterday. I mean, it will tell you what to do. So it's something that you download on the computer, and it will break your screen when you're working too long, and it will literally take you through some exercise. Thank you very much for the opportunity to present, and I hope this lecture was useful to everyone.
Dr. Dawson, we thank you very, very much for an excellent presentation. You've introduced to us a new area which is not well known. This whole idea of that our posture is important to our job satisfaction. And yes, investing in a suitable chair is actually going to increase our performance at work. Yeah. And most of us sit, most of us who are doctors and who work in offices, we sit. So this is something new. A chair is an investment in our happiness and our satisfaction at our work, and is something that we all need to have a look at, as well as maybe we need to start walking as soldiers. Straight, watch that back, watch that 90 degree, watch that standing. So we want to just take, Doc, a few questions. I'm going to go over to Sam, who is on the system here now, just to take a couple questions before we hand over to Professor Reed, because this is an area of new and of interest, great interest. Thank you. Sam, go ahead for me, please.
Hi, Dr. Dawson. Thank you so much for your presentation. Dr. Dawkins Ellis is asking, as a member of the dental fraternity, if you could do a demonstration a bit on how a dental operator may sit to avoid back pain.
Wow, that's a big one. I have had this conversation with my own dentist, and I know the dental fraternity, not the fraternity, but you have dental ergonomic workstation that are sold. I hear they're not very, they're quite expensive. how to sit. And I know that's an excellent question, because essentially you're trying to, one, fit the machine, which is the dental chair. Two, the task is to lean over onto a patient and at the same time preserve your health. And your posture is forward flexed. Unless someone is going to design a standing dental chair, which the patients, once they sit on it, is elevated, you know, that might be something worth considering. But yes, the dentists do have an issue because they're one flexed and they're rotated. And so what I will go along with is the many, many studies out there that have been published on the most ideal dental chairs. The manufacturing companies will purport their own product. I'm sure as a dentist you would have seen that, but it is very challenging for dentists, very, very challenging and costly to get the most ideal setup.
Thank you so much. Last question from Dr. Nisha Gibbons. How do we determine how much weight a person can lift once they have had a musculoskeletal injury, especially a back injury?
I love that question. So after they go through rehabilitation, you get the acute rehabilitation, which will, you know, deal with the problem that they're having. Then they will go through work conditioning, which during work conditioning, you know, sometimes a company, if it's a lifting job, the company will send us the job description and we will condition the worker to see if they're able to tolerate. And when they get to a certain amount during the rehab process, then we can write the recommendations, what we have found. However, if it's a patient that lifting is not a part of their job and they don't have a job description, just after the injury, we would usually write no lifting and repetitive bending or twisting of anywhere between 25 to 30 pounds. But that's usually for general patients. Again, if it's a patient where lifting is a part of the job and they need to go through work conditioning and something called work hardening, then the company will send us a job description and we'll do our best to try and condition and harden them for the job.
Thank you.
The link for the cushion is called Relax the Back. That's relaxtheback.com. It's not sold on Amazon, but the company is actually called Relax the Back. They're all over. If you travel, they're all over the United States. You just enter Relax the Back and put in a zip code and they'll tell you where one is. If not, you can order it online. Relax the Back. There you go. .com.
Thank you, Dr. Dawson. I mean, we really need more time. We need to do something like this again. And we really need to get into the questions because people have a lot of questions. This is actually very key to our success and our future and our comfort. So we thank you again. I'd just like to ask Prof. Boyne if there was any burning question that he would like to respond to. We're running late on time, and have to move on. But Prof, is there anything you'd like to answer here at this time?
There were two questions which I wrote an answer to, so they will be in the Q&A. I don't see any other active ones.
All right, thank you very much. At this time, it is my pleasure to I'm thanking both of you for coming here and giving us your time and sharing some absolutely new and provoking ideas and thoughts with us. I'd like to hand over to Professor Marvin Reed, who will be your presenter for the third session. Prof. Reed, over to you.
Thank you, Arno. Colleagues, good afternoon. In keeping with the spirit of the previous session, I'm going to allow you a 15-second break to do a little bit of stretching. Those of us who were watching the video and remembering, you could stretch out your arms, stand up, move around a bit as we prepare our mind for us to go into the other session. So while you're conducting your stretching component, just to remind you that this session 3, is being sponsored by the Heart Foundation of Jamaica, and the first speaker will be from the Heart Foundation. We have 2 speakers scheduled for this session. Dr. Jordan Eaton and Dr. Tusan Livingston. And at this point in time, I will invite the Heart Foundation to do their presentation.
80% of all deaths in Jamaica are as a result of chronic non-communicable diseases like diabetes, hypertension, and cardiovascular diseases.
1 in 8 have diabetes, 1 in 3 have hypertension, and 1 in 2 have been diagnosed as being overweight or obese.
These increasing rates of obesity, overweight, and related NCDs are highly attributed to unhealthy eating practices.
Foods high in salts, unhealthy fats, and sugars can increase your risk of developing NCDs.
Them are very nice and pretty, you know. I think I'll take one for me discussion. I always ask for one. What's one of these orange chips?
You want my chips? My favorite chips.
What kind of chips that?
This, you know, so the other day when we go out of time, tell me say I must cut out the salt.
So, doctor tell you say you must stop eat salt, and you are really take up a bag of chips. Look at the size of the chips too.
So what wrong with the chips?
Look, remember turn around this. Look from here, so now. You see how them bag of number you look there. 1 ounce is a serving and a 10 in a this.
Yeah, so 1 bag of full man.
You notice how much sodium in that 3%. So times that by 10, how much?
More sodium, that is a salt.
Sodium and salt, the same thing, darling.
So that means I'm going to figure
out
how
over here, so look. You realize what I found this?
Oh, this one says high in sodium. But I prefer this is easier to read than the bag of numbers.
Exactly. So basically, this little black label, it actually translates whatever on here, so I make it easier for you to understand. And look there, I want 2 of them at that. I don't trouble that.
Well, we prefer the HFSS brand because it tells me what's exactly in my food.
Alright.
I'm going to do what they say high in sugar.
So water, you take a drink this.
Alright.
As consumers, we need an easier way to identify and make healthier food choices when shopping, as nutrition facts panels can be difficult to understand.
Front of package warning labels make it easier for consumers to identify foods that are high in fats, sugars, and salt so that they can make easier food choices.
A recent study conducted by the Ministry of Health and Wellness Jamaica, the Pan American Health Organization, and the University of Technology Jamaica showed that black octagonal warning labels, when placed on the front of food packages, were the most effective in helping Jamaicans to make more informed choices.
Food sweet, but you know what you eat? Me glad you ask cause it's not funny. Not funny. Me say help value more than money. If no fun, healthy things in the bag. Put a warning on the front label, not the back. Enough sugar where you add. Put it on the front label. Enough salt where you add. Put it on the front label. Only for fats where you add. Put it on the front label. We don't want search for the facts. We want the warning on the front of the pack. We don't want a heart attack. We want to stay on track. Put it on the front label, not the back.
Greetings, everyone. My name is
All right. Thank you so much for that presentation from the Heart Foundation of Jamaica, basically reminding us that our health is really a choice that we make, and certain to try and provide for us opportunities for us to make more informed choices whenever it is that we're going to purchase items for nutrition and nutritional consumption. So colleagues, we're now going to be moving straight into the academic presentation. Our first presenter today is going to be Dr. Jordan Eaton. He's a senior resident in the Department of Psychiatry at the University of the West Indies. He's a graduate of the UE, and he developed his love for mental health related disorder during his posting at the Kingston Public Hospital. He also has an interest with treatment of conditions using medical marijuana. So he's going to be speaking to us on the significance of psychological stress on chronic disease outcomes during the pandemic. I'll now hand over to Dr. Eaton, Jordan Eaton.
Hi, thank you very much. Good afternoon, everyone. Can you hear me okay?
We're hearing you good.
Okay, fantastic. So I just need permission to share my presentation. and then we can begin. Share screen, fantastic. Share that, and we should be good to go. So you should be seeing the presentation now. Okay, fantastic. So good afternoon, everybody, once again. So I will be presenting on the significance of psychological stress on chronic disease outcomes during the pandemic. So fairly brief presentation. I'm going to do my best to keep within the time limit. We have about 30 slides to go through, and I'm trying not to go too in depth. We're just going to do the basic overview because of the time constraint. So what we're going to be looking at are our definitions, or incidence, or pathophysiology, and the sum total of everything. What are the implications for everything? So in defining these conditions, in doing this presentation, we need to define the conditions. First, we need to define what a chronic disease is, which has been done ad nauseum. Disease that lasts, or a condition that lasts 1 year or more, requires ongoing medical attention, or limits activities of daily living, or both. We're looking at heart disease, cancer, diabetes, mental health conditions, etc. Stress. Stress is a normal reaction that the body has when changes occur, resulting in physical, emotional, and intellectual responses. Chronic stress is continued activation of the stress response that causes wear and tear on the body. Physical, emotional, and behavioral symptoms can develop as a result. So one of the recent concepts that has been formulated in regards to stress is the phenomenon of eustress versus distress. So eustress is positive, it's helpful, it motivates people to work hard, improve their performance, and reach their goals, even in the face of challenges. So for example, eustress would have been, had I forgotten about this presentation until 2 days ago, and I know that I have this presentation to do, there may have been that stress response that says, oh, okay, we have to get this done. And you have that motivation and that stressful motivation to get everything done and make sure everything is perfect. So that's an example of eustress. It's still the same activation of the flight or fight response. However, in eustress, the energy provided is proportionate to what is needed in the situation while in distress. The energy is excessive or unusable. So there's a difference in the amount of energy that you're getting and the overall way it can be managed, utilized, and channeled into something potentially helpful. So in considering distress, it's a negative kind of stress that most people associate with feeling stressed out. It tends to cause people to feel overwhelmed, anxious, and to experience physical and psychological symptoms. We're looking at headaches, tension in your body, neck and shoulder specifically, insomnia, inattentiveness, irritability. You can have memory impairment. You can even have frank personality shifts, irritability, as we had said, or just a lack of energy, anergia, or fatigue. Frequent, intense, or chronic stress is toxic to the body and the brain and is linked with several physical and mental illnesses, as well as an impairment in a person's ability to function. So just to get an idea of the difference between eustress signs and distress signs. So with eustress, you're looking at productive energy. Focus is increased. You have an increase in your motivation. It is often experienced as excitement. It feels manageable. Your performance goes up. You have confidence that comes with it and the expectation of a positive outcome. Distress, however, you have restlessness. Your focus is impaired, procrastination and avoidance, experience of fear or concern. It feels overwhelming. It impairs your performance. It is associated with insecurity, and there's usually a fear of a negative outcome. So where are we starting on? So the focus of this presentation is looking at how psychological stress and strain affects our non-communicable diseases. So to start, we're going to look at what our non-communicable disease numbers were like pre-pandemic. So taken directly from the WHO, you're looking at 41 million people per year who lose their lives to non-communicable diseases, and it's approximately 71% of all deaths globally. Each year, 50 million people die from a non-communicable disease between the ages of 30 and 69. 85% of these premature deaths occur in low and middle income countries. Hello, Jamaica. 77% of all non-communicable disease deaths are in low and middle income countries. And cardiovascular diseases account for most non-communicable diseases, or 17.9 million persons annually, followed by cancer, respiratory diseases, and diabetes. These four groups of diseases account for 80% of all premature non-communicable deaths. So what is actually happening in terms of the pathophysiology of distress and chronic stress states on the body? It all goes back to the hypothalamic pituitary adrenal axis and the production of cortisol. The hypothalamus releases CRF and it is transported to the pituitary gland, which then produces ACTH. It is then transported to the cortex of the adrenal glands and you produce corticosteroids, the most important corticosteroid being cortisol. Now, corticosteroids, as we know, are involved in regulating metabolism, the immune system, blood pressure, as well as the response to stress and other functions. So over short periods of stress, you get epinephrine and norepinephrine, or adrenaline and noradrenaline. However, chronic periods will produce large amounts of adrenaline and noradrenaline in addition to large amounts of cortisol. And this is what it's looking like in a very simplistic format. So just for a visual aid. So again, it starts in the brain and it affects the rest of the body. So what are the effects of cortisol on the body? You're looking at an increase in your blood pressure, transient blockage of retrieval of memories and affecting of the learning capabilities of the person. It creates habit-based learning with strong emotional arousal, meaning if you're in a chronic state of stress, you have a heightened likelihood of creating negative emotional connotations with specific triggers. So something that may have been, for example, a neutral stimulus in a non-stressful situation. When you have a chronic stress situation, a neutral stimulus has the potential of creating neural pathways in your brain that lead to a strong emotional response. Cortisol also suppresses your digestive function. It increases your blood glucose levels, you get impaired immune function, and you have impaired neurotransmitter functioning. And I just put that in there because when we speak about impaired neurotransmitter functioning, we're talking about dopamine, serotonin, glutamate, all these neurotransmitters that are linked with the development of multiple mental health conditions, pre-psychotic disorders, schizophreniform schizophrenia, anxiety disorders, post-traumatic stress disorder, chronic depression, low-grade depression, all of those. So you can see the gamut of effects that cortisol can have. So let's connect these dots because we need to take from one step to the other. What is the effect of SARS-CoV-2 on non-communicable diseases? Underlying chronic conditions such as cardiovascular disease and diabetes are predictors for severe illness and death from COVID-19. Containment and mitigation measures from COVID-19 make it difficult for patients to access routine diagnosis and treatment. So here we're going to look at some data from the WHO, and this comes from their rapid assessment report on the effect of COVID-19 across the world. I'm just going to highlight some of the specific areas that apply to us. So here we are looking at the percentage of countries where government funds initially allocated for non-communicable diseases have been reassigned to non-communicable disease services during the COVID-19 pandemic. And as you can see in the Americas region where we are, you're looking at about more than 50% of countries at the time when this was done was not being affected. However, 50 to 100% were actually, phrase that poorly, 51% to 100% of resources in less than 10% of countries were being redirected. And about 35% of these countries just didn't know. And when you look comparatively in the global picture, which is on the right, you can see that the Americas actually did fairly better in terms of their response for not sacrificing non-communicable diseases. So again, looking at the Americas and global picture, you're looking at percentage of countries with non-communicable diseases included in the list of essential services for the COVID-19 response. And again, we did pretty well. when compared to the worldwide picture. However, there are some places that fell down. So for example, chronic respiratory disease services, you see a significant drop, as well as dental services, rehabilitation services, tobacco cessation services, and other services. We see a drastic decrease when compared to the international perspective. When you're looking at funding that is allocated from the governmental budget, you will see, again, we have had some issues, right? Additional funds in the Americas does show some amount of countries increasing the amount, but overall, when compared to the global average, we're not doing too poorly. And again, this slide is fairly important. So you're looking at the percentage of countries that had disruption in their non-communicable disease-related services. Almost every non-communicable disease service had a partial disruption. And in some instances, you will see a complete disruption. So again, it just shows that there is a problem in terms of how the pandemic is affecting persons' access to treatment and treatment modalities. So the denouement, what is the overall outcome of everything? When you're looking at the connection between the two, you have to recognize that it is multifactorial. Individuals with certain pre-existing chronic health conditions have been identified as high risk for COVID-19, and we have gone through that before. Prof. Boyd did an excellent presentation on managing patients with diabetes. It is likely that individuals with chronic diseases may worry during the pandemic to the detriment of their mental health. So in a study that was done by Saeed et al. In 2020, looking at the mental health outcomes of adults with comorbidity and chronic diseases during the COVID-19 pandemic, where they tried to case control, what they found is that patients with non-communicable diseases have an increased risk of morbidity and mortality. And when they accounted for the psychological stresses attributed to the pandemic, the same stress pathways were involved, and it resulted in distress and compounded complications for non-communicable diseases. And what they did show in the same study was that persons who did not have non-communicable diseases actually had slightly better outcomes, but it's difficult to tease out, which is why they try to case control as best as possible for age, gender, et cetera, because they wanted to try and isolate purely the effect of the level of distress in persons who are healthy and the persons who have non-communicable diseases. And what they actually showed was that persons with non-communicable diseases had poorer disease outcomes overall. So health, psychosocial, and economic impacts of the COVID-19 pandemic on the people with chronic conditions in India. This was Singh et al. In 2021. They looked at 1,734 individuals, 50% of which were males. 83% of participants reported difficulty in accessing healthcare. 17% faced difficulties accessing medication. 59% reported loss of income, and 38% lost jobs. And this is what I wanted to highlight. When we are considering the psychological impacts of COVID-19, it is not just the stress of either fear of contracting COVID, being exposed to COVID, or recovering from COVID that is affecting us. It is also the results of mitigation measures for COVID. So contextualize. If you are a person in a middle income country who has a non-communicable disease, however, you have been made redundant as a result of the pandemic and lockdowns, or if your clinic dates are being pushed back indefinitely and you're just getting a repeat of your prescription without actually seeing your physician regularly and doing your routine workups that you would normally do, which is very plausible for happening in the public health sector, or a combination of the two. If it is that you were initially on a medication that was well controlling your chronic condition, but for financial reasons, you had to switch to different medication, or there was just a problem getting that medication in the first place, you're looking at increased likelihood of complications from these non-communicable diseases. And this is just as a function of the lockdown, losing your job, having less income, possibly being unable to better feed and take care of yourself. A lot of people, for example, may have been unable to go to the gym, which helped to improve their blood pressure and their blood sugar control. And at-home workouts were just not sustainable for them. So they're going to have a worsening of not only their mental state, but also their physical disease states. Looking at the study by Singh in 2021, the final adjusted regression model, it had diabetes and hypertension, as well as loss of income significantly associated with difficulty in accessing medications. So again, the actual effects of having the conditions and the secondary effects from the pandemic itself. Further, difficulties in accessing medication and job loss was associated with worsening of diabetes and hypertension symptoms. The qualitative data suggested that most participants experienced psychological distress due to loss of job or income, or had difficulty in accessing inpatient services. So when we're looking at the effects of stress on chronic disease, Coupe et al. In 2021 highlighted it perfectly. Specifically, life events perceived as stressful may elicit a negative emotional response, leading to changes physiologically and psychologically. Now, physiologically, you're looking at the activation of the HPA axis and the multiple sequelae that we had spoken about: poor glycemic control, impaired glucose tolerance, and impaired infection response, or immune response, I should say. And we're looking at psychologically, a person who is isolated, you are going to possibly develop anxiety or depression. You may, as a result, develop poor health decisions and health-seeking behaviors. Someone who was well controlled with their diabetes could go to the doctor regularly, afford their medication, and engage in socialization to not have the chronic stresses of life causing distress, but rather providing eustress. In this situation may tip from eustress to distress. And they may, for example, develop a major depressive disorder, which has been happening. As a result of developing that major depressive disorder, you will lose your hopefulness, or you will have a loss of motivation to be active in your health-seeking behaviors. And conversely, you may take poor decisions when it comes to managing your chronic conditions, and you're going to have poorer outcomes overall. So I think we're doing quite well on time, actually. Wrapping it up, right? What are we trying to say? Stress can be healthy or unhealthy. Unhealthy or distress will have a physical and psychological effects on the body. And you're looking at blood pressure, glucose, cholesterol, anxiety, and depression. Long-standing stress will result in chronic physical and psychological conditions. And you're looking at the development, for example, in persons who were previously healthy, developing non-communicable diseases, diabetes and hypertension, or persons who had these conditions before, developing worsening of their conditions or developing secondary conditions. So a person with diabetes and hypertension subsequently developing a depressive disorder. Or you may become, frankly, mentally ill. You had a predisposition genetically to a mental health condition, and the stress and distress of being in the pandemic tipped you over and activated those neural pathways. And as a result, you may need intervention with psychotropic medication. Persons with non-communicable diseases at baseline have an increased risk of distress by the very nature of their diagnosis. And we all know this. When we were all in med school, we were doing sad persons assessment. We all know that one of the risks for suicidal behaviors is the presence of a non-communicable disease. Some chronic condition, especially one that is poorly controlled, is going to raise the risk of this person having ideations of self-harm. This is not new information for us. We know this connection exists already. The effects of the pandemic have affected multiple areas of the effects of the pandemic have multiple areas of impact to cause stress or distress. You're looking at scaled down medical services. So someone who was relatively well controlled, who could come to clinic once a month, once every 3 months, is now going to just get their medication repeated and is going to have longer clinic visits, and they may have poor health outcomes, or because they are afraid of being exposed to the condition, they may avoid trying to seek medical help because of the risk of exposure at the healthcare facility. You're looking at the difficulty or inability of accessing medical services, including medication and follow-up. And we're also looking at isolation and lockdown to prevent COVID-19 infections having deleterious mental health outcomes, i.e. the development of anxiety and depression, which in combination with the lockdown and these non-communicable diseases can cause persons to have poorer health-seeking behaviors, be less active in their participation in their health management, or just take poorer health-seeking decisions. And as a result, their chronic conditions get worse. And this is all just as a result of effects of the lockdown itself. We are not considering the second point here, that distress can induce worsening of your non-communicable disease states and an increase in morbidity and mortality as a result of the direct effects of the hypothalamic pituitary adrenal axis via cortisol, where you will have dysregulation of your blood pressure, dysregulation of your glucose control, you will have dysregulation of your appetite, you will have impairment of your immune response, and the entire cascade of symptoms and sequelae that come as a result of it. And to wrap up, we will just look very briefly at this. Psychological and mental health impacts of COVID-19. We speak about the physical health. We speak about the health compromising behaviors. I didn't even want to touch on substance use disorders and suicide attempts or suicide behaviors, because that is a whole discussion on its own. I can summarize it by highlighting a decision taken by the Food and Drug Administration, no, wasn't the Food and Drug Administration, the American Medical Association during the initial stages of lockdown, where they decided that they were not going to close access, or they were not going to recommend for closure of access to alcohol and other substances, because when they ran the numbers, the sheer burden to hospitals as it was under COVID admissions was going to be made significantly more complicated, because chronic alcohol users were going to go into alcohol withdrawal and would flood the hospital with unnecessary admissions and increase the risk of transmission of the virus. And when I heard that in a presentation, my mind was just completely blown. You're also looking at disruption of the family and the relationship dynamics. So for example, persons who had a healthy relationship and their partner would be encouraging and helping to manage their condition or just give them helpful reminders may lose that influence. You have a decrease in your job satisfaction. You may have a loss of your job or a loss of income, and you're looking at the trigger of turnover in tension, and the cycle just continues and continues. So to try and separate mental health from physical health is very challenging, nigh impossible. And one of the more complicated things about this presentation is that it is going to be very difficult later down the line to try and assess what is the exact impact of the mental health conditions or the worsening mental health state of patients for persons with disease outcomes. Meaning, did this person have stress, depression, or anxiety prior to their diagnosis of a non-communicable disease? Or was it induced by it, which subsequently put them at increased risk for development of COVID? Or did they have the non-communicable disease and they would have been fine had they not had the psychological stress or strain, which worsened their health-seeking behavior or limited their access to care, which increased their risk of exposure and led to poor disease outcomes. We will have to see what the data shows, but all of that to say, I encourage everyone to consider the mental and psychological impacts of this state for all your patients. Across all the specialties, no one is exempt. So just take some time. If you need assistance, there are multiple screening tools online that we can use, the GAD-7, the PHQ-9. You can always pick up and contact the Jamaica Psychiatric Association or the mental health professional who is close to your facility or that you may know casually. We field calls like this all the time. We have no problems with it. Whatever it takes to make sure that everyone is well, and there is nothing wrong with not being well. We own it and we move through it. Thank you so much for your kind attention.
Thank you again, Dr. Eaton, for those pearls, so to speak. It's very important for us to, both as healthcare practitioners as well as our patients, to recognize that we all, it's within our gift to try and ensure that we pay some attention to our mental health and to pay some attention to the stress that is within our environment. At this point in time, I will proceed to take the other presentation, and at the end of both presentations, we will then do the question and answer. Thanks again to Dr. Eaton for actually catching us up with some time. And it is indeed my pleasure at this point in time to welcome to the mic Dr. Toussaint Livingston. Dr. Livingston is a pediatrician. She's board certified both in general pediatrics and developmental pediatrics. And she is relatively new to the island, having migrated to Jamaica just roughly about 2 years ago, and practices out of Kids Clinic. She will be guiding us through the topic of autism spectrum disorder as a chronic disease from birth to death. And it will indeed my pleasure to ask Dr. Livingston to take us through this topic at this point in time. Thank you. Dr. Livingston.
Hi, Doc. So you're unmuted and your screen is showing. Are you hearing us?
Yes.
So we just needed to share. There you are. We're seeing. So just go to the PowerPoint.
Okay. Okay. Yeah, screen sharing. Okay.
Yeah, click on the PowerPoint itself, which is behind that.
Okay. Hold on.
No, that will close it. Okay.
Okay. I'm sorry.
You need to minimize. No, it's okay. You need to minimize the screen here. So click on the yellow button at the top left.
Okay.
No, right there, the yellow button.
I don't see it. Okay,
right
I see that. Yes.
There you go. So let's minimize that. Let's get to your PowerPoint now.
Okay. All right.
Let's double click on it. I think it's right there on your desktop. Perfect. And then we go to slideshow full screen.
Okay. All right. Okay, can you all see my slide?
Yes, we can, and we can hear you well.
And you can hear me well. Okay, thank you very much for inviting me to this conference, and I am really feel honored to be one of the speakers. And this is my topic. I'm going to be talking about autism spectrum disorders, and I'm going to be sharing about autism spectrum disorder as a chronic disease from birth to death. And this is me, and I've already been introduced to you guys. And what I'm going to be doing is I'm going to start with what the definition of autism spectrum disorder is. I'm going to be talking about its prevalence, the etiology, the symptoms, the diagnosis, the management, and then resources available in Jamaica. So starting with the definition, this is very, very important, because if you can understand this definition, then it makes it so much easier to manage this condition. It is a neurodevelopmental disorder characterized by difficulty with social communication and social interaction, as well as restricted, repetitive patterns of behavior, interests, and activities. So there are two main areas: difficulty with the social communication and social interaction. And the second area is the restricted, repetitive patterns of behavior, interests, and activities. So what is the prevalence of this condition? The global prevalence is about 1 in 132. This is worldwide. And this prevalence all over the world has been increasing over the years. And in Jamaica, this is the most current statistic we have, that the prevalence of autism spectrum is about 1 in 68 as of 2014. So that means out of every 68 children, at least one of them has autism spectrum disorder. So the reason for this apparent increase in prevalence all over the world may be related to the improved awareness of the condition worldwide, the expansion of the diagnostic criteria for the disorder, better diagnostic tools, and improved reporting. The prevalence is 4 times more common in boys than in girls. And in my clinical practice over the years, almost 75% of the children that I am evaluating for autism spectrum disorders are boys. And since the majority of those affected are male, there is some concern about the interaction between testosterone and brain development. And autism spectrum disorder occurs in all racial, ethnic, and socioeconomic groups. This picture you see here is a 3-year-old patient that I had a few years ago that had Fragile X syndrome and came to me, and I diagnosed the child with autism spectrum disorder in addition to his Fragile X syndrome. And what is the cause of autism spectrum disorder? This is something that, you know, a lot of the parents ask. No single cause has been determined, but researchers believe that it is partly genetic and partly environmental. Studies have shown that among identical twins, if one child has autism spectrum disorder, then the other twin is likely to be affected with the same condition more than 30% of the time. And also, parents who have one child with autism spectrum disorder have a 2 to 18% chance of having a second child who's also affected. Another reason to suspect a genetic etiology is that children born to older mothers and children born to older fathers are at a higher risk of having autism spectrum disorder. It tends to occur more often in children who have genetic disorders, as I mentioned earlier with the young boy that I saw with Fragile X syndrome as well. In these children, the level of intellectual functioning is variable. Almost half the patients, 44%, with autism spectrum disorder have average or above average intelligence. The rest of them, which is 56%, have below average intelligence or intellectual disability. Autism spectrum disorder, because it is a spectrum, tells you that the kids present differently. So no 2 children will present in exactly the same way. And how do they present? They can present as early as 12 to 18 months. You can see the differences already. The different areas where you see differences in these kids versus regular kids is that In the visual behavior area, these children have poor eye contact. They have difficulty with eye tracking, prolonged inspection of objects, and difficulty with joint attention. Joint attention is the shared focus of two individuals on an object, and this can be noticed as early as 12 to 18 months. In the motor skills area, these children tend to have delayed fine and gross motor skills, and they have atypical motor behavior. In the play area, they have limited and repetitive toy play, as I will show you in one of my next videos. In the social communication area, they have difficulty responding to their name, lack of social smiling, and delayed use of gestures like pointing. And pointing is a fine motor skill that is used for early social and communication interactions, and it develops at 15 to 18 months of age. In the language area, these children have delayed babbling and delay in the use of single words. This is a normal 12-month-old child, and you will see the joint attention that she's showing.
How old is Hattie? 1. I got you.
She's looking at her grandmother who's talking, and she's also looking at her mom who's taking the video. Now, this is a child with autism spectrum, and you can observe the way she's playing with the wheels of the toy car rather than moving the toy car around along the ground. This is the same child with atypical motor behavior. This is a 23-month-old child that I diagnosed with autism spectrum a few months ago.
Sometimes she rolls her eyeballs in the weird way, right? Yeah, I see that.
This is the same child, and she's having the repetitive toy play, and she's just flipping the spoon. And if you notice, she's sitting on the ground. Children with autism spectrum disorder tend to present with low muscle tone. And this may be the reason why they like to lie down on the ground and they play with their toys on the ground. This is the same child with the atypical motor behavior. She can walk, but she likes to lie down on the ground, and she's trying to get away from social interaction with the examiner. So she's sitting as far away from the examiner. So she goes against the wall and she sits against the wall or lie down against the wall just to avoid social interaction with the examiner. So how do you diagnose autism spectrum? Research has shown that the diagnosis can be made reliably before 2 years of age, as you could see in the previous screen. Provisional diagnosis at 2 years of age overwhelmingly correlates with an ASD diagnosis at age 4. Early detection and early intervention is very important, and this leads to a better prognosis for the child. Another reason why early detection is very important is that plasticity, or the ability for the brain to reorganize and adapt, is greatest in the first years of life. and decreases with age. Early intervention should be made and initiated as soon as suspicion of autism spectrum is made, even before the child has been referred to a specialist for it. So how do you pick up these children early? The modified checklist for autism in toddlers is a screening tool that has been developed and studied and has been proven reliable to screen children as early as 16 months of age for the developmental difficulties in autism spectrum disorder. So this specific screening should be done at 18 and 24 months of age when they come to your office for the well child visits, and you use this modified chart. It's just a single sheet of paper that has 20 yes and no questions on it. You give it to the parent to complete. It takes them anywhere from 3 to 5 minutes to complete it. They just have to circle yes or no for each of the questions in regards to their child. This screening tool has been tested on children from 16 to 30 months of age. And in my clinical practice, I actually use it on children between 18 months all the way up to 36 months, because sometimes you will not see them for well visits at exactly 18 months or at exactly 24 months. It's available in several languages and it's free. You can download it freely, and it also teaches you how to score it. And I will show it to you, okay? This is when you go online, this is what you're going to see. It tells you the instructions for use. It also gives you the scoring algorithm to tell you what scores are low risk, medium risk, and high risk. And this is what the MCHAT looks like. So this is the part you're going to print out and give to the parent to fill out. And to score it is very easy, and I'll tell you a quick way of scoring it. The questions, number 2, the correct response for number 2 is no. The correct response for number 5 is no. The correct response for number 12 is no. So if you just remember that number 2, number 5, and number 12, the correct responses are no. And every single other question, the correct response is a yes. If you can remember that, you will be able to score it once the parent fills it out. So this next slide shows you what an MCHAT looks like for a child that's negative for screening for autism for spectrum disorder. This is a past MCHAT because you have a no for number 2, a no for number 5, and a no for number 12, and everything else is yes. So to be able to score it, this child has a ASD risk score of 0. You count how many no's, how many incorrect responses there are to be able to see if the child has passed or the child has failed. So this child is a negative screen. These two pictures here are positive screens, and these were children that I saw a few months ago. One of them is 23-month-old, the 23-month-old patient you saw in the video, and then the other one is a 2.5-year-old boy. And as you can see, the questions for 2, 5, and 12 were correctly circled, but the child has several no's. So this child has an ASD risk score of 11 because there were 11 incorrect responses. This second child has an ASD risk score of 8 because there were 8 incorrect responses that had been circled as no. So once you get this, a child that has a failed MCHAT, which is a positive screen, what you have to do is you interview the parent to make sure that the responses that were incorrect were really incorrect. So you have to do a follow-up interview with the parent. And then after you do the follow-up interview, you can then refer the child for early intervention services as soon as possible, and then also refer the child for evaluation for autism spectrum disorder, or you do the evaluation yourself. So how do you make the diagnosis? The ideal way would be a multidisciplinary evaluation would be most beneficial for a thorough assessment. But we all know that this can be logistically difficult, especially now in the COVID pandemic era. So the diagnosis of autism spectrum can be made by you guys in the audience. It can be made by a general practitioner, a family physician, a pediatrician, a neurodevelopmental pediatrician, a neurologist, a psychiatrist, or a psychologist. And these are the tools that you use. The childhood autism rating scales, you can get it online. You would have to purchase it online, and it's not expensive. It comes as forms that are like 3 pages long, and you score it in the office based on your clinical observation of the child in the office, as well as the history that you get from the parent. It takes about 15 to 30 minutes to score. And the more times you score this in your office with these children, the better you get at it. And then you can get really good at using these childhood autism rating scales. In addition to the childhood autism rating scales, you can make a diagnosis of autism spectrum based on the DSM-5 criteria, using the clinical observation in the office, the history from the parent, and using the DSM-5 criteria, which I will show you now. So going online, the DSM-5 criteria is as follows. It says that the child has to have difficulty in the 2 major areas that I explained, in the social communication and social interaction areas. The child has to have difficulty, and it gives you 3 subgroups here that the child has to meet these 3 subgroups. And then for the restricted repetitive patterns of behavior, interests, or activities, there are 4 groups, there are 4 areas here, and the child has to meet at least 2 of those. So you want to be able to diagnose it using these DSM-5 criteria. You want to see if the child has difficulty in number 1, number 2, number 3. And then in this second section, you want to see if the child has difficulty in at least 2 of these areas. And there you can make the diagnosis. In addition to using the DSM-5 criteria, the DSM-5 wants you to specify whether there is intellectual disability or not. You may not be able to determine this right away, and you can defer that addition of the intellectual capacity of the child until the time when you can get it. But at the time of your evaluation, you can indicate whether the autism spectrum disorder is with accompanying language impairment or not. Then the DSM-5 criteria also wants you to have a severity level, whether it's level 1, level 2, or level 3, depending on whether the autism spectrum disorder is mild, moderate, or severe. To be able to determine these severity levels, what I do is I use the childhood autism rating scales, because in addition to helping with the diagnosis, it helps you with the severity, whether it's mild, moderate, or severe. Then the ADOS is the Autism Diagnostic Observation Schedule. This is the only standardized tool available for the diagnosis of autism spectrum disorder, and it is usually conducted by a trained professional. And by a trained professional, I mean somebody like a clinical child psychologist or a neurodevelopmental pediatrician. And unfortunately, because of the COVID pandemic, us neurodevelopmental pediatricians had a very difficult time conducting the ADOS, because you need the child to be able to see your face and your facial expressions and hear what you're telling them, the directions you're giving them. And you need to be able to see the child's face completely. So because the clinician is wearing a face mask because of COVID pandemic, and the child is likely wearing a face mask as well, I actually stopped doing the ADOS testing when the pandemic started. And I have not restarted it because I still have to wear my face mask at work. So it makes the diagnosis a little bit invalid, because the child cannot completely observe all the directions you're giving them and watch your facial expressions. So you can use the Childhood Autism Rating Scale, the CAS, and the DSM-5 criteria, in addition to the MCHAT, to make a diagnosis of autism spectrum in a child. And remember also that autism spectrum disorder diagnosis can be made at any age from about 18 months of age all the way to adulthood, because sometimes the children may not present until they're teenagers or young adults, and they present at that late stage because, number one, their autism spectrum disorder is probably mild, and number two, the demands of society, the community, and school makes it hard for them to interact in the social communication and social interaction areas. It makes it very obvious that they have a problem, and you can diagnose them also at that time. At the time of diagnosis, or as the children get older and go through adolescence and into childhood, they can present with some coexisting conditions. These include hyperactivity, impulsivity, and inattention, and they may meet criteria for a diagnosis of ADHD. They can present with self-injurious behavior, aggression, stereotype behavior, OCD, anxiety, depression, poor sleep, social withdrawal, excessive irritability, gastrointestinal and feeding issues, seizures, as well as wandering. And wandering or elopement is when a child or an adult with autism spectrum disorder leaves a safe and secure environment and goes away to another location where they have potentially can be dangerous for them. And an example of wandering or elopement is when a child leaves their home or leaves the classroom and they wander out. And sometimes they can end up getting drowned because they wander into bodies of water and they can't swim and they end up getting drowned. So this is very, very important to see if the child has these coexisting conditions. It tends to occur more in the children with autism spectrum disorder and intellectual disability. Now, how do you manage autism spectrum disorder? As a clinician, every time I see a child with autism spectrum disorder, I look at the big picture and I try to remember that I am looking at the child and I want to see what I can do with medical intervention, what I can help with behavior intervention, child education, parent education about autism spectrum disorder, parent training, parent support, psychosocial support for the child, and sibling support. These are all the areas you want to look at with each patient when they come to your office for management of their autism spectrum disorder. In the section for medical intervention, it should include sending them for a hearing test. This is very important. You want to document that they do not have a hearing loss when you diagnose autism spectrum disorder. Medical intervention also includes getting help with managing their coexisting conditions. You may have to refer them to some specialists like a psychiatrist, or a gastroenterologist for GI issues, for the different coexisting conditions. Then the behavior management in childhood, the behavior management can be done by an ABA therapist. An applied behavior analysis therapy is a behavior therapy specific for children with autism spectrum disorder that has been proven to be useful with scientific studies. And there are also other therapies that are based on the principles of ABA that can be used to help manage the behavior of these children. You also most likely will want to refer them for speech therapy, especially if they have receptive and expressive language difficulty in addition to their autism spectrum disorder. You can also refer them for any other related services that they may need. So what about child education? You want to start early. Start early for children with between 18 months and 3 years. Because of the COVID pandemic, a lot of these kids have been forced to be home and not be able to attend school or daycare centers. So you want to advise parents when they're home to reduce screen time with electronics for these children. And as pediatricians all over Jamaica, we've seen an increased incidence of children presenting with speech and language delay and children presenting with signs and symptoms of autism spectrum disorder because they've been spending hours on a daily basis on screen time. And this just makes their condition worse. So advise parents that they need instead to spend more one-on-one time with the children, reading books and interacting with the children. This is a better management for their condition. When they're 2 and 3 years of age, you want to, suggest to parents to send them to school. And especially now that things have opened up some in Jamaica, they can go to school, they can go to a nursery school or a daycare center. And the goal is to provide the child with structure and methods to facilitate social skills, functional communication, and learning. It also puts them around typically developing peers who will serve as role models and playmates for them. Special education may be needed for the older children in primary school and in high school. This is because, as mentioned earlier, with autism spectrum disorder, they tend to have fine motor skills difficulties. So in elementary school, they may have difficulty with writing. They also can have a learning disability. And one learning disability that we see a lot in children with autism spectrum disorder is difficulty with reading comprehension. So you will need to send them for a psychoeducational evaluation by the time they're in primary school. Another reason for them to get a psychoeducational evaluation is to test them for intellectual disability. And this can be done by a psychologist and is also done by a learning disabilities teachers consultant. And we do have them here in Jamaica. So when they go for the comprehensive psychoeducational evaluation, the clinician checks the intelligence quotient, which is the IQ. So this is a graph that shows you what the IQ group spread is like for the general population. And the center of the middle, the center of average is 100. And to have a diagnosis of intellectual disability, you have to have an IQ score that is greater than or equal to 2 standard deviations below the mean. So the mean is 100. So this is 1 standard deviation below the mean. This is 2 standard deviations below the mean, which is 70. So an IQ score of 70 or below puts you in intellectual disabilities range. And intellectual disability also, the patient has to have impaired adaptive skills. And I will talk a little bit more about that in addition to the IQ score of 70 or below. Intellectual disability is divided into mild, moderate, severe, or profound. And this is important to know as this is going to affect the management of the patient. So how do you manage them as they go through adolescence and transition to adulthood? It is important for the physician, the family, and the school to teach the child in an appropriate way they can understand about sexuality. Social skills training is best done at school and in the community. The youth needs help in understanding their diagnosis within the context of their developmental level. You want to explain it to them in a way that they can understand. You want to start including them in decision-making if cognitively they can understand. You want to start planning with the family and the community an education transition based on their abilities. Some of them with average and above average intelligence can go on to tertiary education, but a large number of them will not be able to do that. So you have to start that planning early when they're still teenagers. You want to start legal guardianship discussions with the family, because some of them, when they're 18 to 21 years of age, they may not be able to take care of themselves, and the parents may have to have legal guardianship moving forward with them as they transition into adulthood. Mentoring for the child within the community is very important, and this will involve engaging the community with the resources in the community for mentoring. You want to help manage the coexisting conditions, as at this stage, they may start to develop anxiety, depression, and other coexisting conditions. And you want to also monitor their medication as they need supervision for this. As they go into adulthood, you want to manage them depending on whether their autism spectrum has intellectual disability or they don't have intellectual disability. And I have the definition of intellectual disability there on the screen. So in addition to the IQ score, you want them to have adaptive skills difficulty in at least 2 of those domains: conceptual, social, or practical. You want to help them navigate the community resources for employment. In addition to managing their coexisting conditions, you want to help manage the medical conditions that may arise as a result of their genetic disorders for those that have genetic disorders. I have sent a list of resources to the planners of this meeting, the CCFP office. I have sent a list of all these resources that I have been able to gather over the past 2 years here in Jamaica. It is not an exhaustive list, and I'm still building up on it, but it's very important that you have access to this list so that you can use to help your patients, especially with the autism foundations. I have a list of autism foundations and government agencies. And this is me, this is my contact information if you would like to contact me. Thank you very much for letting me share, and I will stop sharing now.
All right, thank you, Dr. Livingston, for that very comprehensive overview of the autism spectrum disorder. And I'll just open the floor now for questions. Typically, just to remind the audience, the preferred way to ask a question is to use the question and answer app component of the Zoom, and rather than the chat component. All right, so I see 3 questions here. The first I can see, is it common to have eating disorders in children with autism? Are they because of the repetitive behaviors and sensory overload, less inclined to try certain food because of their texture and newness? So the question overall relates to eating, the eating aspects of persons with autism. Dr.
Yes.
Livingston?
Yes, that is correct. Because of their sensory integration difficulties, it also involves they're very sensitive to the textures of food. So some children avoid certain textures of food. And then also because of because they get fixated on certain things, some children, even the color of the food, they may not like. So these children with autism spectrum, also because they may have low muscle tone, they may also have low oral muscle tone, and that affects their eating. So you want to send them to a speech therapist. A speech therapist assists the parents with feeding. And then you also want to tell the parents not to give up on trying different foods and until the children are able to eat it. You can also elicit the help of a gastroenterologist, and this is where it would be a coexisting condition at this point.
All right, thank you for that response. I think in your last slide, you answered the next question, which is how available is support management available for autism spectrum disorder in Jamaica? And in your last slide, you did share with us
Yes.
the resources that you were able to identify.
Yes, I sent the list of resources to the Caribbean College of Family Physicians, so you can get that list for that. And these are lists that I've verified and that I have been using. and they've been very helpful.
Thank you so much for that. The third question I'm seeing here relates to a specific issue of a 16-year-old boy saying "Papa." Is it cause for concern?
If it, at 16 months of age, they have a vocabulary of anywhere from 0 to maximum 10 words. So if the child says "Papa," that's good, you know, and that is good. So you want to just encourage them to say more words. And that means the papa and the mama or whoever the caretakers are need to spend more time with the child, talking to the child, reading books with the child, and having joint attention, as I showed you, a lot of joint attention with the child, face-to-face human interactions.
Great. The other question I'm seeing here is, pertains to gastroenterologists in Jamaica, and I'll just answer that to say yes, we have quite a few gastroenterologists there in Jamaica. All right, so I've not seen any specific question for Dr. Eaton. Let's see. Dr. Vassell wants to know, are there any specific nutrition and diet recommendations for persons with autism?
I can answer that. This would come under what we call complementary alternative medicine, where there's some diets that, you know, people have said they do better with the children with autism. And what I tell the parents is that a lot of these diets haven't been scientifically studied to be accurate. So what I tell parents is you can try it. And then what we do is we see what the child's behavior and presentation is like before you try the diet. And then maybe 6 months or 3 to 6 months into the diet, you want to assess how is the child doing in terms of their autism spectrum symptoms. And if you do see an improvement, then that means the diet is helping the child and you can continue with it. But if you don't see an improvement, then there's no point continuing with it. So I usually tell the parents, yes, you can try an alternative type diet, but there has to be a beginning and an end, and you have to know what parameters you're looking at when you're trying this diet.
Okay, thank you so much. All right, colleagues, I will have to bring this session to a close. We're at least 10 minutes or so overdue. Dr. Livingston and Dr. Eaton, we encourage you to just continue typing your response to the Q&A, because you should be seeing them up on your screen. And at this point in time, I'd just like to, on your behalf, colleagues, just thank Dr. Livingston and Dr. Eaton for their presentations for this session. And I will now invite Dr. Pauline Williams-Green to take us through the final session. Dr. Pauline Williams-Green.
Hi, Prof. Actually, before Dr. Williams-Green, we have 2 sponsor presentations.
Sorry.
Sponsors,
right. All right, we'll go to the sponsors presentation. Thanks so much for the reminder.
No problem.
Greetings, everyone. My name is Christopher Fuller, medical representative with Medimpex Jamaica Limited, also representing Medimpex West Indies Limited. We're always happy to support the CCFP. Let's get into a few of our products. Our antihypertensive line, first up, Ramlon. Ramlon is a fixed dose combination containing ramipril and amlodipine and comes as 5-5, 10-5, and 10-10 preparations. This schematic highlights just how a ACE and a CCB work in tandem to lower the blood pressure. The ACE will reduce peripheral vascular resistance, while the CCB helps to lower peripheral vasoconstriction, and both working together to alleviate blood pressure. Therefore, Ramlon is indicated for the treatment of essential hypertension and is dosed by administering 1 tablet swallowed whole the same time each day, regardless of food, but never with grapefruit juice. For those with renal impairment, if they were switched to 2.5 or 5 milligrams of ramipril, they can be switched to Ramlon. For the elderly and pediatric population, it is not recommended for the frail and old or those under 18 years of age. Contraindications: angioedema, second or third trimester of pregnancy, hypotensive or hemodynamically unstable patients, cardiogenic shock, obstruction of the tract of the left ventricle, or if there's hypersensitivity to any of the ingredients. Adverse events: metabolism and nutrition disorders, nervous disorders, cardiac disorders, vascular disorders, also respiratory and thoracic disorders, gastrointestinal disorders, skin and subcutaneous tissue disorders, musculoskeletal and connective tissue disorders, generalized anxiety, general disorders, and these occur in 1 out of 100 patients. Ramlan is an excellent product. It does hit the target because it has a wide range of preparations. It is a true long-acting fixed combination product, and there's synergism in terms of its therapeutic benefits and also a low prevalence of side effects. And here's what the packaging looks like, and also the pricing with the NHF subsidy. Basically all strengths within a similar range. Here are some other offerings from Medimpex for tackling hypertension: Lysonorm, Lysopress HCT, and our regular Lysopress. And please bear in mind we also have Taliton and Ednit. Or Cleon-D. Cleon-D is priced at $1,135 for a box of 10 pessaries, and each pessary contains 100 milligrams of metronidazole and miconazole, respectively. It's indicated for the treatment of mixed infections from Trichomonas, bacterial vaginosis, and candidiasis, and it is administered 1 pessary, slightly moistened, inserted high in the vagina at bedtime for 10 days, but alternatively, you can do 2 pessaries for 5 days, slightly moistened. Reminding you also of our Mycosis, 150 and 200 milligrams, and the prices listed below. And our Sorbifer, to complement our women's line. Our Sorbifer contains 100 milligrams of elemental iron. It's a slow-release technology containing 60 milligrams of ascorbic acid, and is priced at $28. Benefits of choosing Sorbifer: small tablet size, odorless, affordable, fast absorption, less GI upset, less constipation. And to round out our women's health line, here's a reminder of some of our contraceptives, emergency and otherwise. Let's look at Midocam. Midocam is a centrally acting non-sedating muscle relaxant containing tolperazone as the active ingredient, and it exerts membrane stabilizing activity on the neurons. So Midocam exerts its action at 3 levels: peripheral level, central spinal level, and the central reticular level. It's indicated for skeletal muscle spasms and spasticity, and it can be taken by adults 12 years and above, and the dosing is 150 to 300 3 times daily. The maximum dose is 300 milligrams 3 times daily. The 150 milligram is not recommended for use in children less than 12 years old. The side effects: muscle weakness, nausea, flatulence, headache, dizziness, weakness, fatigue, Dysautonomia, itching, rash, anaphylactic reactions, which are very rare. The drug interaction side, there are no drug interactions that have been observed, and Midocam combines very well with benzodiazepines and NSAIDs. In fact, it is recommended that you add an NSAID. It is contraindicated in patients with myasthenia gravis or any condition causing rapid exhaustion of the musculature. And of course, hypersensitivity to the drug would warrant a contraindication or for the patient to stop taking. Finally, I will mention our Protec. Protec is our line of orthopedic supports. They are excellent orthopedic products. Their support for the spines, support for sprains and strains, my apologies, support for weakened muscles and joints, help reduce further injury. Compression can help to reduce swelling of injured muscles and joints, provision of therapeutic warmth. Here are a few of the options that they have, and there are many. They come in both elasticated and neoprene formulations. They're breathable, they allow for activity, they are comfortable enough for all-day wear, and excellent for rehabilitation. Thank you for your attention, and we do hope that you enjoy the rest of the conference.
Good day, this is Health 2000 Canada, otherwise known as H2K here in Jamaica. We are a generic pharmaceutical company proudly serving Jamaicans since 1999. Our products are very affordable, effective and safe, and approved by the Ministry of Health. Health 2000 Canada is proud to serve the Caribbean since 1999. Let's talk over-the-counter products. Borototal Neem Cream, an Ayurvedic antiseptic cream that heals, soothes, moisturizes, making it the perfect companion, the power-packed herbal alternative for wound healing and skin infections. Borototal Neem Cream reduces topical pain, calms minor skin inflammation, fights minor skin infections, and promotes skin healing. The main ingredients in Borototal are neem, aloe vera, sesame seed oil, asoka, licorice, and zinc, a power-packed combination. Borototal is effective on cuts and scratches, nappy rash, dry cracked skin, dry cracked nipples, maskne, blisters and burns, minor sunburn, insect bites, and much, much more. Borototal Neem Cream is locally recognized and effective for the diabetic foot, that thin, dry, papery skin that is prone to ulcers forming. Try Borototal Neem Cream, you're gonna love it.
Are you feeling tired and weak? Not eating properly? Recovering from an illness? Take Vitamax, the complete sugar-free multivitamin mineral syrup with over 15 essential vitamins and minerals the body requires daily. Take Vitamax to boost your immune system, enhance your appetite, and boost performance with added antioxidant support. Kids love the taste, adults love the benefits. Vitamax, for overall good health in one spoonful. Vitamax, the complete supplement for the whole family.
Now for prescription medication. H2K Dawacoff, an excellent expectorant, mucolytic and bronchodilator, contains salbutamol, romexin, guaifenesin, and menthol. Tastes great, making it a super effective option for rapidly treating asthma, reversible bronchospasm and bronchial asthma, bronchitis, rhinitis, and in the symptomatic relief of coughs and catarrh in flus, colds, and mild throat infections, and any chesty cough. So when you have wet cough, dry cough, any cough, like me, I need my Dawacoff, use Dawacoff. Dawa is do away, KOF is cough, Dawacoff. H2K Vasogrel Clopidogrel 75 mg tablets.
Clear the shadows of life with H2K Vasogrel Clopidogrel 75 mg tablets. Clopidogrel bisulfate is a thienopyridine antiplatelet agent that irreversibly prevents platelet aggregation or blood clot formation, important after heart attack, stroke, or other vascular issues that increases the risk of clotting. Clopidogrel is well tolerated taken once daily with or without food. With a loading dose of 300 mg, Clopidogrel achieves 55% platelet inhibition in 1 hour and 80% within 5 hours, making it beneficial to patients as early as 24 hours. Clear the channels of life with H2K Vasogrel 75 mg. Advanced diabetes management with H2K Metformin extended release 500 mg tablets. H2K Metformin XR 500 mg tablets releases the active drug through hydrated polymers, which expand after uptake of liquid. H2K Metformin XR provides uniform release for stable and sustained blood glucose levels. H2K Metformin XR provides 24-hour control with its once daily dosing. enhancing compliance, and decrease gastrointestinal side effects. Metformin XR should be taken with a full glass of water with the evening meal. Initial dose is 500 milligrams daily, increasing increments of 500 milligrams up to a maximum of 2,000 milligrams daily according to response. For superior performance, predictable serum concentrations, decreased gastrointestinal side effects, H2K Metformin XR 500 milligrams.
Team H2K is ready to serve you. All our products are available in pharmacies island-wide. Please write H2K before the drug name on your prescription. Follow us on Instagram at Health2000 Canada. Thank you all for listening. Have a wonderful day.
Good afternoon, everyone. And I'd like to express thanks to the organizers of the Caribbean College of Family Physicians for a wonderful symposium so far. World Family Doctor Day is actually on the 19th, I think. However, today's symposium has really highlighted so many important aspects of being a family physician. So if you are just joining, we welcome you. And for those who have been with us, going through the many laps today, then take a stretch, sure you had some lunch as well, and let's get ready for the final lap. The baton has been passed by Professor Reed, and we thank him for being moderator, and I am about to take over. At this time, we enter immediately into our next sponsor's presentation, Miss Adenike Morris, and I hope I didn't destroy your name, from MF&G Asset Management, and she will be talking to us about, I imagine, managing our assets. Go right ahead, Adenike.
Adenike, we're not hearing you. I think there's something wrong with the headphones.
Hello?
Go ahead again.
Can you hear me now?
Yeah, perfect.
Perfect.
Okay, great. And I was saying that you pronounced the name correctly. So, good afternoon, everyone. As she said, I am Adenike Morris. I am the Business Development Officer at MF&G Asset Management, and I'll be giving you a brief synopsis of our company and the products that we offer. So, a famous quote by the infamous Warren Buffett said, rule number 1 is never lose money, and rule number 2 is never forget rule number 1. And I'm here today to help you to follow both rules number 1 and 2. So let's get started. So MF&G Asset Management, the MF&G in our name stands for Myers, Fletcher & Gordon, to which we are a related entity. So Myers, Fletcher & Gordon is one of the largest law firms in Jamaica and the Caribbean single market. And for over 7 decades, they have provided global corporations and individuals with progressive and effective legal advice. Our company, MF&G Asset Management, was formed in 2003 with the purpose of optimizing the performance of high-value asset portfolios for both private and corporate clients within the financial industries. So what do we offer? So we offer fixed income products, and these include bond trading, where we act on behalf of the clients in acquiring sovereign and corporate bonds. These can be locally and international bonds. These may be in the form of treasury bills, investment bonds, global bonds, USD local bonds, and promissory notes. We also offer repurchase agreements, and the repo pays the investor a fixed rate of return based on a fixed investment period. And you can tell us how long you want it to run for, or you can give us a goal that you have in mind or something that you want to achieve, and we will tailor the product to match your need or your goal. The principle of the repo is secured by the underlying government or corporate security, and your funds are invested at, as I said, an agreed upon rate for a fixed period of time. And the minimum investment amount to open an account with us is 1 million Jamaican dollars or 10,000 US. We also offer portfolio management services, and this is ideal for investors like yourself, doctors who are too busy to manage their funds on their own, or they want professional managers like us with greater market knowledge to do so. And each portfolio encompasses an optimal mix of asset classes. Some of these include bonds, repurchase agreement, as I mentioned earlier, equities, unit trust funds in both local and foreign currencies. We also offer private trust funds, and this involves creating a trust deed designed to manage and protect your assets while letting you enjoy wealth during your lifetime. So you sit back and enjoy while we do the work. Sounds good? I think it does. We also offer estate administration, and having a skilled executor is the key to a swift and seamless administration of your estate. So it is on us to ensure that your estate is settled according to your wishes. We offer escrow management services where we act as the escrow agent holding cash, securities, and documents according to the specific instructions. We offer credit services. These include lease financing, personal loans, business loans, as well as mortgage loans. And to close, the process of wealth creation in equity starts with a choice. And I want you to make the smart choice today and invest with MFNG Asset Management. You have a vision of where you want to go in the world, and we are here to make it happen. Thank you for listening, and I hope you enjoy the rest of the presentation. I will be in the chat. I'll be in the chat if you have any questions, and this presentation will be forwarded to all of you guys. Thank you for listening.
Thank you, Adenike. That was very informative and well put together. So let's go full speed ahead. Yes, we're moved into a submarine this time, or a go-fast boat. And we're going to invite Dr. Michelle Campbell-Mitchell. Boy, this is a tongue twister. She is a graduate of University of the West Indies and an obstetrics and gynecology consultant since 2015 at the University Hospital of the West Indies. She's also an associate lecturer at UWI, and she has a private practice at Winchester Surgical and Medical Institute. But what is really striking is at her very young age, she is already published in the Journal of Obstetrics and Gynecology earlier this year. Congratulations. And also she's into medical education because she also published in the Journal of Medical Education and Curricular Development. I think that's wonderful. We're really looking forward to your presentation. Michelle, please go right ahead.
Thank you so very much, Dr. Williams-Green, for your warm welcome. Thank you to the organizers of this conference for inviting me to speak. I feel honored to speak, amongst my esteemed colleagues. So I'm gonna go ahead and share my screen. All right, and today I have been given the task of speaking to you all on the effect of COVID-19 on women's health. As an outline, I'm going to introduce the topic, speak to you about some specific factors that are unique to women. So women as caregivers, women in healthcare, diagnosing and treating COVID-19 in women, disruption disruptions to the essential health services and the effects that this has had on women. Then we look specifically at maternal health, menstrual health, the effects of the COVID-19 vaccine, mental health, and briefly at long COVID and domestic violence as we round up. So actually, the year 2020, marking the 25th anniversary of the Beijing Platform for Action, was intended to be groundbreaking in the area of gender equality. Instead, with the spread of the COVID-19 pandemic, even the small gains that we had made in the past decades are at risk of being rolled back, dialed right back. And this is because the pandemic has and continues to deepen pre-existing inequalities, exposing vulnerabilities in social, political, economic, and what we'll be focusing on today, health systems. And these vulnerabilities are in turn amplifying the impacts of the pandemic. So let's take a look at women as caregivers, and I've put here / in healthcare. Now, the typical role of women is to be a caregiver. And in this typical role, women are at an increased risk because of increased exposure of contracting COVID-19. Additionally, which is why I put the / the vast majority of healthcare workers are women. The vast majority of persons on the front line caring for patients are women, right? And it has been shown, or the data has showed, that 72% of all COVID-19 cases among healthcare professionals in the Americas were women. So this physical and emotional taxation, really, of working long shifts in the hospital, you know, worrying now about your COVID-19 exposure, definitely followed many female healthcare workers home. Many of us on this platform can relate, I'm sure. And then when we went home, 80% of us were responsible for caregiving there. So needless to say that women were or are being heavily taxed as a result of this pandemic. So as a result, women in healthcare are more likely to suffer from anxiety, depression, insomnia, and burnout, way more than their male counterparts, right? But more on mental health later. So also unique to women is that, yes, for sure, we're less likely to develop severe disease from COVID-19. You know, within a few months of the pandemic, that became apparent, right? But we were also more likely to be diagnosed later. And then once women were diagnosed, they died earlier, suggesting that many did not receive timely, adequate care, right? So what about the disruptions to essential health services that, of course, the pandemic led to? Now, with the pandemic, there was redirection of healthcare services in order to cope with the pandemic. But sadly, this redirection left many women and girls without the support that they needed to stay well. In Latin America and the Caribbean, 1 in every 4 adolescents did not have access to family planning services, leaving them exposed to unwanted pregnancies, health risks, dropping out of school, among other risks. So these disruptions to essential health services are being felt broadly. The World Health Organization, in an analysis, found that women's health services are far from being fully restored even now, with 40% of African countries reporting disruptions to sexual, reproductive, maternal, newborn, child, and adolescent health services. So that's really all the health services catering to our women. In another survey that the WHO conducted on continuity of essential health services during the pandemic, and this was carried out between November and December of last year, this survey showed that the majority of 36 African countries that provided full data reported up to a quarter of their services being disrupted. And the extent of the disruption remained largely unchanged up to the first quarter of last year, right? So between June and September of last year, also, contraceptive use fell by almost a half, right? And so consequently, it's no surprise that teenage pregnancies also rose in some countries, right? So these statistics are just showing the worldwide effects that the pandemic has been having on our women, whether in the Americas or in African countries. In fact, in Kenya, girls who had dropped out of school for 6 months due to COVID-19 were shown to be twice as likely to become pregnant. That's not really surprising. And 3 times as likely to drop out of school compared with those graduating just prior to the pandemic, right? Similarly, in South Africa, a study by the Medical Research Council in 5 provinces showed that teenage pregnancies had increased by an alarming 60% since the start of the pandemic. But what about here in Jamaica? This picture is just for your attention. It's the entrance of our labor ward at the University Hospital. Let me add quickly the disclaimer that our UE statistics are not by any means representative of the statistics across the island. It's just that our data collection at UE is perhaps a bit more robust, and so, and obviously I work there, so I can comment, you know. And this graph here, I can comment on these statistics is what I was trying to say. This graph here shows the teenage pregnancy rates at UE that we have observed over the past, this is 11 years actually, so a little bit over a decade, but I just want to highlight that really our pregnancy rates throughout the pandemic, you can see where my cursor is between 2020 and 2021, have really remained unchanged and have hovered, the rates have hovered somewhere between 1.5 to 2%, right? So largely unchanged, at least at the University Hospital. What about maternal health? So expectant mothers have had to balance the fear of contracting COVID-19 or being exposed to it, balance that fear with whether they can safely deliver their babies in a health facility. In the past 2 years, more than 365,000 cases of COVID-19 have been reported in pregnant women in the Americas, and more than 3,000 of these women have died. Now, a study carried out by PAHO's Latin American Center for Perinatology, Women's Health and Reproductive Health, this is actually the largest study of its kind in the world to date, and it's based on 447 cases of maternal deaths in Bolivia, Colombia, Costa Rica, Dominican Republic, Honduras, Ecuador, Peru, and Paraguay. So our neighbors to our south. And this study actually revealed that 1 in 3 pregnant women with COVID-19 who should have had access to intensive care during the first years of the pandemic, unfortunately failed to receive this critical care that they needed. The study also found that about 1/3 of the studied pregnant women who died from COVID related causes were unfortunately not admitted. So they didn't even have the opportunity to be admitted to intensive care. Sadly, the average maternal age was 31, and about half of these ladies who died were obese, in keeping with the trend of, obesity being a significant risk factor for severity of disease and COVID. The same applies to our pregnant population, as you'd have heard Professor Boyne discussing earlier. Now, among the women studied, 86% were infected before childbirth, and more than half of these cases happened in the 3rd trimester. At first hospital admission, the most frequent symptoms that these ladies had were dyspnea, fever, and cough, 73, 69, and 59% respectively. In addition, organ failure was reported in all of 90.4% of cases upon admission, and approximately 65% were admitted to critical care, where they remained for an average of just over a week, so 8 days. In most cases, do note, death occurred during the puerperium, 6 weeks after childbirth, as we know, with an average of 7 days between childbirth and death. I'm just highlighting this because many times we think that after a patient has had her baby, then that's it. Okay, the pregnancy is over, but actually a woman or a mother is most at risk and most vulnerable during this time. Just to note that preterm delivery was the most frequent perinatal complication. And of these babies, 60% of the children that were born were of low birth weight. Another WHO survey, so now WHO survey, sorry, this time our neighbors in African countries found that maternal deaths in health facilities in 6 of the 11 countries in the survey rose by 16% on average between February and May of 2020 compared with the same period in 2019. The figure, however, thankfully dropped slightly in 2021 to 11%. So a similar trend, again, being observed across the world. Note, though, that the estimate is likely to be far higher as maternal deaths tend to occur mostly at home rather than in health facilities. Data show that facility-based births reduced in 45% of countries between November and December of last year compared with the pre-pandemic period. And what about, again, a little look at home? Of course, we want to know what's happening at home. Again, commenting on our UE statistics, just to show that, fortunately for us, our maternal mortality ratios, as you can see here, thankfully, have remained, essentially unchanged. Certainly, in the years of the pandemic, pretty much at the same pre-pandemic level, hovering anywhere between 50 to 150 per 100,000 live births. All right, so we're winding down now to menstrual or really gynecological health, but I specifically said menstrual because the effects of COVID, gynecologically speaking, have really been on the menses. There have been various reports. Even I can speak personally as it relates to my practice of women experiencing changes to their period while sick and even after recovering from COVID-19. And the menstrual changes can be anywhere from a really strange light flow to a heavier flow. The flow being irregular, the periods being longer, and of course with those ladies who have heavier flow, some women have been passing very large clots, right? All after being infected with the SARS-CoV-2 virus. What about the effects of the COVID-19 vaccination? So this ties in actually quite closely with the effects that have been seen on the menses. Well, for one, women experience more side effects. We know that for a fact from the vaccine, from the COVID-19 vaccine. And that is actually seen with other vaccines. It's postulated, though, that these increased side effects could be from just more reporting, or the fact that we know that women have a more reactive immune system, right? And then tying in with the menstrual irregularities, this is also a phenomenon that has been observed post-vaccination. So COVID-19 can affect the menses as well as COVID-19 vaccination, right? And the thinking is that there is some, thankfully transient, changes in the sex hormone concentrations, right? They haven't been able to prove it. It's just a theory. You know, we really don't know what is causing this. What we do know and what we have observed, thankfully, is that it is transient, and most women will revert to their normal menstrual flow and menstrual cycle within 6 months of infection. Mental health, tying in strongly with what my colleague, Dr. Eaton, spoke about. So Liu et al. Found a prevalence of post-traumatic stress symptoms in 7% of persons, 285 residents in Wuhan, China, within weeks, just 1 month of the COVID-19 outbreak. And in a similar manner, Lian Wang found that 29% of approximately 15,000 respondents in the UK scored 4 or more on general psychiatric disorders measured on the 12-item general health questionnaire. And that about 1/3 of the respondents reported feelings of loneliness. Women and young people had higher risks by far of psychiatric disorders and loneliness. And being employed and living with a partner were found to be protective factors. Moreover, participants who have or had COVID were more likely to have psychiatric disorders. So the effects of the pandemic were triggering mental health complications, and the disease itself is known to trigger psychiatric issues. All right, in another study, it was found that COVID-19 positive patients had higher levels of depression, anxiety, post-traumatic stress symptoms as compared with normal controls. And of course, one can understand why. In another study, Lai et al. Again This time, a little closer to home, a cross-sectional study conducted in 1,200 Chinese healthcare workers. Remember now, the majority of whom would be women, right? And these participants were found to have a very high prevalence of mental health symptoms. In total, 50.4, so 50% of them were found to be depressed, 44% of them, or 45, were found to have anxiety, 34% insomnia, and all of these were found in about 3/4 of the participants, right? And 70% reported psychological distress. And I must say, I'm just now learning the difference between distress and eustress. So thank you for that as well, Dr. Eaton. The female gender and having an intermediate occupation were associated with experiencing more severe depression, anxiety, and distress. I mean, pregnancy is a taxing time in and of itself, in and outside of a pandemic, anywhere in the world you are. So imagine being pregnant during the pandemic, right? In one study, 2 cohorts of pregnant volunteer women were compared, and the first cohort was recruited before the pandemic, the second cohort online during the pandemic. And the study was focused on distress and psychiatric symptoms. Women from the COVID-19 cohort, as compared with women from the pre-COVID cohort, showed, not surprisingly, higher levels of depressive and anxiety symptoms. Moreover, in the COVID-19 cohort, women with previous psychiatric diagnoses or low income were also found to be at higher risk to report elevated distress and psychiatric symptoms. All right, we're winding down. A quick word on long COVID. Just to note that women who suffer from long COVID typically experience more symptoms than their male counterparts. So yet another way in which women were more adversely affected. Females were also significantly more likely to exhibit symptoms such as difficulty swallowing, fatigue, and chest pain on long-term follow-up compared to men. And of course, there's no way I could do a talk on women's health and not speak about domestic violence. So during lockdowns, to curb the spread of the virus, women were forced to spend more time at home. And let's face it, home is not a safe place for some of us. So this issue was compounded by the fact that the services put in place to support survivors of domestic violence have been, I mean, it continues, disrupted or made inaccessible. In some countries, it was found that calls to domestic violence hotlines increased by almost a half. But perhaps more concerningly, in some countries, the calls dropped dramatically. So that's more concerning because that points to yet another barrier. Perhaps those women had no way or no means to call, to communicate. You know, if we put it in a local context, maybe those women had no credit. Maybe they had no access to the credit during lockdown. Maybe they had no phone, right? So again, to give a local perspective, about a quarter of women who reported rarely experiencing domestic violence before the COVID-19 pandemic reported frequently experiencing it now during the pandemic, right? And similarly, approximately 80% of these women experienced domestic violence during and frequently after the pandemic. And so I would like to conclude by saying, in no uncertain terms, that the COVID-19 pandemic has definitely, unfortunately, disproportionately affected our women. And these disproportionate effects on women's health, safety, work, all point to a clear need for intersectional approaches to address the impacts of the pandemic on women, as well as future health, economic, and social crises. So what this point is really saying is, and I heard my esteemed and senior colleague, Prof. Figaro, say as he concluded his presentation, that yes, you know, all right, we faced a catastrophic pandemic, right? But life continued, and there obviously were no safety nets or safety contingency plans put in place for the point Prof was trying to make was for persons with cancers and chronic illnesses. In the same way, you know, it was just grossly revealed that these safety nets and these contingency plans were almost non-existent for women as well, which is why the pandemic has had such an adverse impact on our women. And I like to end my presentation with a picture of my favorite picture of my favorite people. And I'd like to thank you very much for your kind attention. These are my references. And I thank you very much. I'm going to stop sharing now.
Thank you so much, Michelle, for a clear, very coherent and appealing presentation. And it hit the nail on the head every time, especially as you highlighted that most healthcare workers are women. And yes, we have been greatly impacted, and we have a lot of catching up to do, and many of the gaps got wider, and we're just going to have to get in there. As usual, it's the women who are going to be in the trenches. Thank you for that. I expect we could take some questions now, since after our sponsor's presentation, we'll be going into our panel discussion. So, Sam, are there any questions for Dr. Campbell just now? We could just take that, maybe 2 or 3.
Sure, thank you, Doc. So there are actually 2. Dr. Mitchell, I had a family member who experienced first trimester pregnancy loss 3 weeks after COVID-19 vaccination. Have you heard of similar reports of miscarriage post-vaccination?
All right, thank you very much for that question. There actually has been no evidence linking spontaneous abortions or losses to COVID-19 vaccination. So, you know, unlikely to be related in any way at all. No evidence to support that.
Thank you so much. Are there any long-term studies being done or any plans for same to follow women who have had changes related to their menstrual cycles post being infected with COVID-19 or receiving the vaccination against COVID-19?
That's a wonderful question. And I am hoping to conduct some research on that, because for sure, we don't have, you know, if I'm to be frank, we don't have a clue. We really don't know. And so, yes, long-term follow-up and further research is definitely warranted.
Thank you so much. And I guess this third question kind of follows Dr. Kirby asked, do we have any data? Is there any age differentiated data for the effects on women healthcare as far as the healthcare workers who are women?
Age differentiated age. Okay. Not that I can specifically recall. Most of the studies just reported, you know, that the majority of healthcare workers were women, which we know. And as such, since it was us really on the front line, we were most adversely affected. Nobody really reported on age. Well, by extrapolation, one study said that female healthcare workers and those in an intermediate position, which I had indicated. So one could assume that persons in an intermediate position would be younger to middle age, but that's an extrapolation really, but makes perfect sense.
All right, perfect. So we have two questions left. First one is, can COVID-19 cause AB? I'm not sure what AB is.
That would be spontaneous abortions. And yes, there has been, you know, there are clear reports and clear evidence of adverse pregnancy outcomes as it relates to COVID-19 infection, of which spontaneous pregnancy loss is one such complication, among many others. So yes, the answer to that question is yes.
Okay. And then I guess the final question is, any worsening of gynecological cancers in COVID-19 patients?
Okay, that's a wonderful question, actually. And the simple answer to that is yes, yes, yes. I'm smiling not because it's funny, but I'm wondering if any of my oncology colleagues are on, because I mean, it's been a real struggle for them. You know, we've had reduced operating theater times, and you know, these are the patients who need their surgery. And so even though we have prioritized them, the operating time is still, you know, is still reduced. And of course, the diagnoses as well, because initially everybody was locked away and hunkered down, hiding from the virus, while other diseases were brewing. The other diseases didn't go anywhere, you know, as this webinar has been highlighting. All right, thank you so much for your questions.
Thank you, Dr. Michelle Campbell-Mitchell, for again a really enlightening presentation. Many of the participants have expressed just the same in the chat. And thank you for the answers to those questions, which have enlightened us even further. So we're going to go on to Arista Farmer's presentation.
Good day, everyone. I bring greetings on behalf of the entire Aristopharm team. Today, we would like to highlight a typical journey taken by an allergic rhinitis patient. We will therefore get you acquainted with our patient and then take you along the journey with them. And finally, we will seek to provide you with some reminders of a few key Aristopharma products. Now, the journey typically begins at first contact between our patients and the specified allergen. Now, let's meet our patient for today. Today we have Jason, who is a 15-year-old male, and he recently received his first pet dog. However, over the past week, Jason has been complaining about a runny nose with clear nasal discharge. And in addition, he has been suffering from irritated, itchy eyes and a sore throat. Now, the symptoms are so severe that they often affect his ability to get a full night's rest. For patients like Jason, they might have a tendency to take a quick detour from what we would consider the conventional path. At this point, they may seek out the agents that are most readily available to them over the counter, These agents tend to be our oral antihistamines. While oral antihistamines may work well for some patients, Jason unfortunately did not receive the relief he was looking for. However, he encountered the sedative effect because he was using one of the first generation antihistamines, and of course with prolonged use he may be at risk of dry mouth and dry eyes, and of course if he's using multiple agents together there might be a risk of drug-to-drug interactions. So for patients receiving inadequate levels of relief from our oral antihistamines, it is at this point you tend to find them returning to the conventional roadway to seek further treatment. We want to highlight the stepwise treatment approach for allergic rhinitis, where we initially start with environmental control and a non-sedating oral antihistamine, and as the severity of the symptoms progress, we start to look towards combination therapy. Now, since Jason requires additional treatment, we are recommending that you guide him onto the path towards our nasal sprays. So there are many doctors who are concerned about the use of nasal sprays simply because of a few of the drawbacks. Now, we know there might be some significant aftertaste, noticeable drainage, irritation of nasal mucosa, which leads to poor compliance. However, we want to highlight our option that will cater to your patients while eliminating some of these concerns. For a patient like Jason, we are recommending an agent that will give him the most complete relief in the fastest possible time. Now for this we are recommending our fluticasone furoate, which when compared to dexamethasone as baseline has been shown to be the most efficacious at binding to the glucocorticoid receptors. Additionally, fluticasone furoate was found to block a wider range of T helper cytokines when compared to mometasone furoate. Now, because of the low systemic bioavailability, patients taking fluticasone furoate would be less likely to encounter any systemic side effects when compared to other nasal sprays like those containing mometasone furoate. But before I introduce you to our brand of fluticasone furoate, I'd like to get you reacquainted with Arista Pharma. So, who is Arista Pharma? The year 2020 marks a very big milestone for Team Arista Pharma. This year, we are celebrating our 10th anniversary being present in the Jamaican market. This means we're celebrating 10 years of providing high quality pharmaceutical options at affordable prices, combined with unmatched customer service that has been driven from innovation led by our highly motivated group of associates. Arista Pharma is one of the top 10 leading manufacturers of pharmaceutical products in Bangladesh, and we started our journey as far back as 1986. We believe quality is a journey and not just a goal, and therefore we're constantly seeking the best raw materials to ensure that each patient who takes an Arista Pharma product is getting a product that delivers quality in every drop, every puff, or every spray. Our commitment to your patients is this. We ensure that we adhere to the high safety practices that ensure that our products are of the highest quality, and we always seek to ensure that the average person can afford an Arista Pharma product. So we are constantly working on these three gears to ensure that once your patients receive an Arista Pharma product, they are getting a product that will best suit their needs. Now, with that said, let's introduce everyone to Flutica. Flutica is Arista Pharma's brand of fluticasone furoate with 120 sprays of 27.5 micrograms of fluticasone furoate. Now, when your patients use Flutica, you can be guaranteed that your patients are receiving a product with a very gentle mist that has no aftertaste because there is limited drainage. In addition, Flutica will relieve ocular symptoms that are related to allergic rhinitis. And additionally, because of the low systemic bioavailability, as mentioned before, they will have a lower incidence of systemic side effects. Now back to Jason. Our recommendation for Jason is 2 sprays of Flutica in each nostril once daily for up to 14 days. And we are guaranteeing that in no time we'll have Jason back to his bright and bubbly self. With that said, we have now arrived at our destination, which simply put is recovery. So we want your patients to recover as quickly as possible and also without breaking the bank. At Arista Pharma, we acknowledge that there may be patients with comorbidities. Therefore, we have introduced our Arista Pharma line of inhalers. Firstly, our Solflow, which is our salbutamol rescue inhaler, and our Aeroflow in the 250 and 125 microgram strength. Now, all our inhalers are covered by the NHF, and with the NHF card, cost less than $500 to the patients, making them the most affordable inhalers on the market. Additionally, we would like to remind everyone of our Olpidine and Stafen, or Olpidine, which is our olapatadine 0.1%, and our Stafen, which is 0.025% of ketotifen. Both drops are widely available and are used twice daily for patients who are suffering from allergic conjunctivitis. We would also like to use the opportunity to remind everyone that Aristabet N is still on the market, and it can be used for eye, ear, and nasal infections. It is widely available in pharmacies island-wide. Now finally, Team Arista Pharma would like to extend our deepest and most sincere gratitude to each and every one of you for the overwhelming support that we have received for the last 10 years. We look forward to partnering with you for many years to come. Thank you and enjoy the rest of the conference.
Thank you so much, Arista Pharma. And yes, we are on the final leg of the conference and continuing on the theme, let's walk together to combat chronic disease in COVID era. Family physicians now will get together as panelists to discuss the topic, how are you coping or handling chronic diseases in your office in the COVID-19 era? And as somebody said, the COVID-19 pandemic met the non-communicable diseases pandemic, and we had a perfect storm. So to help us with this, we have stellar family physicians to join us. These family doctors are always there to care. So they will be directing us. Each will speak for 5 minutes, no more. Please be very concise on this topic. So we'll have family physician, Dr. Dane Levy, who's a past president of the Caribbean College of Family Physicians Jamaican chapter, and I believe also past Rotarian. We have Dr. Donald Gordon, president of the Association of General Practitioners of Jamaica. Dr. Aldis Buckland, also past president of AGPJ and CCFP and smoking cessation advocate. Dr. Jose Humphreys, public health specialist, internal medicine and epidemiology and infection control consultant. Special welcome to you, Jose. And of course, our own and very special leader, conceptualizer, and family physician par excellence, Dr. Anna Brown Morgan. And so we are going to have them stab at this topic, which is such a relevant one. Please go ahead, doctors.
Good afternoon, one and all. I am Dr. Dane Levy. My name is called first, but I don't know if I should go first. I don't know if I should allow.
Yes, Dane, go right ahead. And let's just flow as the order in the itinerary.
Well, as the first one up, I think the conference has been wonderful so far, and it's given us a background, a foreground, a oversight of all the things that have happened to us over the past 2 years. It has given some insight as to how we coped and how we are coping. It has given some insight to the challenges. But from a personal point of view, let me just quickly say that I remember when the story broke out of a viral outbreak in Wuhan province in the Chinese mainland late in 2019. And everything was quickly shrouded in mystery and intrigue. What we saw seemed to be so distant. Chinese citizens in mass, citizen provinces under lockdown. It all seemed unreal, as if we were watching some sci-fi movie. Then the spread began. Europe and then USA became affected, and we prayed it would never reach our shores. But reach it did. And the devastation that seemed so distant finally arrived in March 2020. Let us not forget it only took one unfortunate infected individual to start the spread in our little island. Over the past 2 years, many of our citizens and colleagues have died. Many became seriously ill. Many will suffer the prolonged effects of infection from the SARS-CoV-2 virus. Healthcare in this country will never be the same. Our resources became stretched to breaking point. Staff and physical facilities became overburdened. Myself and many of you, my colleagues, have suffered serious trauma from seeing the suffering and death that pervaded the landscape like a thick fog. Many of us still suffer the effects of the loss and death. We on the front line cannot divorce or separate ourselves from the pain the people we have served for so many years suffered. We don't see our patients, our clients as numbers. We see them as real people, almost like family. Their pain is our pain. Their successes are our successes. Their frustrations with the system are our frustrations. Their challenges were and are our challenges. We did not see them from a distance. We saw them close up. And we did not treat from a distance. We found ways to help and ease their pain and suffering and saved lives. We soaked up new information, sharpened our clinical skills in the field, learned from each other and from our colleagues abroad, and gradually the tide began to turn. We remain vigilant, watchful, hopeful, and prayerful. We continue to educate and treat our patients with the best knowledge we can garner. The vaccines arrived, and we have been a part of the vaccination. We who have been a part of the vaccination programs in partnership with the public health system were belatedly allowed to offer the vaccine, from our offices. Now we have a mountain to climb, a mountain of misinformation, mistrust that has led us to a chronic vaccine hesitancy. Now the deleterious effects of the pandemic on the management of NCDs in our country is being uncovered and unmasked. It is our resolve to work together to combat these chronic diseases in what is now the COVID era. I take this opportunity to encourage you, my colleagues, to walk with us on this journey. I encourage any members of the wider public, our clients or patients, to walk with us, your family doctors, always there to care. A tremendous amount of change has affected how we treat our patients. How do we cope and how are we coping? Several of these factors have been outlined in some of the presentations that have gone before, but let me just say, we educated ourselves, our staff, our patients, and our communities at large. We supported and obeyed the protocols. We made the necessary adjustments to our offices and medical centers. We were and are vigilant and learned to recognize the nuances in the symptomatology of the virus. We supported and continue to support the vaccination campaign by volunteering our facilities and our time. I must at this point in time congratulate my staff at Edgewater Medical Center, and particularly my wife, Florence, because she was in charge of setting up our various sanitization procedures, making sure that our staff remain safe, making sure that sanitizers were in place. We had adequate supplies of sanitizing material, protective equipment, protective gear, and that everybody obeyed the protocols. What are the challenges that we face? Handling chronic disease in the COVID era, that's a challenge. And the biggest challenge so far that we found in this COVID era was fear. Our patients were afraid of coming out. Our patients were afraid of going to the hospitals. And some of us were afraid of seeing our patients. But we couldn't shirk our duties, could we? We geared up, we prepared ourselves, and we kept our offices open. I think one of the best things that happened is that we learned that we did not have to work for those extensive long hours because we couldn't afford burnout. Because the more burnt out we got, the more likely we were to become infected by this virus. There was anxiety, there was depression on the part of our patients and some of our staff, and that brought on a certain level of apathy, which was alluded to in some of our presentations. In our hospitals, we found that there were unacceptable levels of management, and we had to be very vigilant to shore up, to be the go-between, to be the bulwark, to be the front line, to remain in the front line of the management of treatment of these chronic diseases. Of course, as I said, alluded to it in many of the presentations today. We had to overcome shortages of equipment, shortages of medicine, and shortages of personnel. We employ strategies such as distance medicine, telemedicine. We have to regain the trust of our patients. We continue to do home visits for those who could not come out.
Doc, I think we lost your audio, but just a reminder though, we only 5 minutes for each presenter and we're a bit over 5 minutes so far.
All right.
Okay, I think I will just make one more point and then turn over to the next panelist. As I said, we made ourselves available. We kept our offices open. We answered telephone calls, we offered advice, and we made sure our patients got the best care possible in this COVID-19 era. I now turn over to our next panelist.
Thank you very much. Dane, Dr. Levy.
Should be Dr. Gordon now. Go ahead, Dr. Gordon.
Thank you very much, Dr. Williams Green.
Not hearing you.
You're very low, Doc. Not sure why. Do you have a headset plugged in somewhere?
Hello, are you hearing me?
Yeah,
better?
hearing you now. Yeah.
All right, thank you very much, Dr. Williams Green. Thank you very much, Dr. Levy, for that wonderful and fluent opening. And thanks to your audience for staying in tune up to this point. This evening topic, how are you coping or handling chronic diseases in COVID-19 era? A lot of the information that you hear has been dealt with already, so I will not delve on too much of it. Question, what has happened to chronic diseases in the COVID-19 era? We have seen an unprecedented rise in the incidence of—
All right, Doc. So persons are saying that the audio is still low. It is. Yeah, we're hearing it better, but it's still low. Yeah, that's it. You're gonna have to project like that. Go ahead.
Okay. Persons are saying that there is an unprecedented rise in the presence of chronic diseases, and some of it is caused by complication of COVID-19. But most of it is caused by reduction in compliance by patients with the treatment of chronic diseases. And also we see a rise in the incidence of anxiety and depression disorders. What are some of the factors contributing to the reduced compliance? We see stigma associated with COVID-19 infections, in that a number of patients who are afraid to travel travel on public transportation, public health restrictions, which mandated that patients stay home, restriction of movements, fear among patients to leave home. I've had patients who have not left home 2 years on in the pandemic, and they were definitely afraid to leave home. There has been a confusing narrative surrounding COVID-19, NCDs, and compliance of prescribed medications. A lot of patients were asking if they should continue to take their medications, and we had to continue to educate patients along this line. We also noticed that there was a resort of patients to use a lot of alternative medications. Some of the alternative medication, the common ones are ginger, turmeric, and other bushes. We also saw that the role that finance and lack of financial resources played in the reduction of compliance. A number of patients were unable to purchase medication. Some patients were unable to purchase food, and they didn't want to take their medications without eating. Now, as a practice, what did we do to maintain compliance and access? Because we realized that compliance and access were one of the things that were driving a lot of the increase in the prevalence of the NCDs. A number of things that we did, it's alluded to by other speakers. We make sure we kept our office open throughout the pandemic with the necessary public health measures. I did not stop one day from work. I continued to go work along with my staff. We carried out education and counseling. Patients were educated to dispel certain of the myths surrounding COVID-19 and the NCDs. We noticed that they were warned about the increase of mortality in patients who have multiple comorbidities and why it was important to continue their medications.
All right, persons are in the chat saying they're not hearing.
They're still not hearing?
Well, the thing is, I can answer that, so it means I'm hearing. However, it's not clear. You have a headset plugged in. Can you plug it out and let me hear if I hear you? No, you don't?
No, I've unplugged the headset. They're still
Okay,
not hearing.
guys, let me know in the chat. Are you hearing better now? Is this better for you? Give them a sound check, Doc. I'm here.
Hello?
Sure, Doc. Let's just finish up and move on to the next and see if we can work on your audio
Let's
off here.
finish up. Just finish. Let's
Hello.
go on.
Yes. Okay. With education and counseling, we had to educate our patients to dispel a lot of the myths surrounding the taking of their chronic medications and the NCDs. We educated them on the increase of mortality in patients with comorbidities. We encourage the taking of vaccinations, and we had honest discussions surrounding the benefits of vaccination as well as the dangers there might be. We use telemedicine extensively. We used to maintain care with contacts with our patients. Whenever we saw their relatives in office, we always inquire of them, and we would normally call and discuss their medical condition with them and find out if they need any additional prescriptions. We also maintain access to patients who were in nursing homes. We encourage patients to sign up to NHT so that they could continue to afford their medication, and persons who were complaining that they were not eating and so they were not taking their medication, we encourage them to sign up to PATH. Now, we encourage our patients to maintain a very, very positive attitude. We advise patients, to do their own research, not to be misled by other persons. We advise them to stick to information from trusted sources only, and we emphasize the benefits of education, exercise, and proper dieting. in summary, the strategies that we employed to handle the increase in comorbidities and COVID-19 NCDs in COVID-19 pandemic. One, we educate. Patients are educated on the truth and facts surrounding COVID-19. We emphasize, we listen, and we responded honestly to patients' concern and discuss them honestly. We encourage and extol the benefits of compliance, because we find that compliance was a big driver in terms of reducing the incidence, and also maintenance of access to continuous care. Those were some of the things that we found that were very instrumental in caring for patients who had NCDs in this era of COVID-19. Thank you very much.
Please continue.
Okay, we're done.
Next speaker, Dr. Aldis Buckland. Let's roll it. Dr. Buckland?
I'm coming. I'm just sharing this video.
Have no more than 5 minutes.
Sam, can you just share the video that the pop-up that I sent, please? Thanks. And put it on. All right, thank you. Good afternoon, everyone. How are you handling or coping with the chronic disease in the COVID-19 era? This is a big question. Next slide, please. It is very important for me to plug into my microphone. Take a deep breath, stay in the moment, and I focus. I focus on the task that is right in my eyesight in that moment. I respect my world. I know I'm part of the universe and the universe is part of me. I respect the person who's sitting in front of me. I respect the society. I know that people don't think like me, and I may not think like them. And that is just a fact. However, the whole thing is a One Health approach. And One Health is actually a concept and an approach in which it involves human health, animal health, and environmental health. It is really a collaboration of many entities working together so that we can have good human health, optimal animal health, and optimal environmental health. And COVID is an example of how a One Health can be used. So we use prevention, intervention, and recovery or rehabilitation. So what sort of person would have this disease? Would have the COVID, or would even have a chronic disease? We need to think, and we need to go back a little, Sam, and we need to look at the person in their environment, in their family, in their work, who they're mixing up with, who they're talking with is so important. Do they have facilities for water, for sanitation? What is happening? Do they have animals around? Do they have pets around? Do they go walking? Do they involve in other situations that would put them at risk? Do they travel often? Do they contact and love to hug up others? Have they been in contact with a confirmed case? So we know that the vaccinated, those people who wear masks properly, those who sanitize their hands, those who do the physical distancing of the recommended 6 feet, those who live in ventilated environments, and those who have clean environments, we know that they do well. Next slide, please. And so we're going to take our pills. I take my pills. P, I'm going to remain positive and inspired and empowered. And how I do this, I just stand up straight, or I sit up straight, and I take a deep breath and I say, Lord, guide me and let me be a channel of your blessing. When I go by my door to my office, I pretend that this is like Star Wars, and it is, I just say, beam me up, Scotty. And then I go and see the patient. And then when I finish what I'm doing with my patient, I go back to the same door because I just need to recover my energy. So I'm using energy, but I need to recover. And my door is done through the falls. It's done through the falls. And I just imagine, and I feel the falls coming straight on me. And I take a deep breath and I feel revitalized. And I'm ready for the next person. And I show my patients how to do this as well, so that they can be positive and they can be empowered. They need to know how to transport themselves through space and time to a special place where they really feel relaxed and safe. It's important also to have information from credible sources. And I would send them to the Jamaica Jam COVID website. I need to love myself and I need to love others. And it's very important because I can't love another person if I don't know how to love myself. There are lifestyle changes we all need to make, both for chronic diseases as well as for the COVID. But because the context has changed, it is COVID, and how are things going to be different? Things would be different if we do what will keep us safe. And it's also important to support, to give support and to receive support. So I can give support to others and people can give support to me. My patients have been so good at supporting me and I've been good at supporting them. I get support from Pauline. I remember after I got my second vaccine, I had a problem. My patients knew I had a problem because I was put on sick leave. But they saw their doctor getting better. And I said, I may have a problem and you may have an issue with the vaccine, but we need to work through it. And they saw me get better, which is very important. Next slide, please. Now, one of the things that we learned in the webinars from the Ministry of Health, who had collaborated with the Caribbean College of Family Physicians and the Association of General Practitioners, was the WHO approach for the cardiovascular risk assessment. And I'm just putting up this so to remind us all that although we are in the COVID era, we are to still focus on letting the patient understand how to keep safe during COVID, and also how to be happy and safe, how to get safer, how to get to their targets. And this on the left is the cardiovascular lab-based chart. So if you have, you'd know if you'd have the sugar level of the patient, you know, so from that, you know, if the patient is
Doc, your audio chipped out. Can you check for me? But I think we're running out of time as well, right, Dr. Williams-Green?
I know, and she's running. Aldis, you're muted.
Can you hear me?
Yes, and our time is limited, so please wind up.
Okay. So we went through this chart, and so this is important to keep our patient focused so that they know where they're going to. Next slide, please. So we want to resist the writing reflex, let the patient talk, so that they're in charge of what their action plan is, but we're guiding them. They clarify their goals and we can highlight their change talk. We've got to talk, we have to speak the patient's language, and how you can do that is actually to reflect or repeat what the patient is saying. So what sort of person has the disease? And we want to listen with our ears, our eyes, undivided attention, and our heart. Next slide, please. And so this is very important to have a good mind, good exercise, good sleep, good nutrition, and no smoking. Is the activity or decision we are going to make safe for me, safe for you, safe for the environment? We got to get to target. Physicians, we got to get the patient, help the patient get to target, guide them, and the patient needs to get to target. We need to also avoid HALT, which is hunger, anger, loneliness, and tiredness. Because if we have hunger, anger, loneliness, and tiredness, we will not be at our best self as a physician. And our patients will actually be triggered to go back to their old way. And any overwhelm that we feel, we want to show the patients how to do the breathing exercises, behaving techniques with just a gentle stroking of the arms, just gentle, like you're hushing a child, and then meditation and sleep. Sleep is actually a good meditation. And then intervention for COVID. Next slide, please. So the change plans that we go through with the patients, the changes I want to make are, and the reasons why I want to make these changes are, the patients answering these, and the steps I plan to take in changing are, and I will know my plan is working if, so this is the evidence, And some things that could interfere with my plans are, and what will I do if the plan isn't working? And as my doctor, you can help me keep these changes by doing whatever. Next slide, please. And this, I think, is the last slide. We got to set limits. Manage your time, automate, delegate, eliminate. Make a list and prioritize. Learn to say no. Boy, I just love to say no. Leave work at work, reduce email access. Take advantage of your options. Try to shorten commitments and minimize interruptions. Very important, work-life balance. Next slide, please. And I think that's it. So
Thank
that is hope.
Thank you so much. And I know there are many families around the doctors and the other healthcare practitioners who are saying, when are you coming back to us? So we really want to wind up quickly. So 5 minutes, Dr. Jose Humphreys and Dr. Anna Brown-Morgan. Do not exceed your time. We need to give our participants back to their families so they can indeed regain their sense of peace. Dr. Jose Humphreys, please.
Good afternoon, everyone. Are you hearing me?
Hearing you perfectly.
Excellent. I'm so happy to be here. Now, for me, COVID-19 pandemic has resulted in severe disruptions to routine health services delivery, particularly due to strict lockdowns, which were implemented across the globe. Access to healthcare as a result of these lockdowns and even the curfews, along with health workforce redeployment, narrowed focus on COVID-19, coupled with mistrust and apprehension by patients due to vaccine mandates, fear of the new viral contagion, and growing conspiracies became real issues for primary care physicians in providing a continuum of care for non-communicable diseases for their patients. Many physicians had to adapt innovative practice dynamics to cope with patient care, specifically in the COVID-19 era. I relied heavily on digital health tools. Digital health tools help to facilitate patients' appointments and becomes a critical tool to encourage follow-ups and serve as an important platform that can be used to support the continuation of care. Because of social distancing and other disease prevention measures, procedures used to obtain medication through the public health system changed drastically in my country, from the same-day retrieval of medication to a prescription drop-off and medication pickup process that could take up to a full week to occur. Patients either became non-compliant through frustration or ran out of medication because of poor adaptation to this new standard, which ultimately led to an increase in the burden of disease, mortality, and perhaps even morbidity. Many restrictive measures during the COVID-19 era can significantly impact persons living with NCDs by limiting their activities. These restrictions caused disruptions in the access to health services. I personally find that telemedicine plays a critical role in providing support to persons with NCDs and other chronic conditions in such settings, while giving the physicians the opportunity to maintain that crucial doctor-patient engagement. I've also found that ongoing health awareness and education programs can lead to positive behavioral change and increase medication compliance. It also offers patients that added layer of support that was or is critical to dispelling myths and gaining or regaining the trust of our patients during a critical time of uncertainty. A few tips that I used were to build rapport with my colleagues and create that support mechanism among each other, to create a clear line of communication with my patients, employ time management skills, setting boundaries, because I must first take care of me in order to be able to take care of my patients, and share or disseminate credible information. So in conclusion, for me, there is an urgent need for future guidelines to address the issues concerning the adaptation of telemedicine approaches within health systems to maintain that continuum of care, coupled with regular engagement by frontline healthcare workers at the local level and evidence-informed public health messaging, taking into consideration the social and behavioral aspects that need to be addressed to maintain uninterrupted essential primary care services. Thank you so much for allowing me to share.
Thank you, Dr. Humphreys. Dr. Anna Brown Morgan, you have the last word.
Right. Good afternoon, everyone. And I just want to talk very, very quickly about my experience with the chronic diseases and my patients from the beginning of COVID and even now. So go ahead with the next slide, please. I experienced drastic changes in what happened. It was sudden, and there was a drastic change to try to fix your practice to accommodate COVID-19 care. Because of the lockdowns, there was definitely a reduction in chronic care activities. There were less consultations with the chronic patients, and we attempted a transition to digital telemedicine support of them. But I mean, I would not say that this was particularly successful, not in the truest sense of telemedicine. I, at that time, did not have a systematic way of identifying and contacting high-risk patients with the chronic diseases to garner them for follow-up. I didn't have them tagged. At first, I did not expect a serious, the COVID infection to last quite as long as it did. I think everyone thought it would be a little bit more temporary than it was. And so we were forced to make changes as we moved along. So next slide, next slide. There has definitely been a disruption in the delivery of chronic care at my medical center, which I think persists even now. Next slide. A possible remedy. I think in the short term, actions should be directed with all of us in primary care to identifying our high-risk patients, especially those with the chronic diseases. And we should develop plans within our practice to organize how we will care for these patients with chronic illnesses using telemedicine for support, especially our vulnerable patients during any future waves of this pandemic, or there may be other methods. But we should develop a practice plan which directs us and organizes how we care for our patients with chronic illnesses using digital telemedicine for our support as best we can. And we need to definitely identify our vulnerable patients so that we can be of greater assistance to them in the future. Next slide. My patients with chronic diseases were not only affected by the COVID-19 pandemic directly, but also indirectly, as my efforts to secure my place, my business place during the pandemic, and to minimize morbidity and mortality associated with the COVID infection, took over the priority of what was happening, became prioritized. And this affected the continuity and care of all my patients in general, and especially those with chronic diseases who tended to be older and were in a longer lockdown by the government. Next slide. My resources shifted away from the prevention and management of chronic diseases, which perhaps was the core of my medical practice prior to this. I had reduced access though to hospitals for my patients with non-COVID-19 infections, which was also heart-rending. Some of my chronic patients still have postponed coming to see me, even now, due to fear of of exposure to coronavirus. And one wonders when this will end. Next slide. This has led to serious concerns about the indirect health legacy of COVID-19 in relation to chronic diseases. There have been increased complications and progression of the diseases due to seriously delayed access to secondary care facilities at hospitals, closed clinics, or reduced access for chronic care patients because of the other emergency plans for coping with COVID patients and the locking down of their clinics. I also was concerned about the disruption to their care and their follow-up in my clinic. It is a struggle to organize chronic care, especially when there are peaks of the outbreak, which last, because they're not coming. And also, you want them to come, but you don't want them to. You're getting a higher level of the COVID itself coming to your practice. And these older people, often with the chronic diseases, are at risk. And so they don't want to come. And you have to be very careful about how you schedule visits for them. Next slide, please. There is so much fear. My patients are afraid to come. Even though some of them I have not still seen, I'm still getting requests for prescriptions. My initial response for safeguarding and reorganizing the medical center was with a focus on the safety of my staff, myself, and identifying and caring for the COVID-19 suspects who were coming and trying to keep them away or in a different environment from people who were non-COVID. I tried to do that through telephone consultations for both sets of patients, and also a designated area for looking after COVID patients or suspected COVID patients, because I was trying to keep the COVID patients by phone outside of the practice directly. Next slide. Have we done outcomes?
No, next slide, I think.
Outcomes, right. Telemedicine provided us with some ability to monitor and support our patients with chronic diseases from a distance, but its main use was to prescribe medications after obtaining a quick impression of the patient. And this is often not sufficient. So a conclusion here, next slide. General reorganization of primary care practices are necessary to adequately care for patients with chronic diseases in times of the pandemic. And we just need to note, it is very difficult to adjust quickly to changing circumstances which have been occurring with the COVID. Risk stratification within our own patient population is essential in order to reach the most vulnerable chronic patients and to keep them healthy. We doctors need to know our patient load. We need to know who we have on our files. And we need to be able to access them and know that they are the at-risk patients. It is possible to use telemedicine for some intelligent patients who are able to perform tasks such as checking their own blood pressure, doing their blood sugar readings, and even showing us pictures of their progressing healing ulcers. Certain things can be done for these chronic patients by telemedicine. And this did help with the continued care in patients who were reluctant to visit their family doctor. Even now, I get pictures. Family doctors, family doctors need to better identify the chronic patients in their patient population, and they need to proactively plan the steps to be taken in order to track them down. We need to change how we do business in our practices. One way that could help us in the future could be by improving the training of GPs in private practice management. This is something I don't know if the university has scheduled, but this practice management to include sessions on crisis management in pandemics. And this actual specific thing needs to be put in place. The family doctors, the COVID pandemic has affected the continuity of care. It has drastically changed the landscape, and it has cast a light on pre-existing weak spots in chronic care organization. So I had no proactive plan at the time on how to reach out to patients with chronic diseases. And I did feel somewhat abandoned by the hospitals and tertiary care generally. I lost patients that I know to cancer and to heart disease because of lack of this access and because of not visiting often enough to catch the disorder early. And that is a burden I carry personally. That is another outcome of the whole pandemic effect of the chronic diseases. When you cannot serve your own patients as you wish, and the burden you feel to make a difference, to do something about it. Anyway, hope is present. I am learning from this ongoing experience. I know that I have to stratify my patients according to their needs, and I know that I need to plan ahead in anticipation of any flare-up of the COVID. And I thank you very much.
Thank you so much. You had a lot to say, Dr. Brown Morgan, and it was excellent. We are expected to have another COVID, SARS, probably 3 or 4 in the next 10 years. So what you have shared, what all the presenters have shared, Dr. Dane Levy, Dr. Donald Gordon, Dr. Aldis Buckland, Dr. Jose Humphreys, and Dr. Anna Brown Morgan was extremely useful. And we need to take note because, yes, over the next 10 years, we'll be back here. And as well, still dealing with Omicron and all the other letters of the Greek alphabet. And now, Sam, do we go on to so I say thank you for the panelists. Thank you so much. Can we go on to the next sponsor's presentation, please?
With over 20 years in providing quality service, Apex Radiology is Jamaica's premier diagnostic facility. Our services include CT scans, nuclear medicine, ultrasounds, x-rays, and more. We have 3 easily accessible locations in the Kingston area and 1 in Ocherez. With our mission to provide exceptional and affordable healthcare, Apex Radiology is a clear choice for your diagnostic needs.
Short and sweet. I now hand over to Dr. Andre Purai, Vice President of the Caribbean College of Family Physicians Jamaican Chapter. and you're in good hands. Thank you again, organizers, for inviting me to moderate.
Apologies, Dr. Pura is actually over on the attendee side, trying to promote her or allow her to speak. 1 second. Dr. Pura, are you there? Dr. Pura? All right, so we seem to be having some technical difficulties with Dr. Pura. If I could be so,
Hi, Sam.
are you there? Hi,
Yes,
perfect.
I'm here.
Okay, go ahead.
Can you hear me clearly?
Yes.
Okay. Can I have a sharing thing?
We're hearing you loud and clear,
We need to
Andrew.
promote you to panelists because you want to share something. So
Okay, if you,
you see
but if you
that,
have
see something pops up and said promote to panelists, allow, can you just allow it? Say come over, please. There you go. Here you are. So you can go ahead, share your screen, video, everything. There you are. Need you to unmute. 1 second. Unmute.
Okay.
There you go. All right.
All right. Good afternoon, all. Thank you all for staying. All the 478 persons that stay up to this time. So good afternoon, all. It has been an honor to have been asked to offer a vote of thanks on this special occasion, which is the World Family Doctor Day 2022. Let me first begin by giving glory to the Almighty God for making today's occasion a resounding success. I, on behalf of the World Family Doctor Day Committee, extend a hearty thank you to all speakers for taking the time off to share their knowledge with us today. First and foremost, a big thank you to Dr. Marco-san for giving us an excellent informative and relevant coverage on heart disease related to COVID-19, and informing us that palpitation is common in long COVID. Further, we are grateful to Professor Peter Figaro for sharing his knowledge on infections causing cancer, reminding us the importance of prevention, such as vaccination with hepatitis B and HPV, and screening pregnant women for HTLV1. We'd also like to express our sincere thanks to Professor Michael Boyne for a clear and detailed presentation on managing diabetes and COVID-19 infection, also informing us that diabetes patients need 3 doses of COVID-19 vaccine to be fully vaccinated instead of 2. And we'd also like to acknowledge our gratitude to Dr. Paula Dawson for an informative and practical presentation on ergonomics in the 21st century, telling us posture is important for our satisfaction and the importance of stretch break. In addition, we're grateful to Dr. Jordan Eaton Sr. for his excellent performance on his presentation on the significance of psychological stress on chronic disease outcomes during the pandemic, informing us about the difference between de-stress and eustress. We would like to express our sincere thanks to Dr. Tosan Livingston for giving excellent coverage on autism spectrum disorder as a chronic disease from birth to death, informing us that multidisciplinary evaluation may be most beneficial for a thorough assessment and diagnosis, can be made by family doctors just like myself, starting by age 18 months. I would also like to acknowledge our gratitude to Dr. Michelle Campbell-Mitchell for exposing us to the effect of COVID-19 on women's health, enlightening us that COVID-19 pandemic has disproportionately affected women. Lastly, we must mention our deepest sense of appreciation for all our family physicians, our panelists, Dr. Dane Levy, Dr. Humphrey, Dr. Donald Gordon, Dr. Aldit Buckland, Dr. Arna Morgan, Dr. Arna Brown Morgan, for exposing their experience in handling chronic disease in their own office in the COVID-19 era. We are all inspired by their great words. We are grateful and thankful for the sponsors, which are National Health Fund, Recharge Distributor Limited, RDL, Abbott Nutritionals, Indus Life Science, Heart Foundation of Jamaica, Medimpex Jamaica Limited, Health 2000 Canada Inc., Myers, Fletcher and Gordon Assess Management, Astra Pharma Limited, Apex Radiology, also Health Haven Pharmacy, Family Medicine Program, Department of the Community Health and Psychiatry, UWI, MONA, Winchester Surgical and Medical Institute, Winchester MRI Limited, GSK Pharmaceutical Industry Company, VPC Medical Center, Merrimack Medical Center, Edgewater Medical Center, Carimed Group Limited, CCFP and AGP. Thanks also to Mistress Christian from Carimed Group for donating 6 beautiful baskets for our presentation. Thank you, sponsors, for making the World Family Doctor Day Conference 2022 a remarkable success. I take this opportunity to thank the technical personnel, Mr. Harold Sam, for rendering his time and expertise to making this conference a success. I would like to thank Dr. Kay and Dr. for gracing this day and bringing God blessing upon each of us and making this day a memorable day. Dr. Christian Smith from the Family Medicine Postgraduate Program and Dr. Donald Gordon from the Association of General Practitioners of Jamaica for doing greetings for this event, and Dr. Seni Onaju for doing welcoming and organization of this event. The moderators, Dr. Sophie Aberkan, Dr. Arna Brown Morgan, Professor Marvin Reed, Dr. Pauline Williams Green, you were all absolutely outstanding. You did an excellent job, and again, I cannot tell you how much you contributed to the success of World Family Doctor Day 2022, and how much we appreciate your willingness to do this. A conference like this cannot become successful with a single person. Therefore, I extend a big thank you to all persons of World Family Doctor Day Committee who are motivated and dedicated colleagues with a willingness to take and completion of tasks beyond their comfort zone. These are Dr. Brown Morgan, Dr. Anna Brown Morgan, Dr. Aileen Standard Golson, Dr. Seni Onaju, Dr. Arlene Henry Dawkins, Dr. Dane Levy, Dr. Aldit Buckland, and our Secretary, Honorable Ms. Lynn Thompson Hyatt. It has been a momentous day. Finally, we thank you, my audience and friends from Jamaica, the Caribbean, Pakistan, and UK for your attendance and contribution and cooperation in making World Family Doctor Day Conference 2022 a resounding success. I also thank you all for celebrating the 8th World Family Doctor Day Conference with us today. It has been a great pleasure. We'd like to thank you again for being with us and making this event a success. It has been a significant pleasure. Thank you very much. Today, we're asking you to support our Always There to Care project. Just a small voluntary contribution will have a profound impact on one's life. If you wish to contribute to the Always There to Care project, payment option is on the flyer that was sent to you for this program. It is supporters like you that help us change the world every day. Please look out for the World Family Doctor Day 2022 Gleaner Supplement on May the 19th, 2022 in Jamaica Gleaner, and Happy Family Doctor Day on May 19, 2022. Thank you very much again. Stay safe and healthy. Have a great Sunday. Over to you, Sam, or Dr. Williams Green.